The normal calorie intake is 2 days of restricted calorie intake and 4 days.
Sorry to interrupt, doctor. Only 2 more minutes left.
Yeah, I have stopped. Thank you.
Okay. Any questions from the audience? Thank you, Dr. Sumesh, for the excellent presentation. I think even though there were some technical problems, you could manage very well. And I have one question. If a diabetic, obese young patient comes to you and asks whether I can go for a intermittent fasting so that I can reduce the weight drastically and bring my blood sugars under control, what will be your advice?
There is definitely an improvement in the obesity parameters, but in an young patient, mostly obese young patients will be type 2 diabetes. So the chance of hypoglycemia will be definitely less, but it should be done in a controlled manner with frequent monitoring of blood sugar, preferably but from the physician point of view. You should not leave it to the patient alone.
Thank you, doctor.
Thank you.
Yes. Any other doubts? Dr. Deepa, do you have any doubts in the chat box?
I think
Nothing. Okay.
no,
Since
nothing.
I think Meenakshi Bajaj is there, I think we will have one small clarification from her. Can you hear Meenakshi Bajaj?
Yes, sir, I can hear.
Fine. Yeah, just can you briefly describe regarding the fruit controversy in pregnancy?
Sorry, sir, what controversy?
Fruit controversy in pregnancy. Certain dietitians, fruits. Certain gynecologists and certain dietitians are advising that pregnant person should not take certain fruits like pineapple and all. Do you have any scientific basis regarding that?
When it comes to raw papaya, there is the enzyme papain, which there is no evidence for it, but traditionally people say not to take it. Otherwise, we do not suggest raw papaya even otherwise. If you're going to consume ripe papaya, it's perfectly to go because of the vitamin A, and it's not very high in GI or GL. So portion control can be consumed. But raw papaya, definitely there is some information to say because of the papain in it. And when it comes to pineapple also, it is raw. Because digestibility issues are there and you may land up with vomiting and diarrhea, things like that. Not otherwise. There is no evidence to tell us.
Thank you, Meenakshi Bajaj. Any more questions? Otherwise, I think we can wind up the session. Is it okay, Dr. Deepa?
Thank you all the speakers for an excellent presentation. Thank you, Dr. Sadu, for the opportunity. Over to the organizers.
Thank you all the speakers for the wonderful presentation. Thank you, Dr. Deepa, for co-chairing. So over to the organizers, please.
Thank you, speakers.
It's not audible. Please check your mic. It is not audible.
Hello, are you hear me?
Yeah.
Okay.
Hello, is it audible, sir?
Yes. Yeah.
One second. Hello. Hello. Is it okay?
Now it is okay.
Okay. Moving on to our next section. It is hot topics in diabetes. For chairing the session, let me have Dr. Manish Agarwal, founder and director, Medilink Hospitals and Research Center, Ahmedabad, and Dr. Benny PV, Professor of Community Medicine, Sri Gokulam Medical College, Trivandrum. Over to you, Chair.
Manish sir, you are not audible. Please unmute your mic.
Good morning, friends.
Yes. Manish sir, please proceed.
Good morning, friends.
Yeah.
Myself, are you hearing me?
Yeah,
Yes, sir.
perfect. Yeah, please.
Myself, Dr. Manish Agarwal, and diabetologist from Ahmedabad, and I'm running my own 50-bedded of the diabetic hospital named as the Medellin Diabetic Hospital. And this particular session, we are going to discuss hot topic in diabetes. Our first speaker is Dr. Anju Matthew. He's from the Trivandrum, and he's going to talk newer diabetic medications with the cancer food. Already we are in a very poor correlation with the diabetic and cancer, and some of the medication can cause of the cancer. So he's going to talk what about the newer anti-diabetic medications with the cancer phobia. And now I'm going to introduce the Dr. Anju Matthew. He is a consultant oncologist at a medical center hospital and a Trivandrum. He is a certified of the American Board Medical Oncologist and Hematologist. He is a faculty at the National Cancer Institute. He received a lot of awards from the American Society of the Clinical Oncologist and American Society of the Cancer Research Work, and adjust award the faculty of the Kasturba Medical College in Manipur, and have the many publications in the various journals. So over to the Dr. Anju Matthew. He is going to talk newer anti-diabetic medications with the cancer phobia. Dr. Anju Matthew, please.
Thank you. I'm trying to share my content, my slides. Share content. Have somebody locked the screen? I cannot share my content. Okay,
Yeah,
now okay. Got it.
Can you please play right now? Please play
yes.
right now. Yeah. Perfect.
Okay, you can see it. Can you?
Manish sir, please unmute your mic. Please mute your mic. Manish sir, please mute your mic.
I think we can do from here, sir. Can you unmute Dr. Manish? Mute.
Mute.
Okay.
Yeah, Dr. Aju, you can start, please.
Okay. So thank you for the invitation. I'm going to talk about diabetes medications and cancer phobia. I'll speak in 3 sessions. The first one is about the link between diabetes and cancer. The second part will be about the diabetes medicines and cancer. What is the link? And for the third part, I will give you a brief overview on epidemiology and how it relates to this question of diabetes medicines and cancer phobia. So, in terms of diabetes and cancer, we know that diabetes is strongly associated with cancer, but the key word here is associated. But is association equals causation? That is, if you have diabetes, can you say that because of the diabetes you're going to get a cancer? Or just because you have diabetes, it is possible that you also have the same phenotype that can cause cancer? The key problem here is the same risk factors that causes diabetes also causes cancer. So this question, it is to figure out The only way we can figure this out is using Mendelian randomization studies, where the genes of a patient, of an individual, is tested, and using that, the cohort study is conducted. Using a very comprehensive cohort of UK Biobank, using this design called Mendelian randomization study, investigators have sort of figured out that type 2 diabetes can actually raise your risk for cancer, for several types of cancer. Pancreatic cancer is one example, colon cancer is an example, uterine cancer, kidney cancer, and so there are about 16 types of cancers that can you can raise the risk for being the cancer just because you have diabetes. So the association between diabetes and cancer is not just a simple association, but there could be a causation also. But this is very difficult to unravel. Reason, there is a biological reason for this link. That is because hyperinsulinemia, insulin resistance, hyperglycemia, chronic inflammation that one can see with diabetes is also seen with cancer. Now, the second part, how about newer anti-diabetes medicines and cancer? You would see a lot of newspaper reports showing that this drug causes cancer, that causes cancer. So there is a lot of concern and fear in the mind of patients with diabetes. Is the drug that I'm taking, liraglutide is one example, pioglitazone is another example, does that cause cancer? Most of the data that we have comes from observational studies, which is retrospective cohorts, case control series, database studies. Even in randomized control trial, it is very difficult to do time dependent analysis. So, whatever we see in the news reports, whatever you read in journals, understand that methodology or lack of a sound methodology is the crux of this question. So, if you say that so and so medication raises the risk for cancer or is associated or causes cancer, keep in mind that the may be a problem. Methodology may be a problem. So think about all the problems that a methodology can cause. Now I'll get to the last part of my talk, which is epidemiology 101. What are the three methodological issues that we have to always think about when you hear about so and so medicine causes cancer? The first thing is correlation. The second thing is residual confounding. The third point is reverse causality. Correlation is not equals causation. If you look at this graph, during the months of May to September, there are a lot of shark attacks. And during the months of May to September is when the most number of ice cream sales happen. So, can you say that ice cream causes shark attacks? No, it is only because during the summer months in Western countries, that is June, July, August, September, that people go to the beach, they swim, that they eat ice cream. And because of that, when they swim, there is risk for shark attacks. So, one thing you should always remember is just because a patient has diabetes and for that they are taking a medicine doesn't mean that their cancer happened because of that. Correlation is not equals causation. The second point I want you to understand is something called confounding, or rather, residual confounding. Confounding is when the same factors, the same risk factor mediates the two exposures of interest. For instance, in this case, if you look at age, smoking, and Down syndrome, one can say that smoking causes Down syndrome. But is this really true? If you do an analysis and you don't adjust for anything, then one can say that if you smoke during pregnancy, your risk for getting Down syndrome decreases. But if you adjust for age, maternal age, that relationship goes away. So maternal age becomes a key confounder in the relationship between smoking and Down syndrome. Likewise, there are so many factors that we don't understand that interplays the link between two exposures. That is called residual confounding. So, for example, for a patient with diabetes and that patient is on pioglitazone, and that patient also happens to have bladder cancer, the patient with diabetes have probably a poor general physical condition. They smoke, The patient with bladder cancer, they smoke. So it is not the pioglitazone that causes bladder cancer, but it is rather the smoking, the tobacco that causes both the phenotype that results in diabetes and that also causes the bladder cancer. Similarly, there may be several other factors we don't know anything about. That is called residual confounding. In all cohort studies, there is always a risk for residual confounding. And that is why we always look into randomized controlled trials to figure out the question of causality. I talk about is reverse causality. We know that diabetes causes heart attacks. Does heart attacks cause diabetes? No. But in terms of exposure to certain medicines, just because you are on that medicine doesn't mean that you have diabetes. I'll give you an example. If a patient is diagnosed with pancreatic cancer, they have pancreatic insufficiency. They may get new diabetes. And because of that, they may be placed on insulin. So, did the insulin cause the diabetes? Or, I'm sorry, does the insulin cause the cancer, pancreatic cancer? No. Just because they have the disease, they are on insulin. So, that's called reverse causality. So, whenever you see retrospective studies, cohort studies, and trying to answer the question of whether X and Y drug causes so and so disease, think that there may be the problem for reverse causality. So these are the three big questions, three big methodological issues that underplay all the questions that you hear about in terms of diabetes medicines causing cancer. One, correlation. Two, residual confounding. Three, reverse causality. So always methodology is at risk. So whenever you hear about all these associations, think that lack of sound methodology may create a complex analytical problem here. More recent and better designed studies have essentially weakened the link between anti-diabetes medicines and cancer risk. So if there are patients who are listening to me, know that uh, all the things that you read in the newspaper may not be right. If there are doctors who are concerned that X and Y drug causes cancer, we don't know. The chances are the study that you read is probably hindered by methodological issues. So you can take two approaches to anything that you see online. One, you can say it doesn't matter. Much ado about nothing. I don't care about it. It's just fake news. Or you could talk about trade-offs. Okay, let's say pioglitazone causes bladder cancer. But what are the risks? Marginal, tiny. But the patient sitting in front of you with very poorly controlled diabetes, if pioglitazone is a cheap, inexpensive medicine that can help get their diabetes better, and by getting their diabetes control better, you can prevent a heart attack, that is called trade off. So you can take one of these two approaches. One, you could say all of this is just fake news. Two, you could say that there is a trade off involved in all of our decisions. Keep in mind the methodological issues in that also. Thank you. I hope I have answered the question that there really doesn't need to be a phobia about taking diabetes medicines in terms of relationship with cancer. Trade-offs matter. So make sure your diabetes is better controlled. That is the most important factor. Thank you.
Thank you, Anju, for the nice and lucid talk. Thank you.
Next, I am Dr. Benny, a professor and HOD of Community Medicine, Sri Gokulam Medical College, and director of Ashrabad Mission Hospital, and editor of Kerala Medical Journal, IMA Kerala State Branch, and practicing diabetology for the last 20 years in my hospital. Next topic for the discussion is OSA and diabetes, clinical significance. We all know obstructive sleep apnea is now a public health problem because of the increasing trend of obesity globally. So even in the lockdown situation, the trend of obesity is go on increasing. There is a much more chance of obstructive sleep apnea. This topic is discussed by the Dr. Mohan T. Shenoy. He is a colleague of me in Sri Gokulam Medical College, and he is a consultant endocrinologist in Sri Gokulam Medical College, Venyarmud, and GG Hospital, Murinyapalam, and SK Hospital, Idapazhi. And he has done his MD from the Kempagoda Institute of Medical Science, Bangalore, a DM endocrinology from the Amrita Institute of Medical Science, awarded with the FRCP by Royal College of Physicians, and he is the promotion coordinator of EasyCon 2017 and a life member of many associations. I invite Mohan T. Shenoy for discussing this hot topic, OSA and diabetes. Over to you. You are not audible. Please unmute your mic. Yeah, yes. Please proceed.
Can I share the screen? I think the screen cannot be shared now. Can you? I'm trying with that sharing. Yeah, now it is possible. Doctor, for giving me the opportunity, and to my slides, I will really thank Dr. Devani sir for introducing me to this session. So,
Manish sir, please unmute your mic. Mute your mic. Mute, please mute.
Is it visible now?
Yes, visible. Yes, visible.
Okay. So let me just.
Yes, visible.
So, yeah. Let me go into my talk. So this topic is regarding OSA and diabetes, and what is the clinical significance of this correlation. This discussion over the next 12 minutes would be on the context of my talk, why I am talking about this in this endocrine topic, and I will discuss a case regarding this. It is recently seen in my practice. I will highlight the clinical clues towards the relation of OS and diabetes, the conventional and comorbidity associated with these factors, and contemporary knowledge, and finally some learning pearls for all of you to listen. So, first of all, the biology of sleep is absolutely fascinating because sleep is required for the recovery of our health because it is critical for our physical, mental, and emotional well-being. As you know, the defects in sleep quality and quantity can result in metabolic errors, and also there are reports of cardiovascular dysfunction being described. All diseases, just like diabetes, are chronic. So they have some emotional attachment, and they can also adversely affect the sleep by causing depression. It is a 36-year-old male, an IT professional who was recently in the OPD. He had come because of his weight gain, and he also reports anxiety, daytime snoring, and night sweats. You can see clearly that there is a pre-diabetic history previously, and he's working from home, maybe because of the lockdown period, but otherwise also they used to work, but now confined to home for the last 4 months. So multiple stressors are going on, and you can see that the labs are all deranged because metabolic markers, HbA1c is crossed the border, that is 8% now. Fasting glucose is 148, postprandial of 238. You can also see other markers are just in the borderline zone. So he's having subclinical hypothyroidism, but the range of TSH in our lab is 4.2 for TSH. You can see that he's also mild fatty liver, SGPT R cutoff is 42. So he's an adult with having fatty liver, also having non-alcoholic hepatic liver disease. You can also see that the lipids are also deranged. So sleep is basically a highly ignored aspect. In ancient times, we used to respect and honor the sleep. Nowadays, we are accustomed to doing the night as well as taking the calls on the phone. And now with the telemedicine, there is no restriction of any appointments as well. So in clinical practice, we often do not record sleep history in detail. Modern lifestyle disorders definitely have a correlation with the sleep apnea syndromes. So parallel to this, we are also seeing parallel to the pandemic of COVID, we are also seeing a continuous pandemic of type 2 diabetes as well. So significance of the sleep problems, this is a highlight because immunity also derived by restoration of the proper sleep pattern. We can see the total duration of time, the quality of time is also important. Many studies on diabetics have shown that there are various spectrum of presentation of sleep issues, either in delaying initiation of sleep or maintaining the sleep, or even daytime sleepiness also is more. So the point is that there is a close relation between the sleep, circadian rhythm, obesity, insulin resistance, and all the cardiovascular risk factors. So what are the clinical clues towards the diagnosis of sleep apnea? So the patient can report directly as sleep issues, or even the spouse, roommate, or bed partner can be forthcoming when there is no proper history in the patient. Also, the history of loud snoring, weight gain, impaired memory, all these gasping sounds and all, they are part of this disease process. So what a conventional knowledge has taught us in a textbook is that sleep problems are definitely required to be monitored, and we can see that there are many risk factors being described for this. Eating is one of the main risk factors. Obesity is of course an association. Other risk factors are also having craniofacial abnormalities, family history of sleep disorder or obstructive sleep apnea, menopause, tobacco. Epidemiology is one of the major things which we have to consider when you have a patient coming with history of sleep apnea. There is also a cause because the recurrent episodes of partial or complete collapse of the airway can result in all these oxygen desaturation happening. So net effect is basically poor work performance. So what about the sleep duration and risk of diabetes? So this is a trial done and published which has shown that sleep disordered breathing can complicate diabetes as well as cause diabetes. And we can see underlying depression is also important in these factors. Polysomnography done in diabetic patient revealed a lot of issues in fragmentation of sleep as well. This is the textbook description as well as the journal description. 3 years back, this publication has come in the Diabetes Care Journal. I would urge you to pay attention to this U-shaped dose relationship because the sleep duration and risk of diabetes, because the average requirement of sleep is 7 to 8 hours. So compared to that, whenever you have a lesser duration or even a more duration, we can see there is definitely an increased risk of diabetes in those who are prone for it. So sleep as a metabolic regulator, and you have sleep depth is also important. So when you have a 3 hours of sleep or 8 hours of sleep, there is a depth of 5 hours. So definitely the sleep deprivation makes the patient fatigued, unable to concentrate, and finally daytime sleepiness and tendency to overeat and eat fast. Moreover, to keep them awake, patients resort to using addictive agents like tobacco and smoking, which itself can increase the risk of type 2 diabetes. A study which has published shows that insulin resistance can also be due to sleep deprivation. Sleep disordered breathing, which is a spectrum of snoring, upper airway resistance syndrome, and sleep apnea. So sleep apnea can be obstructive, central, or even mixed, but you can see that obstructive sleep apnea is the independent risk factor for developing hypertension, ischemic heart disease, diabetes, and slow. And even the habitual snoring can predict the onset of diabetes. This is a JAPI journal published in 2012, making sure that this is a very important concept, never to be ignored in our practice. So I'll come to the last few sections, OSA and type 2 diabetes. Chronically reduced sleep time, we can see that pathway of sleep apnea cycle, repetitive pharyngeal collapse, and cyclical hypertension, release of stress hormones. We can also see that patients witness choking episodes, somniloquy, sleeping during talking during the sleep, acidic reflux also happening, and finally sleep rhythm also getting changed. In diabetic patient, there is also a postprandial drowsiness, and finally leading to confusing picture and misleading with other diseases. So mechanism beautifully summarized in the Diabetes Research Journal again, showing that sleep fragmentation, intermittent hypoxia, all liberate many risk factors like sympathetic activation of factors, and you can see the hypothalamic pituitary axis also deranged by increased cortisol drive, reactive oxygen species. This is just to show you that we have many things which are not definitely missed in our practice, and insulin resistance is one thing finally leading to type 2 diabetes. So what is obstructive sleep apnea and the comorbidities? A study by the name SAVE study was published in NEJM. Why I'm telling this study is this is one of the studies which has done a post analysis, because this is comparing the diabetic and non-diabetic patient. Until OSA in diabetic patient can even increase the complication rate And treatment of OSA might definitely help to reverse the severe consequence of diabetes, but definitely the glycemic control definitely needs medicines appropriate for diabetes. But adherence to CPAP treatment, at least for 4 hours of CPAP, definitely help this patient in this study. So other endocrine associates are also described. One of them is hypothyroidism. Hypothyroidism can associated with OSA. Daytime tiredness and sleepiness can also be the pattern of hypothyroidism. And the point is that this patient had subclinical hypothyroidism. Unless we definitely manage properly, if administer thyroxine without treating OSA, they can itself precipitate the cardiovascular events because REM sleep can risk factors there. Another point is hypogonadism treatment with testosterone therapy, also a risk factor for worsening of OSA. So definitely OSA history should be taken before starting testosterone therapy in hypogonadic males. So another factor is shift work and diabetes. We are all agreeing that shift work is important for our industry, but the human factor affected. The risk of spectrum is there. Circadian rhythm liberating melatonin, excessive nocturnal cortisol and catecholamine drive is bad for the equilibrium. The data from sleep health study showed that sleep less than 6 hours or more than 9 hours definitely has high risk of developing type 2 diabetes compared to 7 to 8 hours of ideal sleep. Sleep restriction coupled with eating separately contributes to development obesity. Obesity is another pandemic, and coming together coupled they are called diabesity. So it is all due to the risk of increased cortisol, adipose cytokines, finally leading to these factor of full-blown diabetes. This I will urge you to pay attention because OSA and diabetes, I just made this table from a textbook I had copied and I made this diagram. You can see that anatomical factors leading to sleep disorder breathing are very important. Modern lifestyle, I have mentioned the stress, sleep deprivation, also highlighting the role of diet, obesity. The next consequence are insulin resistance and apneic activity leading to liberation of all these cortisol and catecholamines and stress factors. So finally, we remember that genetic factors are also important in progression of this risk. Screening. What can we do to control this and how to address this problem? There are several screening tools available. One of them is the Epworth Sleepiness Scale. This is beyond the topic, but you can just see another questionnaire also is there, Berlin questionnaire, also highlighting that sleep apnea is a very important for ENT side also. Classification for anesthetics to pick up is called Malampati score for the intraoral checklist. Easy tool is the overnight oximetry because clinical practice we can demonstrate that recurrent episodes of desaturation can definitely document the risk. Updates, because updates are important because we are all sitting in the webinar and listening. So updates, we can see that stop bank score is one of the major updates in obesity management. We can see the code here, snoring, tiredness, observed breathing stopping, the blood pressure, and bank stands for BMI, age, and I'll urge you to go through it in detail later on. Another factor is Dr. Kalra and team have come up with a secure model for diabetes and obesity. Concept of barochronology has been developed, and I really agree that GLP-1 agonists have definitely helped in both diabetes and obesity. The cornerstone of treatment gold standard is CPAP therapy. Patients wear a mask or nasal mask during sleep and they connect to the pump and provides positive airflow to nasal passages. And next effect is the airways kept patent and open. This is the content connect. We can see the summary of the secure model, the severity of obesity, etiology, C for comorbidity, urgent lifestyle changes, role of medicines, and finally the target should be that of personalized control. OSA is definitely the strongest association with all the metabolic risk factors and is an independent risk for progression of diabetes. And how this happens? Because insulin resistance occurs and we are seeing the 24-hour model of signaling definitely showing the cortisol surges more. This is proven from the sleep disorders journal published recently because high level of fasting plasma insulin and glucose levels. This is also shown in PCOD patients because PCOD patients have got insulin resistance and sleep deprivation can definitely lead them to have diabetes in future. So my concluding remark would be that sleep hygiene is a concept for primary care physicians. This beautiful journal published about 2 years back, and we can see that there are suggestions from this journal as well as suggestions for bedroom as well as for daily activities. The summary of this would be to ideally reduce your stress, maintain a healthy sleep schedule, and use your medicines appropriately with doctor's advice. and avoid using sleeping pills and definitely exercise on regular basis. So the main points which I have learned by making these slides, and I want to also remember, is that detection of treatment of sleep disorders in diabetes is essential because the treatment is highly rewarding. Early recognition of signs of warning by history and screening tools, as I told you, are very easy to diagnose. And data on CPAP on diabetic complications are scarce, but definitely systematically screening for OSA in type 2 diabetes and diabetes patients should be done because it is protective for diabetic complications. And adherence of other lifestyle measures and weight loss measures are definitely a concomitant factors. So both short duration and long duration of sleep is risk for type 2 diabetes. So sleep quantity and quality are important to delay or prevent type 2 diabetes. So I bring you regards from the I work from a beautiful senior from our rural medical college. Dr. Benny and me are fortunate, and I'm very glad to Dr. Sabir for giving me this opportunity. I will be glad for any topics of questions. Thank you for the listening.
Thank you, Dr. Mohanty Shonai. Actually, you have very well, excellently narrated why sleep hygiene is very important in diabetes control. Is there any question? If there is no question, we can pass on to next topic, I think.
Thank you, sir. Thank you, sir.
Thank you. Thank you. I'm going to invite next speaker is Dr. Arun B. Nair, and he's going to talk is how to take psychosexual history in erectile dysfunction in diabetes. We are seeing a lot of the erectile dysfunction in diabetes, but patient is not going to uh, giving any proper history. Patient is coming with a couple, husband and wife, and in fact, they are not going to. They are always saying, he is having the weakness. I think we should take of the proper psychosexual history, erectile function, in particular diabetes, and he's going to Dr. Arun B. Nair. He is an associate professor, Department of Psychiatry, Medical College, Trivandrum. He is a regular faculty of the many regional and national forum, and he is author of 15 books related to the psychiatry. He is a guest faculty at the CDC Trivandrum, and he is the tune of the civil service interview programs, more than one of the millions by the Amrita TV. He has conducted over the more than 1,000 episodes health and social awareness program in various TV channels. Over to Dr. Arun B. Now he is going to talk psychosexual, how to take care of the history regarding the sexual dysfunction in the diet. Dr. Arun B. Nair, please.
Thank you, sir, for those introductory words. My sincere gratitude to Sabir and TDR for giving me this great opportunity. Since we are running really short of time, I would like to rush through my presentation and finish it within 10 minutes flat. So, coming to the psychosexual history in erectile dysfunction in diabetes, it has been rightly put under the heading of hot topics in diabetes because sexuality is definitely a hot topic. Can we have the slide share? So as we all know, erectile dysfunction is something which is the result of a combination of both organic and psychogenic factors. And this Massachusetts male aging study, it's a landmark study which was conducted in people between 40 to 70 years of age. And it showed that 52% of males have some degree of erectile dysfunction. 17% of them have got minimal erectile dysfunction, 25 have moderate, and 10% have severe or complete erectile dysfunction, incapacitating them from engaging in any kind of sexual activity at all. So most of the studies worldwide have shown that 34 to 36% of people with diabetes have got mild to moderate erectile dysfunction, while 28 to 32% of them have got severe erectile dysfunction. Why erectile dysfunction is a problem in diabetic patients? Erectile dysfunction increases with the age of the person, it increases with the chronicity of diabetes, and it is also very correlated with the poor diabetic control. And diabetic persons suffer from erectile dysfunction at a very young age, an extremely young age. And they are more liable to suffer from more severe erectile dysfunction. The disease-specific quality of life would also be worse in diabetes, and ED in diabetes is less responsive to treatment compared to ED in other healthy people. So can we move to the next slide? Next one. Next. Next. Yes. So why erectile dysfunction in diabetes is important? It is not just a quality of life issue. It is a very clear-cut medical issue as well, because WHO has very clearly stated that erectile dysfunction could be a prodrome or a trailer to a coronary artery disease event. People who suffer from erectile dysfunction in diabetes are more likely to get a myocardial infarction or a coronary event in the near future. So ED may be the first symptom of diabetes also in up to 20% of people. So people find that there is erectile dysfunction and on subsequent investigation identify that they are diabetic. So ED could also signify dyslipidemia, which was hitherto undetected. It may also be a sign of hypogonadism, and sometimes it could be the sign of an occult cardiac disease, which was not manifest otherwise. Next slide, please. Erectile dysfunction in diabetes is also very important from a psychological point of view. Can we have the next slide, please? Because erectile dysfunction in diabetes is very closely associated with depressive symptoms. A person with depression and diabetes is more likely to suffer from erectile dysfunction. The diabetes distress will be more in those people with diabetes and erectile dysfunction. People with erectile dysfunction understandably would be suffering from low self-esteem, their quality of life would be low, and they will have negative effects on interpersonal relationships, including their family relationships. And it's also seen that people with diabetes and ED often hit the bottle. They tend to become dependent on alcohol in order to overcome their sexual dysfunction. Next slide, please. So to take a proper history about the psychosexual functioning of a diabetes person, we have got an internationally standardized tool also that is known as the International Index of Erectile Function. There are 15 questions in this, and we can utilize this itself in our history taking. So here, sexual activity, the definition of sexual activity is anything which includes intercourse, caressing, foreplay, and even masturbation. Sexual intercourse is defined as sexual penetration of your partner. Sexual stimulation includes situations like foreplay and showing erotic pictures. Ejaculation is defined as the ejection of semen from the penis or the feeling of that. And orgasm is the fulfillment or climax following sexual stimulation or intercourse. So the first question is, you have to ask the patient regarding how often you were able to get an erection during the sexual activity. You can grade it also. 0, if the score is 0, it means no sexual activity, while 5 means almost always you'll be getting an erection. And question number 2 is, when you had an erection with sexual stimulation, how often were it hard enough to sufficient for a penetration? Here again, 0 means it was never hard enough for a penetration. 5 means almost always hard enough for a penetration. Third would be, when you attempted intercourse, how often were you able to penetrate your partner? Again, 0, if it was not at all possible. 5 were always possible. The fourth question would be, during sexual intercourse, how often were you able to maintain your erection after you had penetrated your partner? This is another very important problem. So 0, if did not attempt intercourse at all. 5 means almost always, even after penetration, the erection was sustained. Fifth question, during sexual intercourse, how difficult was it to maintain your erection to complete the intercourse? 0, again, if no intercourse was possible at all. 5 means extremely possible. Next slide, please. Sixth question would be, how many times you attempted sexual intercourse? So 0 if there are no attempts. This questionnaire is actually in relation to the sexual life in the past 4 weeks. You're asking about the sexual life in the past 4 weeks. If no attempt for sexual intercourse in the past 4 weeks, it should be 0. And if 11 or more attempts, it should be 5. 7 to 10 attempts is 4. 5 to 6 attempts is 3. 3 to 4 attempts is 2. And 1 to 2 attempts is 1. The seventh question, when you attempted sexual intercourse, how often was it satisfactory to you? 0 if no attempt was made. 5 it was absolutely satisfactory throughout. Eighth question, how much have you enjoyed your sexual intercourse? 0 if no intercourse was possible, 5 it was highly enjoyable. Ninth one, when you had sexual intercourse or stimulation, how often did you ejaculate? Again, 0 if no intercourse was possible, 5 if always following intercourse you had ejaculated. 10th is when you had sexual stimulation or intercourse, how often had a feeling of orgasm or climax? 0 again if never. Sorry, 1 if it was never, and 5 it was almost always. Next slide, please. 11th question is how often did you feel sexual desire? 1 if never, 5 if always. 12th is how do you rate your level of sexual desire? If you rate it as very low, it is 1, very high, it is 5. How satisfied have you been with your overall sexual life? 1 if very dissatisfied, 5 if extremely satisfied, with different gradients. 14, how satisfied have you been with your sexual relationship with your partner, with your regular partner? Again, 1 if you are very dissatisfied, 5 if very satisfied. Now, how do you rate your confidence that you could get and keep an erection? 1 if it is very low, 5 if it is extremely high. Next slide, please. So again, when we come to how to evaluate this, so this questionnaire evaluates not only erectile function, but the other domains also. So questions 1, 2, 3, 4, 5, and 15 are specifically evaluating the erectile function. And how do we assess or how do we analyze if it is a problem? So the maximum score out of for this erectile function domain is 30. The average score which patients have is 10.7. If the total score in the erectile function domain is 14 or less than 14, a trial of a phosphodiesterase inhibitor like sildenafil is indicated, provided there are no other medical contraindications. Orgasm is assessed by questions 9 to 10, sexual desire by questions 11 to 12, intercourse satisfaction 6, 7, 8, and overall satisfaction 13 to 14 with different scores. I'm skipping that for want of time. Next slide, please. So some other aspects of history is also important. Can we go to the next slide, please? So medications, what all medications did the person take? That's a very important thing because antihypertensives like beta blockers, methyl dopa, all these, and sometimes verapamil can also produce erectile dysfunction. Diuretics like thiazides and spironolactone can sometimes produce. And of course, cardiac circulatory drugs also like clofeprate can produce erectile dysfunction. Tranquilizers like phenothiazines and butyrophenones can also produce erectile dysfunction. Anticholinergics, very often they produce erectile dysfunction. Some antidepressants like tricyclic antidepressants, monoamine oxidase inhibitors can produce erectile dysfunction. Certain hormones, some H2 antagonists like cimetidine, and even cytotoxic agents can also produce erectile dysfunction. So a complete history of medication intake is very important to help us to avoid anything which produces sexual dysfunction. Substance use, alcohol, smoking, or any other substance use can increase the desire initially, but impairs the performance slowly. Chronic physical illnesses, mental illnesses, including anxiety disorders and depression, can lead to psychogenic erectile dysfunction. Marital discord is another very common reason for psychogenic erectile dysfunction. After having a fight with your partner, you cannot expect to get an erection and sustain it throughout the intercourse. Sexual orientation problems is another very important matter which is coming up in new generation marriages. People with same-sex orientation getting married with the hope of correcting their orientation post-marriage, developing erectile dysfunction understandably, and then run into trouble. Again, sexual growth and development. If there were any problems in the sexual growth and development, that also should be understood and appropriate hormonal evaluation and treatment should be. So thank you very much for your very patient listening. I hope I have stuck to my time.
I think Manish sir is not there. Uh, Thank you, Arun, for an excellent presentation. Actually, most of them want to hear the management of those type of erectile dysfunction, but you have wonderfully narrated the cause and causality of erectile dysfunction. But most of the young doctors and middle-aged doctors also want to hear the correction of, especially the psychogenic erectile dysfunction. Can you tell some hints of some
was
correction.
in fact psychosexual history. That's why I skipped the management part since I was supposed to complete it in 12 minutes. I shall definitely say how to distinguish a psychogenic erectile dysfunction from an organic one is that if you have got early morning erection, it is an important sign that it could be psychogenic. And if you are getting erection towards certain pictorial stimuli or even towards certain people, but not getting an erection towards your partner, that is also another factor which points towards probable psychogenic erectile dysfunction. So management, the psychological management of erectile dysfunction starts with something known as dual sex. So dual sex therapy is a coupled therapy in which both partners have to be jointly present. So erectile dysfunction is not considered as a personal problem of the man. It is considered as the common problem of the family unit as such. And we have got something called sensate focused therapy in which stimulation of the non-genital erogenous zones of the body are done step by step, followed by stimulation of the breast and then genital area, then female on top position with vaginal containment in which the female has the control over the movement, and finally the man on top position. So that's an 8-step process. Very gradually it has to be done, ideally over a period of 4 to 8 weeks, and that produces excellent results. If there is premature ejaculation, we can treat it with some psychological techniques like start-stop technique or squeeze technique. And if still it is not improving with that, we can go to the medical management part. This is what is inhibitors. There are no other contraindications. And sometimes we may even have to add some medications to improve that desire. For example, bupropion is one antidepressant which improves sexual desire by enhancing the dopamine in prefrontal cortex and improving the motivation and desire to have sex. So that's it in a nutshell.
Thank you. Over to Manish sir.
Thank you for the nice and lucid talk how to analyze of the psycho counseling and the erectile dysfunctions.
Thank you, sir. Next topic is exercise prescription in diabetes. Actually, this topic is dealt with. Dr. Roy R. Chandran is a young dynamic leader of IMA, and he is one of the apt person to discuss this topic because he is very active both physically and mentally. So, Dr. Roy R. Chandran is working as Associate Professor in the Department of Physical Medicine and Rehabilitation, Government Medical College, Kozhikode, and he has done his MBBS and MD from Government Medical College, Thiruvananthapuram, received IMA National Award in 2018 for Best Local Branch President of IMA, IMA Kerala State Presidential Special Appreciation Award during the year 2014, 15, 16, 17, and 18, 19, and years to come. I think he will be one of the continuous award-winning champion of IMA because of his exceptionally high attitude towards the profession. And he is a regular speaker in many national and regional forum, and he has published many papers in international and national journals. Welcome to you, Dr. Roy R. Chandran.
Hello, am I audible?
I invite you to speak on this topic.
Am I audible, sir?
Audible.
So, good afternoon, respected chairs, Manish sir and Benny sir. And thank you, my dearest friend Shabir and team for giving me this fantastic opportunity. And see, my topic is actually a relatively grossly neglected part in the management of diabetes not only by the patients but also by the treating doctors. See, an advice on lifestyle modification is like a super duper Hindi movie. It contains sentiments like this: gravity has lowered my chest, my stomach, and my butt. Why hasn't it lowered my cholesterol? And arguments like this: dinosaurs didn't smoke cigarettes, drink alcohol, or eat junk food. And where are they now? Advices like this: an excellent way to lose weight is by skipping snacks and desserts, and usually, like any Hindi movie, There will be happy endings like this. I was on strict diet for a month and lost what? 30 days. And see, the question is, are we giving advice on lifestyle modification? Probably many say yes or no. And are we giving the correct advice? Again, a doubtful thing. And are the patients doing it correctly? See, ads usually confuse, like this ad. Like, see, Fair and Lovely. And the ads on obesity and diabetes management will definitely confuse you. Like this oils, some bells, and some slim centers like the slim center get cured of hypertension and diabetes, 3 kg loss for 30k, 5 kg loss for 50k, and some give new year offers like 1.5 kg loss free. And these things, these centers and these ads will add to the confusion of the obese and diabetic persons. Then that is visible in our statistics. Like we have got a dubious distinction of the diabetic capital of the world. And the government says we are on a war against militants, and they say that our forces are ready to deliver anytime. And seems they are not bluffing. And definitely we should start a war against lifestyle diseases because we have a dubious distinction of diabetic capital of the world. We should fight against these lifestyle diseases. Coming to the guidelines, ADA guidelines 2020 for exercises for diabetes. This is a guidelines, you know this, I'll rush to the slides. Children and adolescents with type 1 and type 2 should engage in 60 minutes per day of moderate or vigorous activity. Most adults with type 1 and type 2 diabetes should engage in 150 minutes or more of moderate intensity per week over at least 3 days with no more than 48 hours without activity. Short door exercise is enough for young and active. Adults with type 1 and type 2 diabetes should engage in 2 to sessions per week of resistance exercise on non-consecutive days, not daily, non-consecutive days. Flexibility training and balance training are recommended 2 to 3 times per week for older adults with diabetes. And yoga and tai chi may be included to increase the flexibility and balance. Prolonged sitting should be interrupted every 30 minutes. You know that sitting as near diabetes, that is for blood glucose level, particularly in type 2 diabetes, because the reason is that the metabolism increases about twofold when you stand up from a sitting position, and from sitting to walking fourfold increase. Coming to an exercise, what is the difference between physical activity and exercise? There's a confusion. See, physical activity is generally term that includes all muscular movements that increase energy use, and exercise is more specific form of physical activity that is structured and designed to improve physical fitness. Coming back to the American Diabetic Association guideline, there is confusion ahead. And see, what is this aerobic? What is this moderate intensity? What is this resistance exercise? And definitely we should decode the science behind by going back to the basics. The exercise physiology, we have got 3 major energy systems in our body. The ATP-PC system, that is our emergency. ATP and phosphocreatine is stored inside the muscles that can be used for 5 to 20 seconds. And we have got another anaerobic system, the anaerobic glycolytic system and the aerobic system. This is the ATP-PC system. In anaerobic glycolytic system, glycogen is the fuel source. It does not need oxygen, and lactic acid is produced as a byproduct. And see, the aerobic system is the most important system where glucose and fat are fuel sources and are utilized to their availability and the intensity of the exercise. See, here the thing is that this is used for slow, sustained activities like sitting, cooking, taking classes, taking rounds, etc., etc. So this is the most important slide in my presentation. See, the efficiency of each system differs. The glycogen will give you, when burned anaerobically, will give you 4 ATPs. 1 will be used and 3 is the result. Glucose burnt aerobically will give you 38 ATPs. 6 will be used and result is 32. And free fatty acids will give you huge amount of ATP, 140 to 150 ATPs according to the chain size. So this is the most important thing. Trying to remember this. And by this basics, we'll get started. We have to advise 3 sorts of exercise in diabetes. Fourth is an optional thing, the balance training, the flexibility exercise, endurance or aerobic exercise, and the resistance exercise. Flexibility, you can see that even animal starts the day with exercise, but we won't usually. Flexibility exercise are not an integral part of exercise program, but in diabetic persons, many of the diabetic arthropathies like desicapsulitis, OA, backache, trigger, Dupuytren's contracture, etc., can be reduced or prevented by doing flexibility exercises. Coming to the most important thing, the aerobic exercise, you know that these are all aerobic exercises: walking, running, swimming, and games, Zumba, dance, etc., etc. Another important thing is that all these exercises can be done aerobically or anaerobically. We'll come to it. So these are called aerobics, but if you don't do it in a scientific manner, you will reach anaerobic level. This is a definition of aerobic exercise: using your large muscle groups of your body rhythmically for a period of 15 to 20 minutes or so, and maintaining their heart rate between 50 to 70% of maximum. This is a physiological adaptation. The back to physiology: in muscles, there will be angiogenesis, more vessels, more myoglobin, increase the number of mitochondria, increase respiratory capacity per mitochondria, and ultimately the muscles will be able to extract more oxygen from the given blood. And in heart, you know that heart is in a good position when load is more than and the afterload is less. Here, the preload is more because of the peripheral. There will be some hypertrophy. The peripheral heart will be acting. There will be more venous return, so increased preload because of the angiogenesis and less resistance in the muscles. There will be decreased afterload also. So ultimately, due to the increased oxygen demand and absorption, there will be decrease in heart rate and decrease in BP. So this is called aerobic training. And this aerobic training fitness also means the ability of your body to utilize free fatty acids as the main energy source. And the more energy you derive from fat, the better your fitness, health, and human performance. And by improving your fat burning system, you will improve your metabolic energy. Back to that important slide. See, the ATP given by the free fatty acids at 140 to 150 when compared to glucose and even glycogen. So what happens is that we will store less fat. We don't need much sugar for energy. We depend on fat, and that will decrease your appetite, and there will be a reduced craving for glucose-rich food. This is the syndrome probably of the decade, the aerobic deficiency syndrome, when the aerobic system is not well developed and maintained. This is one major risk factor for lifestyle disorders. The symptoms of fatigue, generalized aches, pains, frequent hunger, and craving for sweets, excess fat storage. Here, when you are not aerobically fit, your body will be depending 70% from 90% from sugar and only 10% from fat. And if you are aerobically fit, your body will be using 70% from fat and only 30% from sugar. Second is the resistance exercise. Why should we advise resistance exercise? And changing body composition is one hallmark in sedentary and physiological aging. Includes the gradual accumulation of body fat and its distribution. And see, on an average, the adult lost 5% of muscle mass per decade after in the age of 30. That is not after 50, it is after 30. And more rapid decline after the age of 65 years. So you should definitely advise this resistance training. So this can maintain the increased muscle bulk, maintain increased BMR, and most of this strength exercise involves lifting or pushing external weights or your own body weights. We need simple equipments like TheraBand, dumbbells, and a chair like this. I won't go to the details due to time constraints. These are a simple exercise which can be done at home even during COVID times. And see, exercise prescription. You know that most of our patients are very, very compliant regarding your advice. Like this patient, the doctor advised me to spend at least an hour per day on the treadmill, and the patient says, why not? And this is a result. And see, the exercise prescription should be tailor-made. Consideration should be given to their hobby, interest, skill, ability, their job, and financial capacity, and should be the one that will be easily carried out and regularly for a long period. The thing is, you don't have to go fast, but you have to go. You have to start exercise. Coming to the intensity, if a person described aerobic exercise as a series of strenuous exercise which convert fat, sugars, and proteins to aches, pains, and cramps, means the person is doing it wrongly. See, this is intensity, the maximum heart rate. This is a rule 220 minus age. You should start with 50% of the maximum heart rate. That means a 20-year-old a person should start the exercise with 100 beats per minute. Then you can increase up to 60 to 70%. That means a 20-year-old up to 140 beats per minute. So a simple advice is called talk test. That means if we are exercising mild, means less than 50% of maximum heart rate, you can sing while you exercise. And moderate means you cannot sing, but you can talk with your partner. That means the rate is 50 to 70%. And vigorous means you cannot talk, you cannot sing, you cannot tell only words. That means you have crossed the aerobic range, you have reached the anaerobic range. The desirable things are moderate. That means we can talk. And scientifically, if we want to exercise, you have to buy this tracker, which will give you the heart. This will cost around 1,000 rupees. And there should be 3 phases of exercise. The warm-up is not stretching exercise. That means the first step of exercise, warming up, is slowly shifting the blood into the working muscles, because you should start slowly and should reach over 5 to 15 minutes your desired heart rate. The keyword is low. So this is an exercise program. A is the warm-up, C is the cool-off, and B is the exercise proper. The cool down, definitely there should be a cool down. That's the end part of the exercise, the final 5 to 15 minutes, slowly lowering the heart rate from the maximum aerobic level back to the near resting level. So this will prevent the pooling of blood in the muscles and prevent what? Cramps, post-exercise cramps. Coming back to the ADA recommendation, see, the ADA recommends 150 minutes or more of moderate intensity exercise and not 150 minutes of walking or exercise per week. So this is 150 minutes per week of moderate intensity exercise. That means this is 150 and not the whole thing. So if you want to exercise 30 minutes per day, there should be a 5 to 10 minutes of warm-up and 5 to 10 minutes of cool-off, total 40 to 50 minutes. So this is last describes the substrates used for exercise. Mild intensity, only free fatty acids are used. In moderate intensity exercise, during exercise, 50% will be taken from free fatty acid and 50% from glucose, and in severe, only glycogen or glucose is used. And a few words on self-criticism. This is from DNA journal published in February 1, 2020. This is an observation by IMA Pune. Chapter says an average Indian lives up to 69 to 72 years, whereas a doctor lives only up to 55 to 59 years, which is shocking. It was noticed that most deaths were due to cardiac arrest, and there was a study from I think Benisar is also associated with a study in 2007 in Kerala. It showed that average lifespan of Kerala doctors only 62. And we have 2 options. We don't exercise, eat all you want, probably die early, and exercise daily, count calories, and merely wish you were dead. And most of the doctors rely on the first option. We cannot advise a patient like this. We should be leaders to give others proper lifestyle. And you should also help others in exercising. Like this is a quote by an unknown walker. If a young woman goes for a walk daily, she improves the health of 10 men. And thank you very much for the patient hearing. This is my simple advice: exercise, move a little more and eat a little less, and be positive and give positive thoughts to your patients. Thank you very much.
Thank you, Dr. Roy R. Chandran, for an excellent presentation regarding the physical exercise, physical activity. And is there any questions? I think there is no question in the chat box. Thank you, Dr. Shabir Rashid, for giving this opportunity to chair this session, which was an excellent one. Thank you. Thank you, all speakers, for excellent presentations.
Thank you, sir. Thank you for the wonderful.
I think Dr. Ravindran, you're not audible.
Hello. Moving on to the next session, special topics in diabetes. For chairing the session, we have Dr. Ajit Chakravarti, specialized in sexual medicine, faculty of Trivandrum Medical College. Also, we have Dr. Ramesh Kumar, sir, assistant professor, Department of Endocrinology, Government Medical College, Trivandrum. Over to you, sir.
Hello. Afternoon, everybody. So the next topic is blending of glycemic curve. And to address this topic, we have Dr. Om J. Lakhani, a renowned endocrinologist of our country. He did his MBBS and MD from Baroda Medical College. He has 5 gold medals and MBBS and 2 gold medals for MD. And he got the best thesis award during his MD period. And he did his DNB endocrinology from Gangaram Hospital, New Delhi. And he received President Gold Medal Award for his Gold Medal for National Diplomate of Medical Board of Examination. And he is a lot of award winner, including the Young Scholar Award of Endocrine Society of India, A.V. Gandhi Award for Excellence in Research. That is, so he has got a very good academic career and a flamboyant research career. So over to Dr. Om J. Lakhani for his topic. Thank you.
Hello. Thank you so much for the kind introduction, Dr. Ramesh Kumar, sir. I'll just share my slides. Okay, are my slides visible?
Yes, yes.
Great. Right. So what I'm going to talk about is, and for the fans of football, bend it like Beckham, right? So how we bend the glycemic curve, especially with the use of alpha glucosidase inhibitor like acarbose. And before I begin, I'd just like to say that when I started my endocrinology career, I was not very well familiar with AGI. In fact, I thought that alpha glucosidase inhibitors are just one of those many anti-diabetic drugs. But 6 years down the line, I think it is an indispensable tool in my diabetic armamentarium, and I think it's very very difficult to manage diabetes without the use of acarbose, especially when you have a population which is extremely high intake of carbohydrates, and I think it becomes very very difficult to manage without the use of alpha glucosidase inhibitor. So even though in the West you will see a lot of data which say that there isn't much benefit of acarbose or any other agent of similar group, I think in India there is tremendous impact of the use of drug like acarbose in our clinical practice. So what I'm going to do is in my talk, what we're going to talk about is first of all the importance of glycemic variability. How do we measure glycemic variability? Some clinical evidence based on acarbose, some of our own clinical cases with our AGP charts with the CGM data to show you how really effective acarbose is. Okay, so if you talk about glycemic variability, I'll show you a couple of cases of CGM to really demonstrate the concept of glycemic variability. So this is the patient number 1. His initials are PCM. Look at his glycemic curve. So what you can see here is average sugar here is his average sugar here you can see is 144. At the same time, what you can see is that okay, so you can see his average sugar, which is 144. You can see his curve, and you can see the thickness of his curve, and the curve is extremely thin. So he tends to have a similar inter-day glycemic variability, which is extremely low. And let me show you another case. Now, this is a patient who is having also having an average sugar of 145 milligram per deciliter, which is very similar to what we saw in the first patient. But you can clearly see his glycemic variability is extremely high. He has both high interday and intraday glycemic variability. So you can clearly see the difference over here. And the third patient I'd like to show you is almost a perfect situation where his glucose value is 111, average glucose is 111, and you can see he has very low interday and intraday glycemic variability. So we'll discuss these terms in more detail as we go along. Now, whenever we discuss dysglycemia, we talk about hyperglycemia, we need to talk about hypoglycemia, we also need to talk about glycemic variability. Glycemic variability is the third wheel of our glycemic management. Now, those who trade in stock market or commodities, it's very popular in my part of the world, and we are very, those who are traders in stock, they are very well accustomed with the term of short-term or intraday variability in the stock prices. The same way, when you talk about glycemic variability, you also have something which is known as short-term variability, that is intraday variability. We also have medium-term variability, that is intraday variability. So that means that my glucose value pre-lunch today is 145. On some other day it is 180. So that is interday variability, which is a medium-term variability. And then when you talk about long-term, we talk about long-term glycemic variability, chronic variability, that is the changes in HbA1c with every visit. So on one visit, the patient's HbA1c is 6.3, the next visit is 8.6. Patient has probably missed his medications for a few months. So, that is what is known as long-term variability. Now, all the three forms of variability have impact on overall glycemic control of the patient. It has impact on the microvascular and macrovascular complications in the patient. So how do you measure glycemic variability? The simplest way is to measure the standard deviation, and that is the derivation from the mean. So that's a standard deviation. We'll see with examples what are the normal values of this and how do we interpret these values. The second important parameter is coefficient of variation, and coefficient of variation is standard deviation divided by mean into 100. Coefficient of variation is considered the best indicator for intraday glycemic variability. So in the three patients that we saw earlier, the standard deviation I can see is in the first patient was 23, the middle patient who had a lot of intraday variability, it was 25, and the third patient was 24. But if you see the coefficient of variation, the first patient it was 19%, the second patient was 27%, and the third patient was 17%. So you can clearly see the difference in terms of, you can see that the intraday variability is very well reflected by the coefficient of variation. It is in fact reflected better with coefficient of variation than with standard deviation, as you can clearly visually see from the AGP curves. So what are the preclinical implications of glycemic variability? It is very well known, and it's been shown in the studies done in cells that whenever there is a glucose variation, whenever there is a glycemic variability, there is increased oxidative stress and potential to cause cell damage. Again, you can see from this a beautiful chart given in Endocrine Review in 2002 that whenever you have a hyperglycemic situation, so what I believe is that whenever you have the glucose rising or the glucose suddenly falling, you tend to develop more free radicals, more reactive oxygen species, which activates the various pathways which lead to ultimately the damage, microvascular damage that we see in practice. What about the clinical implications of glycemic variability? When we talk about clinical implications, generally in Indian subset of patients, the patients tend to spend more time in a postprandial situation. So hence, most of our glycemic variability in Indian patients is determined by glucose values. So what typically happens is that when you have a patient, and again, this has been shown in multiple studies, that the MAGE value, that is the mean glycemic excursion, is often associated with increased risk of both macrovascular, in this case, you can see increased risk of coronary artery disease, and in other several studies, increased risk of microvascular complication also. So glycemic variability, whenever you have variation in your glycemic control, both intraday, interday, and long-term variability, these have been shown to be associated with long-term complications of both type 2 diabetes related macrovascular complications as well as microvascular complications. Again, you can see the impact shown in various studies that glycemic variability is associated with higher risk of microvascular complications. So, how do you reduce glycemic variability, and how do you consider that as a form of treatment target? Well, what you can do is the best way to reduce glycemic variability is to have consistency in the patient's lifestyle, especially with regards to the carb content in the diet. And second is by again giving medications which will reduce glycemic variability. And the chief amongst them, there are two class of drugs which have a very good impact in reducing glycemic variability. One is your incretin-based therapies, that is your DPP-4 inhibitors and GLP analogs. And the second is your AGIs, that is alpha glucosidase inhibitors like acarbose. So, like we said, using AGIs and GLP analogs, reducing the having a consistency in the lifestyle patterns and reducing the carbohydrate content of the drugs often leads to reduction on glycemic variability. As far as insulin is concerned, use of basal insulin with oral anti-diabetic drugs has been shown to reduce glycemic variability compared to the use of premix insulin or multi-dose insulin, that is known as basal bolus insulin therapy. Now, we all know how acarbose typically works. What it does is it slows the absorption of the carbohydrate, it slows the breakdown of the carbohydrate, leading to a slower absorption of carbohydrate. In fact, I'll tell you something very interesting. Amongst all the drugs which are available for diabetes mellitus, the drug which actually reduces of hypoglycemia is also acarbose, because what acarbose does is that it slows the absorption. And nowadays, you're seeing a lot of patients, we see a lot of patients after Roux-en-Y gastric bypass who develop postprandial hypoglycemia secondary to bariatric surgery, secondary to the nesidioblastosis which develops in their pancreas. And in these patients, when we give these patients acarbose, the hypoglycemia episodes also reduce. So it is very interesting that acarbose is a drug which reduces both the hyperglycemia as well as risk of hypoglycemia, and hence producing a more static glucose situation. Okay, so again, this is a thematic cartoon which shows that treatment before acarbose and after acarbose, you can clearly see the postprandial peaks are blunted and the patient is doing much better in terms of glycemic control. Again, this is a study which was published in Diabetes Nutrition and Metabolism. Again, it was shown that acarbose tends to have an insulin sparing effect, and because you have whenever you have a machine which has a lot of moving parts, you are more likely to have some part which malfunctions. For example, those who follow Formula One, a Formula One car is more likely to break down than a standard car which you and I drive. The reason is that a Formula One has a lot of moving parts, a lot of complicated instruments, and every time the racer goes out on a race, there are a very good chance that the car would malfunction because of that. The same way, when you have a lot of insulin doses, multiple doses of insulin, you are likely to have a lot of problems. And hence, by giving acarbose, we often reduce the doses of insulin. It has an insulin sparing effect, and because of that, tend to have a much more stable glycemic control. So overall, if you talk about acarbose tends to act on all the aspects of a glycemic pentad. It reduces the HbA1c, reduces the postprandial glucose, reduces the risk of hypoglycemia, reduces glycemic variability, and mind you, it also reduces fasting plasma glucose also. Now you tell me why fasting plasma glucose is reduced by acarbose. The reason is very simple. Remember, post-dinner sugar, the sugar with which you go to sleep, is the same as the sugar that often is reflected in the morning time. So if your post-dinner sugars are very high, your morning sugars are also going to be very, very high. So by giving acarbose before dinner time, you're reducing the post-dinner sugar, leading to a stable fasting plasma glucose also. Now, what I'll do is this is the meat of my presentation. I'll actually show you my system, our own system of how we manage patients with diabetes, and how our patients we are able to reduce the glycemic variability and maintain excellent glycemic control, and actually bend the curve, that is flatten the curve and make it more like Lake Placid, as one of my friends described some of my CGM patterns. Okay, so typically what we do is when we have a patient who comes to us with diabetes for the first time, we start the patient on oral antidiabetics or insulin plus minus plus acarbose. This is a standard prescription. Depending, of course, on the HbA1c and the clinical status of the patient may or may not need insulin, may or may not need a certain group of oral antidiabetics. Then we adjust the dose of oral antidiabetic and insulin to achieve a target fasting plasma glucose in the range of 90 to 130 milligram per deciliter. That's our target. So let's say I start the patient with basal insulin. I titrate the dose of basal insulin to achieve a target fasting plasma glucose. Then we place a continuous glucose monitor to fine tune the glucose throughout the day. And then after 2 months, we follow up with an HbA1c. So this is a typical workflow, right? So the entire cycle is a 3-month cycle. The initial first 15 days, you adjust the fasting plasma glucose. The next 15 days, you put the AGP, continuous glucose monitor, and for the next 2 months, you just monitor that and we repeat the HbA1c. So that is a typical workflow that we follow in our patient. So I'll show you one case. This is a patient who is a 38-year-old male patient, newly diagnosed patient with diabetes mellitus, weight of 105 kgs, a strong family history of diabetes, newly diagnosed, like I said. His HbA1c at the time of presentation was 11. Again, you can see diabetic dyslipidemia very clearly in this patient. So we started the patient on insulin Rhizodec, which is a combination of short-acting and long-acting insulin, a pre-mix sort of situation, or like it's a co-formulation, along with acarbose and other oral antidiabetic drugs. We adjusted the dose to maintain fasting plasma glucose in a normal range, and then we put the continuous glucose monitor, and then you can see this beautiful curve. This was achieved in about 1 month time. We could achieve almost a flat, low glycemic variability, low intraday and interday glycemic excursions with an average sugar of 96. We were then able to reduce the dose of insulin and eventually within a couple of months stop the insulin in this patient. And this is how beautifully we are able to do it. This is the data from the patient using tide pool, and you can see 80% of his readings are in range. The time in range is 80%. Remember, time in range is the glucose values between 70 to 180 milligram per deciliter. The target which we try to achieve is more than 70%. And you can see this patient is having 80% time in range. His standard deviation is 29 and his coefficient of variation is 31%. So you can see again very low values here. Standard deviation, typically it should be at least less than twice ST into 2 should be less than the mean of the values, and ideally the coefficient of variation should be less than 36%. So this we are able to achieve in our patient. You can see ST into 2 is 58, ST into 3 is in this case is 97. The mean value was 96, so very close to the standard deviation into 3 was what we were able to achieve, and the coefficient of variation in our patient was 31%, which is clearly less than 36%. That is the target which we try and achieve. The second case, also a 40-year-old male patient with type 2 diabetes. This was what he presented to us. His HbA1c was 9.3 at the time of beginning. After 2 months, it went down to 6.3 without hypoglycemia. His glycated albumin was 20 at the time of initiation. Postprandial sugar of 409. So you can clearly see this patient. This patient again was started on insulin, and eventually the doses were adjusted along with other oral antidiabetic drugs. Again, you can see his CGM curve, beautiful. Again, there is still a lot of intraday variability and interday variability, but at the same time, his glucose values are average glucose is 125. His standard deviation is 36, and the coefficient of variation is 28%. Again, that suggests that the patient is doing relatively well. Some other cases, again, this patient, again, you can see the tide pool value, a very low glycemic variability. The patient is on acarbose with insulin, with the basal insulin in this patient. Another patient who is on oral antidiabetics. We are using sulfonylurea with acarbose and a combination of E3/4 with SGLT2 inhibitor. Again, you can see the beautiful curve, low intraday and interday glycemic variability in this patient again. Who is on insulin with acarbose with SGLT2 inhibitor and metformin. Again, you can see a beautiful flat Lake Placid type of glycemic curve. You can see. So what I'd like to conclude is that, and those who have not been using acarbose, I was also very skeptical about use of acarbose when I started my career right at the beginning, and what I eventually realized is that our patients are extremely high carb eaters, And I'm sure all of you have access to a very good dietitian, nutritionist, and you counsel your patient very well. At the same time, the patients tend to be indiscreet with the use of their carbohydrates, and hence they tend to have a very high postprandial glucose values. And hence, by using acarbose, you cut the peak, you break those mountains down, and you bring that to a more stable level. And this also improves the glucotoxicity, reduces the glucotoxicity, and eventually the patient, you are able to reduce the other medications also. Also, remember, acarbose reduces the risk of hypoglycemia. So what you're doing is you're reducing the peaks as well as you are preventing the troughs from happening, and eventually leading to a much more static and a stable glycemic situation for that patient. So thank you for patient listening, and I think I'm well on time. So thank you.
Thank you, Dr. Lakhani. That was a great, talk on acarbose, how acarbose is useful in, improving the glycemic variability per se. And yeah, even acarbose is one such molecule which has been used in the stop and IDDM study for the prevention of diabetes, and it is known to improve the carotid medial thickness also. So great presentation. No wonder why you are one of the favorite speakers of the country. We will see whether there's any questions to be taken, and if no, then we shall proceed to the next session. Thank you.
Thanks.
Thank you, Dr. Lakhani and Dr. Gomez. So I'm Dr. Ajit Chakravarti, Senior Consultant Reproductive and Sexual Medicine. So before going to the next presentation, let me introduce the speaker. Our speaker is Dr. Manish Agarwal, and he is the founder and director, Medling Hospital and Research Center, Ahmedabad. A completed postgraduate program in diabetology from Johns Hopkins University School of Medicine, fellow of Royal College of Physicians, Glasgow, certified by the American Thyroid Association, a PhD in diabetes from European International University, Paris, and he is a trustee of the Swami Vivekananda Education and Health Foundation. The topic is brittle diabetes, challenges and solutions. Over to you, sir.
Thank you, sir, for the first of the thanks for the Diabetic Today team, and congratulations of the whole the Diabetic Today team and Dr. Rasid is one of my good friend, and thanks to Rasid for inviting me, and thanks to the chairpersons for the kind introductions. I'm going to challenging of the topic in brittle diabetes and how to diagnose of the brittle diabetes as well as challenging and treatment of brittle diabetes. First, I'm going to introduction. What is the definition of the brittle diabetes? Almost all the diabetic patients, either type 1 and type 2 diabetes, they are experienced of swing of the blood glucose level, which are larger and less predicted in diabetic than the non-diabetic. When this swing become intolerable and cause the disturb to the person's daily life to life, is a diagnosis as a brittle diabetes. Normally, we are seeing of the whole lot of glycemic variability in diabetes, but glycemic variability is going to more and going to disturb the person to daily life to life. It is a brittle diabetes. Definitions in high glucose variability. High glucose variability to the wide glycemic exertion that occur within the same day, including the fluctuation in between the hyperglycemia. Typical already earlier speaker told, we are in particular out of 24 hours, 18 hours we are in the post-pancreatic and post-absorptive stage, and post-pancreatic hyperglycemia and hypoglycemia as well as fluctuation at the same time of the different way. Glucose variability is an important patient type 1 diabetes who are having the absolute insulin deficiency, incomplete suppression of the hepatic glucose productions. Hepatic is one of the liver is a good side of the hepatic gluconeogenesis and compromise the counter-regulative response, but definitely not happening. Some patients with a long standing type 2 diabetes, having the very particular the old above the age of 60, above the age of the 60, with a long duration of diabetes, age of the duration of diabetes more than 10 years, having some autonomic dysfunction and a glycemic invariability of this particular. So what is a brittle diabetes? Brittle diabetes represent the most severe phenotype of the high glucose variability. Histological brittle diabetes was defined of the severe glycemic instability of the blood glucose level with a frequently and unpredictable episode of the hypo and hyperglycemia. And patient is having the severe hyperglycemia and landed with a diabetic ketoacidosis and disturb the life activity, often required frequent and prolonged hospitalization. Brittle diabetes predominantly occur in setting of the absolutely insulin deficit. I am talking with the type 1 diabetes. They are more prone to the brittle diabetes and either the pancreatic diabetes, post-pancreatic of the cystic fibrosis, and some of the cystic fibrosis and pancreatic issue of the acute and chronic pancreatic can lead to the total problem. History in 1942, before the freedom of the Indian, Chicago physicians introduced the terms of brittle diabetes. Nobody was knowing the brittle, what is the brittle. 42 Chicago physicians were and he gave the word of brittle in 1950, and that is a questions were whether they were two distinct group of the patient with hypo with hyperglycemia. In 77, it again is going to the episode of the hypo and severe hyperglycemia and then the diabetic ketoacidosis. In 80, and it was investigated of the how. What about dermatology? It is a brittle diabetes. It's a very small group, significant properties. Having the significant problem is under diabetic patient normal. Is a out of 1,000, one patient is going to the brittle diabetes. But insulin, I'm talking with the type 1 diabetes, 3 times more common than the type 2 diabetes. It mainly affects the younger. What about the type diabetes? Between the age of 50 to 30 years. With the second frequently peak is older, 60 to 70. So it is going to brittle diabetes going to the two extremity of the first is younger and second is elderly and who are having the long duration of the diabetes, having some of the autonomic dysfunction. 2/3 of the affected patients are female, most of the female. Short duration of diabetes with a stable control with the high HbA1c, they need the high insulin dose of this particular. What about the forms? Most common forms of the recurrent diabetes. Already I have discussed with the diabetes, brittle diabetes is more common in particular the young 50 to 30 or a type 1 diabetes. And what about they are having the episode of the decade, 3 episodes per 2 years is a accountability of the 59% of the labile form. This form, which is more common in younger patients, is recognized with the reflective the simple non-complex with the insulin. Predominant hypoglycemia is a 3 severe episodes per year. What about the predominant hypoglycemia? The blood sugar is a less than 50 milligram deciliter is a considered as a hypoglycemia, but accountably of the 17% with the mixed instability of the 24-hour, and these last two form are more common. Already I discussed the earlier slide, more than age of 60 or 70, where we have the long duration of the diabetes. What about the etiology? Etiology is still is etiology, idiopathic, we are not knowing. But psychosomatic factors, 74% of them, almost 74% are psychosomatic. Other of the less of the 25% malabsorption, celiac disease, fat malabsorption, alcoholic abuse, drug abuse, antipsychotic drugs, autonomic dysfunction by the type 2 diabetes, history of the long duration of the diabetes more than 1 decade, having some of the autonomic dysfunction, autonomic neuropathy, and ultimately they are landed with the gastroparesis, with the hypoglycemia, unawareness, subcutaneous cause with defective insulin absorption, accelerated degradation, insulin allergy. These are some of the cause. Defect of the counter. Once we are going to patient is going to hypoglycemia, our counter regulator hormones are going to the accelerated, just like epinephrine, non-epinephrine, growth hormones, and defect of the counter-regulated hormones, the hypoglycemia, some of the auto-antibody against the anti-insulin and anti-insulin receptor. So these are some of the possible cause. Still, is a 74% of possible cause are psychosomatic and other. Real cause is some of the Merck syndrome, with a rare complication, type 1 diabetes, extremity hepatomegaly due to the glycogen deposit, along with the growth failure and delayed puberty. It is one of part of the polyglandular autoimmune syndrome of that. What about the clinical manifestation? That was epidermal 74% psychosomatic. Now I'm going to talk with the clinical manifestation. Two clinical presentation of detailed diabetes have been described. Predominant hypoglycemia with a recurrent severe hypoglycemia, more than 3 to 4 episodes per year is considered as a brittle diabetes. Virendra, is it predominant hyperglycemia is a word, but type 1 diabetes in the children, they are toddling, missing the dose of insulin, taking the meals, and ultimately they are end up with the severe hyperglycemia and some of the underlying infection and end up with the diabetic ketoacidosis. High glucose variability is the most concern whenever it is associated with the frequent episode of the severe hypoglycemia. How to evaluate it? How to evaluate it? Initiate. Care for evaluated should be performed by the pressure meter. Different diabetes two form. One of severe hypoglycemia with the severe hyperglycemia and high glucose variability, identifying the risk factor and differential physiological from the potential behavior cycle. Already I've discussed with the epidermal, 74% are causes of psychosomatic. So we have to change of the we have to go yoga, meditation, some of the behavior therapy, psychosomatic therapy. All the patient diabetic education assessment is a must of the all the type 1 and type 2 diabetes, self-monitoring, glucose monitoring is a must. They should keep glucometer to the type 1 diabetes. I'm going to again of the request of the we should get the blood sugar 4 to 5 times per day is a compulsory. They should get the blood sugar before breakfast, before lunch, before post lunch, 4 p.m., before dinner, post dinner, 10 p.m. These are compulsory to rule out the glycemic variability. And some of the patients are educated, they are having the basal bolus therapy and they are on the various insulin pump. And all the patients are going to request all the patients they should get the continuous glucose monitoring is a must of the to recognize the hypo and hypoglycemia. History is a main important of the rule out the brittle diabetes. Duration of the diabetes. So before going to, we should take the proper duration of diabetes. Patient is having a diabetes 2 year, 3 year, 4 year, 5 year. Discrimination of the all the episode of the decay. Either patient is landed with a decay or not decay and history of the hypoglycemia. Presence of the diabetic complication, comorbid conditions. What I'm talking with the above the age of 60, long duration of the hyperglycemia uncontrolled. They are having the underlying autonomic neuropathy like the gastroparesis with a conjugative effect with the cardiovascular defect with the celiac disease. All the type 1 diabetes, we should get that get antibody C peptide level along with the we should get the serum IgA should be done to rule out the celiac disease. Recent illness, infection, prescribe the insulin regime with any recent medication or self-monitoring of the glucose, self-monitoring of the glucose with the CGM is a compulsory all the type 1 diabetes and type 2 diabetes with the uncontrolled to the stimulated with the hypoglycemia. This is a glycemic profile. Again, in addition with SMBG, use of the professional of the CGM, log of the food intake. Every diabetic patient, they should keep the what they should keep the some diary. What about the thing they should mention with the what about the food they use physical activities. About patient is doing the physical 40 earlier talk by my coach, speaker. He mentioned the physical activity properly. 60 minutes of the walking is a must of the diabetic. Instead of how to use of the insulin, administer short acting, long acting, and mixed aid, understand the person glycemic profile. Who discovered the cause of recurrent decay? I said, type 1 diabetes, most of diabetes, they are ended with the decay. They are going to hospitalize. First time 500, 600 milligram HbA1c more than 11 at 12. And they are having some nausea, vomiting, and fever, and with some of the decay and frequency reason of the misinsulin. Most of the type of diabetes, at least age of the 10, 15 year, 20 year, they are not knowing what about the severity of the disease. So they should proper educated monitoring of the discover the cause of severe hypoglycemia, source of the mismatched insulin requirement. Some of the patients having the very short acting of the insulin, they are long acting of the insulin with the 30-70 or 50-50. I think all the patients they should know the carbohydrate counting of the mass because of the 10 gram of the carbohydrate needs the 1 unit of the insulin of the eating behavior, exercise, and how to dose of the insulin delivery needs to be determined. Evolution, again, the unexplained hyperglycemia. Some of the patients, they are coming with the clinic or we are getting the sugar more than 500, 600 without any symptoms of the, but ultimately they are landed with the some of the diabetic ketoacidosis because of the undiagnosed infections. So they just like a sinusitis, osteomyelitis, renal, perinephric abscess, perirectal abscess with the lung abscess should be excluded. Patient is having the hyperglycemia with the decay. These problems are more likely to the patient is IV drugs. In India, they accept also European, they are more of the drugs abuse, intravenous drug abuse. So all the particular we should get the urinary dog test is a compulsory one which patient is having the how to diagnose the beta diabetes and poor in Indian scenario we are seeing of the poor dental care and dental abscess. Nobody is going to care is a dental of the. So I am going to requesting type 1, type 2 diabetes. They should get the proper dental checkup and to the dentist to the scaling and cleaning of the dentist because of some of the article had present periodontitis and what about the periodontitis, periodontal infection, they are more popular coronary artery disease. Unexplained hypoglycemia with the patient unexplained hypoglycemia, some of the TSH, all the type 1, type 2 diabetes, we should get the T3, T4, TSH, and some of the addition disease should be ruled out. Patient is having the unexplained hypoglycemia, all the unexplained hypoglycemia, recurrent hypoglycemia, brittle diabetes, we should get rule out addition disease by the ACTH stimulation test. Insulin autoimmune, already I have discussed some of the rarely cause of the antibody against the insulin and other of the assessment of the brittle diabetes. These are some of the assessment of brittle diabetes properly psychosomatic and clinical and educated. What are some of the these are some of the mean and standard deviations of blood glucose, MAGE, mean of the daily differentiate. Suppose daily difference of blood sugar is a normal subject is less than 10 milligram deciliter, but stable diabetes with HbA1c 7.5 is a 40 milligram deciliter, but labile and brittle diabetes is a wide variable of the blood sugar is a 160 milligram deciliter, and that is the liability index, low blood glucose index, Clark score, or hypo score. These are some of the how assessment of this particular assessment. Now there are some of the few slides treatment options. Definitely lifestyle education.
Sorry to interrupt, sir. Sir, kindly fasten in the slides.
Some few slides, sir. Sorry. Lifestyle education is a must. All the diabetic patients they need proper education, self-monitoring of the blood glucose. Psychotherapy is a must of the most of diabetic patients. They are having the anxiety and depression, alternative medicine, insulin therapy, insulin pump therapy, and some of the beta cells transplant of the lifestyle education. I'm not going to educate them, but already I've discussed with self-monitoring of the blood glucose. All the patients they should know about how to do the carbohydrate counting. Suppose the person is having the patient is from the rural area and they are not knowing the carbohydrate counting is not possible. But what about the persisting carbohydrate consisting is each meal? Suppose they are taking the 2 chapati lunch and 2 chapati dinner. So we should fix of the 2 chapati and 2 chapati of this particular. In addition, insulin regime should be individual tailoring to the reduce the risk of hypoglycemia, where they maintain the glycemic index. General principle, this is my couple of the slides, education, monitoring of the educations of the mass, general self-monitoring of the glucose, of the must, all the diabetic type 1, type 2 diabetes, they should keep the glucometer of the so self-monitoring of the glucose is critical to the glycemic management of the type 2 diabetes. Intense treatment type 1, I'm talking with the basal bolus therapy, means the 3 times of the bolus and 2 times of the basal and type 2 diabetes, and CGM is the must of the glycemic. General principle insulin pump, most of the type 1 diabetes, they are having the basal and bolus is not going to achieve the HbA1c 7.5. We are putting out this particular insulin pump of the psychosocial patient with a clear psychosomatic component of diabetic instability, psychological evaluated referral to the world of the patient in spite of the they need of the psychotherapy and pancreatic of the this by exclusion criteria ultimately is not going to the control with the basal bolus and insulin therapy and what about we have to
Sorry to interrupt, Dr. Manoj. Many
last slide, sir, please. Sorry. And complications of the suppose we are not going to control with the brittle gastroparesis, severe malnutrition, endocarditis, intracranial pulmonary edema, cerebral edema, and spontaneous muscle infarct. These are common complications when suppose you are not going to the diagnosis of brittle diabetes. Summarize of the severe unstable brittle labile diabetes can be disturbed to the present day to day and life to life. Peak age of the brittle diabetes is already I discussed age of 50 to 30 years. Younger patient, principal manifestation, brittle diabetes, very recurrent ketoacidosis, and elderly patient with a long standing of the diabetes, more than 1 decade, age of 60 years, they are more prone to the hypoglycemia. Thank you, hearing me. And first of the apology, I took few more time. Thank you, sir.
Thank you, Manish Agarwal, sir. I think there is not much of, there is no worries there. So that is a wonderful talk regarding the brittle diabetes. So let us go forward to the next, topic. So the next topic is on medical management. We have, heard about the psychological aspects and the management of, erectile dysfunction. So let us go forward to the medical management of erectile dysfunction in diabetes, especially. So today we have my very close friend of mine and Dr. A.V. Ravindran is there. So let me introduce him. He is an alumni of Government Medical College, Kozhikode and KIMS Hubli. Worked as Assistant Professor of Medicine, Government Medical College, Kozhikode, Kottayam and Manjeri. Currently working as specialist in internal medicine, Badr Al Sama, Baka, Sultanate of Oman. Published about 25 articles in various international and national journals, more than 100 health educational articles. He has written more than 100 health educational articles in various health magazines. Over to you, sir.
Thank you, Dr. Ajit, for the nice words of introduction. First of all, I would like to thank Dr. Sabir and his team for giving me an opportunity to present this topic. So coming to the topic proper, medical management of erectile dysfunction in diabetes. I will be discussing the topic under the following headings. So as you all know, erectile dysfunction is defined as the persistent inability to achieve or maintain penile erection for successful sexual intercourse. So the prevalence of ED increases with age. And in the famous Massachusetts aging study, you can see that the prevalence of erectile dysfunction increases with age, starting from 40 years to 70 years. It is shown in the diagram. And the complete erectile dysfunction or severe erectile dysfunction also increases from 5% to around 15% by the age of 70 years. And erectile dysfunction increases also with in patients with diabetes, those who are having hypertension, dyslipidemia. Also, there is increased risk of development of erectile dysfunction. Coming to the erectile dysfunction in diabetes, the overall prevalence of ED is around 16 to 25% in the general population, whereas it is around 60 to 80% in people with diabetes. So the erectile dysfunction is a risk factor for sexual dysfunction in diabetes. There is a 3-time increased risk of ED in people with diabetes. And erectile dysfunction appears much more earlier, that is around 10 to 15 years earlier in people with diabetes. Coming to the mechanism of erection, as you know, all know, this is the cross-sectional view of the penis. You can see the corpus cavernosa, and this contains sinusoidal cavity lined with endothelium. And what happens is, this is the diagrammatic representation of the same. These cavities get filled with blood during erection. So this is the sinusoidal cavity, and this is the blood-filled sinusoidal cavity resulting in erect penis. So this is the mechanism by which erection occurs. And during erection, as you can see in this diagram, there is increased inflow into the lacunar space. There is increased blood flow into the lacunar space. It accumulates there, and it reduces the venous return because of the compression in the subtunical space. So when there is sexual arousal, there is a release of nitric oxide from the nerve terminals and endothelial cells, which activate guanyl cyclase enzyme, which convert GTP into cyclic GMP. This cyclic GMP results in smooth muscle relaxation and increased blood flow into this area, resulting in erection. And this cyclic GMP is degraded by phosphodiesterase 5 enzyme, which results in loss of erection. So, a neurologically mediated arterial inflow, then relaxation of the smooth muscles allowing blood flow into the penile vasculature, and venous obstruction that allow the blood to remain in the penile vasculature to maintain erection. These are the requisites for a normal erection. If any of these steps are affected, it can lead to erectile dysfunction. So coming to the causes of erectile dysfunction, as we already discussed, any psychological illness like anxiety, depression, vascular causes like peripheral vascular disease, hypertension, neurological illness like peripheral neuropathy, stroke, endocrine disease like diabetes, hypogonadism, all these can lead to erectile dysfunction. In addition to that, various drugs can cause erectile dysfunction. Surgery or trauma can also result in erectile dysfunction. And these are the drugs associated with erectile dysfunction like beta blockers, antipsychotics, antidepressants, diuretics, etc. Coming to the clinical evaluation of a patient with erectile dysfunction, in addition to detailed sexual history, we have to ask about the lifestyle factors like smoking, medical history including diabetes, hypertension, coronary artery disease, history of any drug intake, and we have to assess the psychological status of the individual. And ED can be the first symptom that bring a man to the medical attention, which leads to the diagnosis of cardiovascular disease or diabetes. So a detailed physical examination, including examination of genitalia, is also required, but most of the time the clinical examination will be normal. And with this background, we'll be able to differentiate organic ED from psychogenic ED. I'm not details because Dr. Arun B. Nair already discussed about organic differentiation between organic and psychogenic ED. So there are a lot of formal questionnaire to help to assess the erectile dysfunction, including International Index of Erectile Dysfunction, Sexual Encounter Profile, Global Assessment Question. This also discussed by the previous speaker. So after clinical examination and examination, we have to do the relevant investigation. We have to rule out risk factors like diabetes, hypertension, dyslipidemia by proper testing and assess the cardiovascular status of the individual. And depending upon the patient profile, we can ask for hormone assays also. As you all know, erectile dysfunction is always equated to endothelial dysfunction. Hyperglycemia, hypertension, dyslipidemia, obesity, smoking, all these leads to endothelial dysfunction, leading to atherosclerosis and coronary artery disease and stroke. And the same risk factor can lead to endothelial dysfunction and erectile dysfunction. So hence, people are considering that endothelial dysfunction is a systemic illness, and erectile dysfunction and coronary artery disease are varying manifestation of this endothelial dysfunction. And the arterial size hypothesis clearly explains this phenomena. You can see the arterial size of penile artery is 1 to 2 millimeter, that of proximal LAD is 2 to 3, internal carotid is 5 to 7, and femoral artery is 6 to 8. When there is around 50% luminal obstruction, patient usually develops symptoms. And when penile artery is obstructed, it leads to erectile dysfunction. Coronary artery involvement lead to coronary artery disease. So it clearly explains why erectile dysfunction occurs prior to coronary artery disease, depending upon the arterial size. So the interval between the onset of erectile dysfunction symptom and the occurrence of coronary artery symptom is estimated at 2 to 3 years, and the cardiovascular event at 3 to 5 years. So clinician must always remember that treatment of ED in people with diabetes must always include glycemic control and risk reduction for cardiovascular events, in addition to specific therapy directed towards erectile dysfunction. So coming to a cardiac evaluation, in a patient with erectile dysfunction, we have to find out whether he belongs to low risk, intermediate risk, or high risk. If he's in the low risk, we can initiate or resume sexual activity, whereas for high risk individuals, sexual activity is deferred until cardiac condition is stabilized. And intermediate risk group, we have to do proper cardiovascular assessment to re-stratify the individual. And this shows the risk categories: low risk, intermediate risk, and high risk. Coming to the treatment of erectile dysfunction, so as I already discussed, this risk factor control is important for the treatment of erectile dysfunction. So lifestyle modification, glycemic control, control of hypertension, obesity, dyslipidemia, all these are important in people presenting with erectile dysfunction, especially diabetic individual. So physical activity has got beneficial effects. Obesity is associated with 40% increased risk of developing erectile dysfunction, and control of diet to control all these risk factors also helps to control erectile dysfunction. And smoking is a strong risk factor for erectile dysfunction. And poor control of blood sugar, poor glycemic control, increase the risk of ED by 2 to 5-fold. So improvement in comorbid condition like modifying associated risk factor before initiation of PDE5 inhibitor is associated with improved overall success rate to 82%. Coming to the pharmacological treatment, as you all know, PDE5 inhibitors are the major drugs used to treat erectile dysfunction, and there are 11 isoforms of PDE5 enzyme, phosphodiesterase enzyme, and the 5 isoform is found in corpus cavernosum. And we will see how PDE5 inhibitors act. This diagram we have already seen. Sexual arousal results in nitric oxide release, which results in activation of guanyl cyclase, which convert GTP to cyclic GMB. And cyclic GMB results in smooth muscle relaxation, leading to increased blood flow and erection. And this cyclic GMB is rapidly degraded by phosphodiesterase enzyme, resulting in loss of erection, and PDE5 inhibitors act at this stage. These are the commonly used drugs like sildenafil, vardenafil, tadalafil, avenafil. And you can see the half-life of tadalafil is 17.5 hours, which is a long-acting drug, and the duration of action is around 36 hours compared to other drugs. And sildenafil and vardenafil has to be administered 1 hour before sexual intercourse, and tadalafil and avenafil half an hour before. And it acts up to 4 hours after the intake of tablet in case of sildenafil and vardenafil, and for tadalafil it acts for almost 36 hours. And if a patient has taken PDE5 inhibitor and subsequently if he develops cardiac illness, nitrates have to be avoided for 24 hours for those who are on sildenafil or vardenafil, 48 hours for tadalafil, and 12 hours for avenafil. So these are the few real-life data, clinical data showing the effectiveness of these PDE5 inhibitors. I'm not going to the details because of the time constraints. So what are the adverse effects of these PDE5 inhibitors? The common adverse effects include headache, dyspepsia, flushing, abnormal vision, back pain, and muscle cramps. So what are the contraindications for PDE5 inhibitors? Concomitant treatment with nitrates or nicorandil, recent MI, cerebrovascular accident, unstable angina, severe hypotension, uncontrolled hypertension, severe hepatic impairment, retinitis pigmentosa are all contraindications for the use of PDE5 inhibitors. When we use PDE5 inhibitors, most of the people respond after 1 or 2 doses, but some need 6 to 8 doses before an optimal response occurs. So when we give PDE5 inhibitors, what are the response we get? The categories of treatment success: we can get cure, or drug-dependent success, or drug-dependent success with new symptoms like inability to ejaculate, premature ejaculation, etc., or improvement but no intercourse. And drug failure category include transient unsustainable improvement, resistance failure, where the patient is not willing to take medication because of the perceived risk of adverse effect, and pharmacological failure. So a trial of minimum 8 doses of maximum tolerated dose of PDE5 inhibitor has to be given before declaring that the patient is not responding to PDE5 inhibitor. So what are the causes of initial PDE5 inhibitor failure? Like inadequate patient education and incorrect drug usage, failure to optimize the dosage, severe penile vascular disease, unrecognized hypogonadism, uncorrected comorbid illness, vascular risk factors, psychological factors, severe erectile dysfunction at presentation, development of tachyphylaxis, and history of trauma or surgery. All these cause lack of response to PDE5 inhibitors. How we can manage this? Proper patient education. Educate the patient regarding the need for adequate sexual stimulation, because the drug does not cause sexual arousal, and it has to be taken, like sildenafil and vardenafil, have to be taken 30 to 60 minutes before the intercourse. And food and excessive amount of alcohol has to be avoided, which interfere with the drug absorption and action. And sildenafil and vardenafil have to be is effective for 4 to 6 hours, whereas tadalafil is long acting, it's effective up to 36 hours. And if patient is not responding to this dose, we have to titrate the dose to achieve optimal response or till the maximum dose is attained. And if it is not responding, we can try another PD inhibitor. Some people may respond to another PD inhibitor. Those who are on-demand PDE5 inhibitor, we can start them with a daily dose of PDE5 inhibitor, which also improve endothelial dysfunction. And improvement of risk factor is also important, and also address any psychological issues that interfere with the treatment response. And some people may fail to respond after some years, and it is mainly due to tachyphylaxis or progressive worsening of the underlying illness. And those who are having hypogonadism, addition of testosterone significantly improve the response to sildenafil in men with erectile dysfunction. And we can combine sildenafil with other drugs like alprostadil, daxosin, apomorphine to get optimal response. And those who are not responding to these, there are vacuum devices which help to attain erection, and it is found to be effective in 75% of men in one study. And the vacuum constriction device, the major side effects are pain, numbness, obstructed ejaculation, etc. And we can also use intracavernous injections, which the commonly used drugs are alprazosil or combination of papaverine, phentolamine, or alprazosil, which is called trimix. And usually it's applied, the injection is given in the middle third of the penis in the 10 o'clock or 2 o'clock position. And adverse effects are penile pain, fibrosis, and priapism. And transurethral alprazosil can also be used to treat erectile dysfunction. And those who are not responding to medical management, we can go for surgical therapy like insertion of penile prosthesis, corrective surgery for those who are having deformities like fibrosis or Peyronie's disease, or vascular or arterial surgery with compromised vascular issues. The penile prosthesis can be inflatable or semi-rigid. I'm not going to the details. So the common complication is infection, which can be reduced by using antibiotic-coated penile prosthesis. So coming to the end of the talk, the conclusion is ED is an important but often neglected complication of diabetes. It always include sexual history in your clinical examination part, and early diagnosis help to treat erectile dysfunction properly. Treatment of ED in people with diabetes must always include glycemic control and risk reduction of cardiovascular events, in addition to specific therapy directed towards erectile dysfunction. Thank you for the patient listening.
Thank you, Dr. Ravindran. Basically, say erectile dysfunction is one of the most important the problem in diabetes, especially the quality of life as well as the life of the color of is the person's life, right? So that was a very detailed talk on before passing to the next chair, let me thank Dr. Sabir Rashid and DDR for giving the opportunity to the chair. Thank you very much.
Thank you all. Thank you, Dr. Sabir and team, for the opportunity. Thank you.
Okay, so just one important announcement. Since we are running short of time, I think we are avoiding this lunch break. We are avoiding this lunch break, and we are moving straight away to the sessions. And thank you, Ajit. Thank you, Ravindran, for the excellent talk and excellent sharing. So we are going to next topic, next session. There is something related to like what we had in our medical school days. This is something very special, especially to me, because all the four speakers are my either my batchmates or my like seniors in medical school, Trivandrum Medical College, and those who are chairing, Dr. Benny and Dr. Arun, are also my very good friends and are my my seniors or my batchmates in Trivandrum Medical College. So let me invite Dr. Benny PV, is the Professor of Community Medicine, Google Medical College, and Dr. Arunvi Nair, is the senior consultant psychiatrist, Medical College Trivandrum, to chair the sessions. Over to you, sir.
Thank you, Dr. Shabir. The next session is on back to basics. Actually, we have to refresh most of the topic on our basic knowledge regarding the clinical skills. Today, this is I think this session will be helpful for refreshing our knowledge regarding our basics. First topic is ECG changes in common disorder. I welcome Dr. Arun for introducing Dr. Arun Gobi.
Yes. Thank you very much, Benny sir. It's a great privilege for me to introduce my dear friend and junior at Trivandrum Medical College, Dr. Arun Gobi, who I had already mentioned as the most brilliant young doctor of our generation. He is the director and head of electrophysiology unit and heart failure clinic at Metro International Cardiac Center. He was formerly assistant professor of cardiology in Pariyara Medical College. He is a product of 1998 admission batch of Medical College Trivandrum with gold medals in medicine, surgery, pediatrics, and ophthalmology. He is a winner of the Young Investigator Award on his paper on mitochondrial mutation in long QT syndromes in the Asia Pacific Heart Rhythm Society Conference of 2012. He also holds the Fellowship of American College of Cardiology 2017 and Fellowship of the European Society of Cardiology 2018. So with great pride, let me hand over the mic to Dr. Arun Gobi for his presentation on ECG changes in common disorders. Welcome, Arun.
Yeah, thank you. At the outset, I thank Shabi for this opportunity, and it's really an honor and privilege to be to have my beloved senior Dr. Arun as the chair as well, and it's again coming back home to the basics. So I'll try to share my slides. My slides visible and my audio clear.
Yes, both right.
Yeah. So at the outset, I would just have a disclosure. This is a topic on which I would have dealt my at least 7 to 8 years of my academic career on, and 15 minutes would just be be just too short to do some justice to this topic. So I would just carry on, and I request the chairs to just let me know when my time is up, and I can stop at any time actually. So ECG, as you all know, gives us a tremendous amount of information. This small piece of paper which records the summated electrical activity of the heart gives us a lot of information on diagnosis of both cardiac and extracardiac disorders, provided you analyze this strip of paper in a systematic way by looking at the rate, rhythm, and each of the individual waves and understanding what is going on. To start off, let's look at acute coronary syndrome, where ECG forms the cornerstone of diagnosis of acute coronary syndrome. We all know that people who have a non-occlusive occlusion in the coronary in the form of unstable angina, you find abnormalities predominantly in the repolarization pattern, especially as peak T waves, flattening of T waves, T wave inversions, or ST depression in varying magnitudes. Generally, this indicates subendocardial ischemia and generally do not translate to Q wave. But once you have a occlusive thrombus, you tend to have a Q wave and an electrical window in the heart, which translates as a ST elevation myocardial infarction, which is the more fatal of all forms of acute coronary syndrome. Whenever you have an occlusive thrombus in the coronary, generally it starts off with having a prominent hyperacute T waves, which becomes very prominent. followed by elevation of the J point, which is nothing but the junction between the QRS and the ST segment, which is generally a convex elevation, followed by inversion of the T waves, and gradually as the infarct progresses, the patient starts developing electrical window in the heart, which is seen as a Q wave on your ECG. There are some objective definitions for these criteria for having to call it an ST elevation. You should have more than 2 mm or 2 millivolt elevation in leads V1 to V3, or more than 1 mm elevation in any of the other leads measured at the J point in 2 or more contiguous leads. To call it a pathological Q wave, you need to have a Q wave which is more than 25% of the corresponding R wave, or a duration which is more than 30 milliseconds in leads 1, 2, AVL, AVF, or V4 to V6. Majority of these larger infarcts are associated with corresponding or reciprocal ST depression in the other vascular territory. For example, this ECG, as you see down, we have ST elevation in the anterior leads and ST depression in the inferior leads, which actually indicates remote ischemia or evidence of large infarct. This is actually the classical evolution pattern of an acute coronary syndrome or an ST elevation MI that you see on the ECG. The first change is nothing but a hyperacute or a prominent T wave, which is followed by elevation of the J point or a convex ST segment elevation, which is the pathognomonic feature of a massive infarct. As the infarct progresses, the height of the R wave gradually comes down, indicating the viability of the myocardium going down, and Q wave starts developing, and T wave, which gradually inverts. From here on, it can evolve in 2 patterns. One is if the area becomes non-viable and aneurysmal or dyskinetic, this ST segment elevation can persist beyond 6 weeks, which is synonymous of LV left ventricular aneurysm, or if the infarct is resolved, the R wave although loses its height and they form a QS pattern with a T inversion in the evolved phase of acute myocardial infarction. The T inversion gradually over time becomes upright and leaves behind only a QS pattern, which is a signature of old myocardial infarction. So this is the classical evolution pattern if you follow these patients sequentially with serial electrocardiograms. For interventional cardiologists like us, this gives us a lot of information not only on diagnosis but also to localize the culprit artery when you're dealing with a case of ST elevation myocardial infarction, because it gives us the vessel to target when you're doing a primary angioplasty. On the other hand, for ST depression, it does not have any localizing value. For example, if a person has an ST elevation in lead V1 to V4, it indicates an anterior wall myocardial infarction, and most probably the culprit artery is going to be a left anterior descending artery. If you have ST elevation in leads 1, AVL, V5, V6, it indicates a lateral wall infarct, and it most likely the corresponding culprit vessel is going to be the left circumflex. If you have ST elevation in leads 2, 3, AVF, it indicates an inferior wall myocardial infarction, and likely the culprit artery is going to be a right coronary artery. This is a case scenario, just the typical, you have QS with convex ST segment elevation and inverted T waves in leads V1 to V3, synonymous or pathognomonic of an evolved anterior wall myocardial infarction. Not only it gives us information that the culprit artery is going to be the left anterior descending artery, also some other features on the ECG like evidence of right middle branch block or ST elevation in lead AVR along with V1 to V4 indicates a proximal LAD occlusion. If there is ST elevation in both V1 to V4 and ST elevation in the inferior leads, it indicates a distal LAD occlusion. While if neither of these things are there, it localizes the site of occlusion to mid part of the left anterior descending artery. This is another example where you have ST elevation in lead 1, AVL, and V5, V6. As we saw earlier, if you have elevation in ST elevation with Q waves in lead 1, AVL, V5, V6, it corresponds to a lateral wall infarct, and likely the culprit vessel is left circumflex artery. The other infarct that we commonly see in our clinical practice is the inferior wall infarction, where you see ST elevation, evidence of Q waves, and repolarization abnormalities in lead 2, 3, and AVF with reciprocal changes in the anterior leads. When you have seeing a patient with inferior wall myocardial infarction, always look at the rhythm, because most of these patients are complicated by AV blocks, which can be complete heart block to even a minor degrees of first degree heart block, as was seen in this case, which had a proximal right coronary artery occlusion, which was opened up by revascularization. In all cases of inferior infarct, it's always prudent to have right-sided leads. That is nothing but a similar leads like V4R and V3R on the right side of chest to look for evidence of right ventricular myocardial infarction, which might complicate about 40% of cases of inferior wall myocardial infarction. And as seen in this ECG, you will have ST elevation in V4R and V5R, which is synonymous, V3R and V4R, which is synonymous with diagnosis of right ventricular myocardial infarction, which clinically presents with cardiogenic shock and clear lungs. And so in persons with inferior wall myocardial infarction, you know that either the culprit artery is going to be right coronary artery or left circumflex artery. ECG also gives us clue to look at which artery is likely to be the culprit before we take the patient to the cath lab. For example, in an inferior wall myocardial infarction, the extent of ST elevation is more in lead 2 than lead 3. If the ST elevation in lead 3 is more than lead 2, if there is evidence of complete heart block or any evidence of significant AV block on the ECG, or if there is evidence of right ventricular myocardial infarction on the ECG, all these are very specific for right coronary artery to be the culprit behind the elevation in the inferior leads. On the other hand, if the ST elevation is more than in lead 2, more than lead 3, and you have corresponding ST depression in lead 1 and AVL, it is very likely to be involving a dominant left circumflex artery. One other myocardial infarction which is very commonly missed is a posterior wall myocardial infarction. This is precisely because we keep our leads on the anterior chest wall and you don't find any form of ST elevation on these anterior leads when a person is having a posterior wall myocardial infarction. To be more specific, in these cases, it is ideal that you keep some leads on the posterior chest wall, which we call V7, V8, and V9, which in these cases will classically show Q waves, ST elevation, and inverted T waves in V7, V8, and V9. But in cases where you don't keep these leads, the corresponding anterior leads, especially V1, V2, and V3, will show mirror images of the corresponding changes that are expected in the posterior leads. So the mirror changes of a Q wave is going to be a prominent R wave. The mirror change of an ST elevation in the posterior is going to be an ST depression, and the mirror image of an inverted T wave is going to be a prominent upright T wave. So if you have a prominent R wave, ST depression, and a prominent T wave in V1 to V2, this is very pathognomonic of posterior wall myocardial infarction, which might be seen in a left circumflex occlusion. It is not only useful for diagnosis of ST elevation or non-ST elevation myocardial infarction, it also gives us an idea about the therapy that we give. 90 minutes after a therapeutic intervention or a pharmacological therapy with streptokinase or a thrombolytic agent, if you find a more than 70% resolution of ST segment changes, it is very specific for a complete opening up of the culprit artery. In addition, you can find reperfusion arrhythmias like axillary radioventricular rhythm in about 50 to 70% of cases when you are taken up for primary angioplasty. So it not only helps us in diagnosis, but also helps us in understanding whether our therapy is getting effective or not. We are always taught that ST elevation is an entity which is considered to be fatal and with ominous prognosis. You see this patient who came to us with significant angina and in a near hemodynamic compromise. On contrary to what is expected, we find ST segment depression all the leads, and if you have a close look, you can find actually ST elevation in 2 leads which we don't talk to about much, that is AVR and V1. If you have these global ST segment depression with ST elevation in AVR, this is the worst form of myocardial infarction the patient can have, and that is why he is having severe angina with crippling hemodynamics. He has what we call a left main artery occlusion, and in this case, unless we immediately take him to the cath lab and open up this left main artery, this is a case with almost 100% fatality. On the other hand, if you have ST elevation across all the precordial leads in a relatively seemingly stable patient, this is a benign entity, what we call as pericarditis, where you have a concave ST segment elevation. As I said, in myocardial infarction, you have convex ST segment elevation. In pericarditis, you have concave ST segment elevation. In different vascular arteries, you will have ST elevation in inferior and anterior leads without reciprocal ST segment changes. And the most specific sign of pericarditis is to have PR segment depression in all the leads except for AVR and V1, where you have PR segment elevation. So pericarditis has global ST segment depression with no corresponding T wave changes, no Q waves, and absence of reciprocal changes indicate that this is a benign entity which is pericarditis and needs just anti-inflammatory treatment. There are spotters on patients presenting with acute coronary syndrome. If a person comes with this kind of EKG to your OPD, this is something very obvious. If you have, this is called de-Winters T waves, where you have an upsloping ST segment depression with a 1 millimeter J point depression with very tall, prominent, hyperacute T waves in V3 to V4, which is called de-Winters T wave, and it is a very sure shot sign of proximal leg occlusion and carries ominous prognosis, so should be taken up for early invasive strategy. Other thing which has to be noted is if a person comes with typical angina and very prominent T inversions in V1 to V3, this is called Wellens pattern and is very specific for a critical proximal radial occlusion, and 2/3 of these patients can evolve into an anterior myocardial infarction anytime, so needs an early invasive strategy. Whenever you see this prominent T wave inversion, you need to look at this T wave inversion specific. If you have an asymmetric T wave inversion with a steeper upslope, a terminal positivity, and a J point depression, this indicates a repolarization abnormality secondary to left ventricular hypertrophy, while an ischemic T wave inversion will be symmetric, will not have a terminal positivity, or will have a corresponding ST segment elevation. So moving on from acute coronary syndrome, the other entity where ECG is very clearly diagnostic is arrhythmias. We all know that this is the classical sinus rhythm where you have a normal P wave followed by a normal PR segment and a normal QRS. In people who have an accessory pathway connecting the atrium to ventricle, you tend to have a very short PR interval, a slurred upstroke of the QRS, and a wide QRS, which forms a triad of what we call as Wolff-Parkinson-White syndrome, where there's an accessory pathway connecting the atrium to the ventricle, and they are predisposed to various forms of supraventricular tachycardia. If you have everything which looks like a sinus rhythm, a normal P wave followed by a normal PR segment and a normal QRS, the heart rate is less than 60, it indicates sinus bradycardia.
Your slides are not moving.
I think there is some
None of the slides, it stays there.
Is my slides moving now?
The last slide, what is staying there is the pericarditis.
Okay, I think there's an issue with the network then. It's still stuck.
Yes, it is not moving, and now it is okay.
Now it's moving. We are running a little bit short of time also, Arun. So
okay, so I think we have discussed with acute coronary syndrome, and since there's shortage of time, I'm not, because rhythm disorders itself is a big topic on itself. I'll just get out by just saying one common thing that most of the physicians should be knowing, that is where ECG is very specific, is an electrolyte disturbance, what we call as hyperkalemia. So I'll end up with this entity where ECG is sure short of diagnosing an electrolyte disturbance without even looking at the serum potassium values. So when you have a ECG which shows a very prominent hyperacute, like prominent pointed T waves with absence of ST segment, gradually as the hyperkalemia worsens, the ST segment goes off, the P waves flatten out, the PR prolongs, and you have what we call sine waves. And the beauty of this entity is the ECG changes actually closely correlate with the potassium levels. Like if you have potassium levels which is more than 5.5, you have tall prominent T waves. As the potassium levels goes above 8, you have absence of P waves. So there's a clear correlation of ECG to the biochemical potassium values, and so that is why these electrolyte disturbances can easily be spotted out on the surface EKG as well. So when you have tall prominent T waves, if it is very symmetric narrow based and pointed and tending, it is hyperkalemia, while if you have symmetric broad based and not tending, it is a sign of ischemia, while if they are asymmetric and not narrow, it is considered a normal variant. So I think ECG in various disorders, I can keep on going on, but in the interest of time, I'll stop here saying that ECG is a wonderful diagnostic tool, a very cheap diagnostic tool, which gives us tremendous amount of information for diagnosis of not only various cardiac disorders, but also various extracardiac pathologies, provided you have a systematic analysis of this paper. I'll stop here. Once again, thanking Shabir for this opportunity, and this is why I'm here. He's been close to me for the last 22 years, and this is our batch get together. And I conclude by having a silent moment of prayer for all the families who are suffering because of the numerous tragedies we are going through, be it COVID, landslides, or the plane crash we had yesterday. Thank you.
Thank you, Arun, for that excellent, very elaborate, very illustrative, illuminating presentation. Any questions from any of the participants? We have 1 minute for a brief discussion. Any questions directed to Dr. Arun Gopi for this topic?
It's difficult to deal with ECGs in 15 minutes, actually. Yeah. So, and again, each of these topics can be dealt with for days together. So, I'm anyway happy if if any of you could get some points across. I'm sure it was quite a rapid presentation, and I hope there's some take-home messages from this. Thank you.
Okay, thank you, Arun. It seems nobody is in a mood to ask any questions. Anyway, thank you very much for your excellent presentation as always. And over to Dr. Benny PV to continue the.
Thank you, Shabir. Thank you. Yes, thank you.
Next topic is chest X-ray interpretation, which is presented by Dr. Rajat Tilagam. She is a very close friend of me, and she is assistant professor in the Department of Pulmonary Medicine, Government Medical College, Kollam. Did graduation from Medical College, Alappuzha, and MD, DNB from Medical College, Kottayam, and also DM from Calicut Medical College. Now, the era of COVID, we know most of the pandemic and also diseases of public health importance like TB is mostly affecting respiratory system, and the diagnostic tool is always the very basic X-ray. So today, Dr. Rajatilagam is going to deal with the basics of chest X-ray interpretation. Over to you, ma'am. Hello? Hello? Hello?
Hello, can you see the slides?
Yeah, actually, did you hear my introduction?
Yes, I heard.
Okay, did you hear?
I can hear. Can you hear me?
Yeah. Actually, I will introduce once more. Actually, next topic is chest X-ray interpretation, which is that topic is dealing by Dr. Rajatilagam. She is a very close friend of me, and she is an assistant professor of Department of Pulmonary Medicine, Government Medical College, Kollam, and did graduation from Medical College, Alappuzha, and MD, DNB from Medical College, Kottayam, and also DM from Calicut Medical College. Now we are in the era of COVID. We know most of the diseases of public health importance like pulmonary TB and very common pandemic like COVID is affecting the primary system is a respiratory system, and chest X-ray interpretation is one of the most basic tool we need to diagnose most of the problems of COVID and also the public disease of public health importance. To deal with that topic, I direct the mic to Dr. Rajatila. Welcome you.
Thank you very much for the nice words. And thank you the organizers for giving me a chance to present the topic. Straight away going to the topic. Can you hear me and see the slides?
Yes.
Okay, thank you.
Can you show it in view mode? Slideshow mode, please put it. Okay.
Slides.
Yeah, ma'am, it's not. Do you want us to share my? You just.
The slide. The view mode is okay.
Yeah,
I think
it's there actually. Earlier it was there.
I think some technical issues there.
Any issue, ma'am? Do you want us to share?
Okay. First,
Can you
Ma'am,
change?
previously it
Can you
was
change
it's
okay.
the
not
slide?
coming in the screen. The slide is not coming in the screen now.
So
I don't know.
shall we start?
Okay.
Okay, ma'am. We will do. Just wait. Meanwhile, ma'am, I think till then it may take another 30 seconds or so. Till then, you can just describe regarding the basics of X-rays. How to get a normal X-ray and all. You can just start talking.
Okay. What's about the basic of X-rays? Can you hear me?
Yeah, now it is here. Now it is showing that the slide is coming. Yeah, now it is okay.
Ma'am, now it's okay. Please start.
Okay. So I will start with how to read a chest X-ray. First we have to check the name, date of birth or age, and check the orientation, position, and side description, whether it is in the left, right, or erect position, APV or PAV. It's important because the left side is marked, and in dextrocardia also we can miss the dextrocardia if the side is marked and not marked right. Like that, in PA view, the X-ray beam falls in the posterior aspect of the patient, and in the AP view, the X-ray beam falls in the anterior aspect of the patient, and usually in the supine position it is taken. And it is very important to know the inspiratory film or expiratory film. Usually, this is taken in the inspiratory view. Inspiratory view, the 10th rib till the posterior end of 10th rib we can be visible, and in the expiratory film only the 8th till the 8th rib is visible. So the 8th for this. In the expiratory film, till the 8th rib is only visible, and there can be an apparent cardiomegaly also. And check for the rotation of the film. It can be measured by the distance from the medial end of each clavicle to the spinous process. We have to draw a vertical line in the spinous process and the medial end of the both the clavicle, right and left clavicle, and the distance should be equal. If it is increased in the one side, it is rotated. And one should barely see the thoracic vertebra behind the heart. So this X-ray is a little more over penetrated film. We have to barely see the vertebra behind it. And one needs to see both, identify the costophrenic angle and the lung abscess. Here, so the X-ray should be like that. The costophrenic angle and lung abscess should be clearly seen. And in a normal X-ray, this is a spinal processes. You can identify the trachea. Trachea can be traced to lower level. This is the carina, and the carina angle should be between 60 and 100 degree. And this is the bronchial bifurcation.
Please check this slide also. Actually, is it the right slide?
Yeah, ma'am. Please kindly tell whether we should change the slide or not, please.
It's not seeing this normal chest X-ray slide. I am seeing the normal chest X-ray slide.
Which one you want, ma'am?
This is 9th slide.
9th slide. Okay. First.
Okay.
In the 9th slide.
From this.
9th slide. Okay. This is a spinous process. This is a trachea. Trachea can be traced to the left and right bronchi. You can see the carina here. Carina, the usual angle is 60 to 100 degree. And if it is increased, it can be this hilar mass. This carinal mass can be there. This is the tracheal bronchial bifurcation. This is the left bronchus, and this is the aortic knob. This is the aortic knob, and this is the hilum. And this is the hilum, and this is the posterior and anterior ribs. This is the right atrium, and this is the diaphragm. There is the breast soft tissue shadow and the gastric air bubble. So this is the normal X-ray. And the 10th slide, this is the airway. Airway narrowing can be seen here. It's seen usually you can see the airway narrowing. This is the airway narrowing, and you can see this in croup or tracheal stenosis. And the next slide. Ensure trachea is visible in the midline. Usual position of trachea is the midline. Trachea gets pushed away from the abnormality. Example in pleural effusion or tension pneumothorax or mediastinal mass. In this, this is due to the mediastinal mass. Trachea is pulled away from the abnormality, and this trachea gets pulled towards the abnormality in case of atelectasis or collapse. This is the 12th slide. Atelectasis or collapse, and in fibrosis and in pneumonectomy, trachea usually pulled towards abnormality. And this is the 13th slide, view of carina. I already said that it is an angle between 60 and 100. This is what? Marvin. Right.
Can you view the slide?
No, no.
I think you have put it in slideshow mode. Not in your presentation, that you close.
Ma'am, the slide is viewable for the rest of the persons.
Okay, please close your slideshow.
Slideshow.
PowerPoint you have to close.
Ma'am, we are sharing the slides, ma'am. You need not share. We are sharing the slides. Okay.
Okay.
Now it's shown as foreign body aspiration. Is it okay? It is foreign body aspiration.
Okay. Now it's okay.
Fine.
Sorry. Okay. This is the, you can see the foreign body here, mainly in the right bronchus. Foreign body here in the right bronchus. Foreign body, we have to check whether there is any foreign body in the X-ray. Next check. So the bones and soft tissue should be checked. The bone here, here we can see the fracture bone. This is the 6th posterior rib is fractured. So in every X-ray, you have to see the whether there is any fracture of the bone, ribs or clavicle or scapula like that. Next. Here subcutaneous emphysema. We can clearly see the here the subcutaneous emphysema and some foreign bodies in here. So if in every X-ray we have to see whether there is, and soft tissue also should be seen. Soft tissue, there can be subcutaneous emphysema. It can be there. Next slide, please. This is usually the cardiac angle. It is 50%. Usually less than 50% is a cardiac. This cardiac thoracic ratio, and if it is less than more than 50 to 55%, it is borderline cardiomegaly, and more than 60% it is cardiomegaly. We have to measure the distance. We have to draw a line, vertical line, and the maximum distance from the right and left side. And this is the cardiac ratio, thoracic ratio. So cardiothoracic ratio is less than 50% usually. Next slide. This is the anterior axillary fold. Sometimes can be there can be confusion with the pneumothorax also. We have to trace the anterior axillary. This is the anterior axillary fold. We have to trace this line. Trace this line. So this is coming outside. So this is the anterior axillary fold. Same in case of this also. This is the anterior axillary fold. Next slide, please. This is cardiomegaly. is usually seen in cardiac failure and pericardial effusion. It's a water bottle like heart. Next. Next.
Next.
This is the mediastinum. Mediastinum is anterior, middle, and posterior mediastinum. You will divide the mediastinum into three parts: anterior mediastinum, middle mediastinum, and posterior mediastinum. Anterior mediastinum sternum to the posterior aspect of the heart or great vessels. This is posterior to the heart or great vessels and lying drawn 1 centimeter behind the anterior margin of the thoracic vertebra. Here the 1 centimeter behind the anterior margin of the thoracic vertebra. Posterior behind the posterior limit of middle mediastinum. So we can clearly see the and this X-ray anterior, middle, and posterior mediastinum division. Next. This is mediastinal widening. This is a case of lymphoma. Mediastinal widening can be seen in case of this lymphoma, thymoma, all cases. Next slide. This is a hilar mass seen in lymphoma. Next. This is an aortic aneurysm. This also there is mediastinal widening aortic aneurysm. Here the aneurysm. Here the aortic knuckle is usually seen. The aneurysm is there. So mediastinal widening is there. Next slide. And this is pneumothorax. You can clearly see the collapsed lung margin. Here is the collapsed lung margin. And this is the pneumothorax. Next. Pleural effusion. We can see that there is a homogeneous opacity. Homogeneous opacity here, and this is a moderate. This is an example of moderate pleural effusion. Next slide. And blunting of the costophrenic angle can be seen there. This is a pseudo tumor usually seen in cardiac failure and all. Trapped fluid collection within the fissure. This is the fissure. Smooth or lenticular contour is there. This is the pseudo tumor. And the pleural plaques, this is a pleural thickening. As you can compare the right side and left side. Here the pleura is not thickened, but here the pleura is thickened. Usually the pleural thickening is more seen in malignancies, mesothelioma, and metastatic disease. This is a case of mesothelioma. This pleura with the pleural thickening. Next slide, please. This elevated hemidiaphragm. You can see usually the right diaphragm is elevated slightly, but elevated hemidiaphragm is usually seen in diminished lung volume as in restrictive lung diseases, some case of phrenic nerve palsies, eventration of diaphragm, subphrenic abscess, hepatomegaly or splenomegaly. This can be seen in elevated diaphragm. And pneumoperitoneum. This is a case of pneumoperitoneum, that is in cases of perforated viscous, that is in post-operative cases, trauma and peritoneal dialysis, this pneumoperitoneum can be seen. You can see the air shadow here. Next slide, please. This is a chilladity sign, colon between. You can see the hostrations also. This colon between the liver and diaphragm. Here the liver and here the diaphragm, and the colon is in between there. The hostration is also seen here. This is the chilladity sign. Next slide. So we can divide the lung fields into three usually: upper zone, mid zone, and lower zone. Upper zone is this is the first anterior rib. This is the second anterior rib. So we can draw a line below the level of second anterior rib, and above that is upper zone. Here the fourth anterior rib. Here the above the this line. In between is the mid zone, and this is a lower zone. So second rib lower side and fourth rib lower side. So we can divide upper zone, mid zone, and lower zone. Next. The position of upper lobe, right upper lobe in lateral view and the PA view. This is the right upper lobe position, and this is the right upper lobe in lateral view. Next slide. This is the right middle lobe, and this here in this here is the right middle lobe. In the right middle lobe, when there is collapse, there will be a triangle. The shadow will be like a triangle. Next slide. This is the collapse, right middle lobe collapse, and this is this can be seen Here the collapsed segment, the right middle of collapsed segment can be seen. Here, there will be collapse of the middle lobe, a triangular shadow. Okay, next slide. Here is the right lower lobe, and in the lateral position, the right lower lobe here. Next slide. Left upper lobe with the lingula. This much portion is with the left upper lobe with the lingula. And here in the lateral position, left upper lobe with the lingula is this much. And left lower lobe. We have to identify the lesions, where the lesion is. So we have to know that where the position of the upper lobe, middle lobe, lower lobe, etc. So the left lower lobe position is this much, and left lower lobe in the lateral view is this. Next please. This is a case of horizontal fissure thickening. The horizontal fissure is thickened here. Next slide. Here we are seeing the Silhouette sign. Silhouette sign means usually the borders are clearly seen. The heart border is clearly seen. If there is a lesion here, the borders cannot be clearly seen. So there is a lesion in the same plate, so we cannot see the border. So if we cannot see the border, it is seen as it is said as a Silhouette sign. This is a typical example of Silhouette sign. We cannot see the clear border of the left heart border. This is a golden S sign. Golden S sign is usually it's a reverse S sign usually. Reverse S sign. This is the minor fissure. Minor fissure is collapsed upwards. Minor fissure is collapsed upwards, and there is a hilar mass. Hilar mass with upper lobe collapse. It is in these cases you can see a reverse S sign. This reverse S sign. This is the golden S sign. Next slide.
I think, ma'am, sorry to interrupt. I think the time we are running short of time, so kindly, you can take 1 or 2 more minutes. Kindly make it fast. Dr. Benny, please note.
Next slide. This is a case of alveolar opacities. This is pneumonia. A rare bronchogram is seen. Next slide. This is a air bronchogram. Here the air bronchogram is seen here. Next in the slide, the CT. Next slide. CT picture, air bronchogram is clearly visible. Next slide. Here is a case of bronchopneumonia. Next slide. Here pulmonary nodules are in most cases in metastasis. Here is a pulmonary nodules in aortic aneurysm. Next slide. This is calcification usually seen in a silicosis slide. Silicosis. Next slide. This is a popcorn calcification usually seen in hamartoma. Next slide. This is an abscess. You can see in TB, carcinoma, lung mets, etc. Next slide. This is a cavity wall. This is a cavity. Next slide. This is bronchiectasis. Next slide. This is lung collapse. Next slide. This is ARDS, bilateral homogeneous this with the ground air bronchogram is seen. Next slide. This is pleural effusion versus consolidation. Here air bronchogram needs this is homogeneous opacification. Next slide. What is this? This is a miliary shadow. Miliary shadows less than 2 millimeter in diameter. This is a case of miliary tuberculosis. Next slide. This is metastasis, cannonball appearance. Next slide.
Can you conclude?
This slide is hydropneumothorax. Next slide is thanks. Thank you.
Thank you for an excellent presentation. Actually, you have covered most of the X-rays except COVID, I think. Nothing to worry. Actually, the COVID is one of the most commonly discussed topic now. Actually, excellent presentation. Thank you.
Bilateral ground glass opacities that usually seen. Bilateral consolidation. Usually we have all X-ray. These patients have bilateral consolidation or bilateral ground glass opacities with one-side consolidation also there in some cases.
Okay, thank you. Thank you for an excellent speech. Next topic, we are moving to the next topic. It is a 2D echo. How to interpret it? This topic is dealt with Dr. Anand Marthandapille. Actually, he is a very close friend of me, and he is a consultant interventional cardiologist and electrophysiologist at Anandapuri Hospitals and Research Institute, Trivandrum. He is an American board certified interventional cardiologist and heart transplant, fellowship in interventional cardiology, then fellowship in cardiac electrophysiology, and fellowship in cardiovascular medicine, then fellowship in heart failure and cardiac transplantation. And he is an MPH holder from University of Illinois, Chicago. Welcome to you, and for this excellent this presentation.
Thank you, Dr. Benny. I'm trying to share my presentation. Okay, now it is coming up. Thank you for that kind introduction, Dr. Benny, and it is good to be back with friends, Dr. Shabir. Thank you for the opportunity. Are you able to see my slides?
Yes.
Yes.
Oh, okay, very good. And my audio is reasonably okay?
Yes.
Okay, I'll try and keep it short as it is a 15 minutes talk. I had done the same one last year also. I'll be talking on cardiac echo basics from a clinical perspective. A very basic review on an echo and how to interpret an echo report. So gone are the days when physicians would just send the patient to the cardiologist and have the cardiac issues taken care of without them knowing what is happening. Now it is a multidisciplinary approach. The physicians are very closely involved in ongoing cardiac care as well as follow-up of these patients. So because of which getting to know some basics about the echocardiogram will go a long way in terms of a comprehensive management of these patients as far as the internist and physicians are concerned. So when do you most commonly request for an echocardiogram? The most common situation is when there is a murmur, a pansystolic, ejection systolic, or a mid-diastolic murmur corresponding to a mitral regurgitation, aortic stenosis, or mitral stenosis. The second scenario is when there is a clinical suspicion of heart failure. Patients having exertional dyspnea, JVP is elevated, peripheral edema, you're suspecting systolic or diastolic dysfunction, and you want to know what the EF of the patient is like. Third one is coronary artery disease, when patient already has Q waves, as Dr. Arun had very nicely described in his talk, suggestive of old myocardial infarction. This could be a diabetic patient who might have had a silent MI in the past, and now coming with probably angina or heart failure. You want to get an echo and see if there is evidence of a myocardial infarction in the past. Hypertension, probably the most common cardiac disorder. A long-standing hypertension patients should have an echo to find out what degree of left ventricular hypertrophy they have and if they have any diastolic dysfunction leading to diastolic heart failure. Pulmonologist commonly wants to do an echo if the dyspnea is out of proportion to the pulmonary findings. And even in lung patients with chronic COPD and interstitial lung disease, you want to know if there is any evidence of pulmonary hypertension or right heart failure. So these are common situations when an additional echographic input is required in order to correlate the clinical scenario. I'll keep it simple as far as the echo report is concerned. The key things you need to know about is about, most importantly, the left ventricle size function. If there is evidence of regional wall motion abnormality, which we will talk about, evidence of LVH and diastolic dysfunction, at least a basic idea about the mitral and aortic valve, and evidence of right heart failure and pulmonary hypertension. So just to give you a sense of what we see in an echo lab, this is a parasternal long axis of the heart. You can see the left ventricle here, the right atrium, the left atrium, mitral valve in between, aortic valve in between, aorta, and this is part of the right ventricle. This is a parasternal short axis, a cross section. The heart looks like a donut, as you see here. in the still images and in the pathology specimen. You can also appreciate the mitral valve here. This is what is called as a four-chamber view. As the name indicates, you can see all the four chambers, LV, RV, LA, and RA. So this is just to give you a visual appreciation of what we see in the echocardiography lab. So let's start with the left ventricle. All of us are, the key number we want to know about is the LVEF, or the left ventricular ejection fraction. You need to know what the normal is, which is around 55 to 65, and degree of diastolic dysfunction. And EF corresponding to that is also important. Just remember 35, 45, and 55. Less than 35 is severe, 35 to 45 is moderate, and 45 to 55 is mild systolic dysfunction. So you should be able to correlate the degree of symptoms with the degree of LV dysfunction. Also important is the left ventricular size. Because long-standing LV dysfunction can lead to LV dilation and remodeling, which is a very bad thing for the heart, going into progressive heart failure. And you need to have a sense of what the normal size of the heart is. So dimension-wise, heart should be less than 5 centimeters, which is the internal diastolic diameter of the heart. And in males, it should be less than 5.5. So chronic heart failure patients, if the heart size is around 6, 7, and 8, means that they are having very advanced forms of heart failure. Also important, this is again the cross section of the heart with these segments, anatomical segments, anterior, inferior, lateral, and septal. And why it is important to have an idea is because that corresponds to the blood supply, just like how Dr. Arun had described about the myocardial infarction of each of the territories. The anterior wall is supplied by the LAD, the inferior wall by the RCA. So let's talk about regional wall motion abnormality, which is a common term that you will see in the echo reports. As the name indicates, it indicates a regional problem in contractility of the heart, usually because of a myocardial infarction. And there is usually a very detailed explanation of the regional wall motion. We will talk about which segment is affected, which will corresponding to which artery is affected. The extent, base, mid, and apex of the heart is what you see here. So how extensive is the regional wall motion? And also we will talk about what is the degree. So we talk about hypokinesis when the contractility is less, and that is also classified into mild, moderate, and severe hypokinesis. If the wall is completely infarcted, it is called ekinetic, and if it is moving the opposite direction, it is called dyskinesis. So, and this is also has to be correlated with the total systolic function of the heart. So just to give you a visual appreciation of the regional wall motion, this is a normal heart that we saw before. Here, if you look at the anterior wall of the heart, you see that this wall is not moving much. So this will be an anterior regional wall motion abnormality corresponding to a myocardial infarction of the anterior wall from an LAD artery occlusion. Again, a cross section, you can appreciate that the anterior wall is not moving much. Long axis views corresponding to the same echo, showing a sluggish anterior wall. So you would also be familiar with another term which is called global hypokinesis, which, as the name suggests, all walls of the heart is not contracting well. Regional wall motion is only one or two of the walls, either anterior, inferior, or lateral. Global means all the walls are equally not contracting, and more commonly it is associated with a non-ischemic dilated cardiomyopathy, which tends to uniformly affect all the walls of the heart. So all the walls are equally hypocontractile. On the other hand, if there is a regional wall motion, it is more suggestive of a localized hypocontractility because of an infarction or ischemia due to one particular territory. So these two kinds of, this will give us a clue about the etiology of the LV dysfunction. So with wall motion is most likely ischemic cardiomyopathy LV dysfunction. Global is more likely a non-ischemic, but these are not exclusive, but I'm not going into the details. The next important thing to look at is to quantify the left ventricular hypertrophy in a patient with long-standing hypertension. Normal thickness is less than 11. Thickness, as it increases, you'll have mild, moderate, severe left ventricular hypertrophy. Why is it important? The thicker the heart gets, the stiffer it becomes, and that is what leads to heart failure with preserved ejection fraction, or a HEF, which is a increasingly understood entity, particularly with patients with diabetic cardiomyopathy. Also, we are seeing heart failure with preserved ejection fraction. A lot of data has come out with the SGLT2 drugs. Most of these patients have actually diastolic heart failure. So that is an important type of heart failure which we are increasingly recognizing, and most commonly it is because of long-standing hypertension leading to LVH, leading to stiffness of the heart and causing heart failure. And that is also measured using an echo. The diastolic function is quantified as grade 1, 2, and 3 depending on the severity, and this is assessed from the mitral inflow. So most commonly you will see these gradations. And you can correlate that with the degree of hypertension, diabetes, and the heart failure symptoms. Moving on, we'll talk a little bit about the valve. Before going into the details, it's important to know what to look for when the patient is having a valvular lesion. So one, you want to assess the degree of valvular leak or regurgitation and valvular stenosis. But above that, you need to know what the impact of the regurgitation and the stenosis is on the left ventricle. So the regurgitant lesions like mitral and aortic regurgitation causes unnecessary back and forth flow of the blood, leading to what is called as a volume overload, which leads to LV dilation, systolic dysfunction, and systolic heart failure. On the other hand, aortic stenosis, where the heart is pumping against a high pressure because of a stenotic valve, causes what is called as a pressure overload, and that on the other turn causes hypertrophy rather than dilation, causes diastolic dysfunction and diastolic heart failure. So this is what you want to know when you're sending a patient with valvular lesion. One, want to know the degree of valvular problem and what the impact of the valvular problem on the heart is. So let's quickly look at a few of these. Mitral regurgitation. Looking at the valve, you will know why the valve is leaky. It could be a mitral valve prolapse or a rheumatic valvular disease. And you should know what the degree of valvular leak is, as well as the impact on the heart. A quick echo clip here showing a very floppy mitral valve, as you see here, and a very bright jet which is coming back into the left atrium, suggestive of severe mitral regurgitation due to a mitral valve prolapse. Mitral stenosis, all of you are familiar with advanced rheumatic valvular disease. Again, you want to know the degree of stenosis of the valve and other potential causes such as degenerative or congenital cause for the mitral stenosis, and what the impact on the heart is. So when the valve is stenotic, there is pressure overload in the left atrium, and the left atrium looks very dilated as you see here, and there is also risk of atrial fibrillation and thrombus formation in the left atrium. Aortic stenosis, again, you want to know why the cause of stenosis. It could be degenerative senile stenosis or a bicuspid or rheumatic valve, and what is the impact on the heart. Echo will give you quantify the degree of thickness and calcification in the aortic valve, and as well as the degree of stenosis. Aortic regurgitation, why is it happening? Either because of a bicuspid valve, a rheumatic valve, or infective endocarditis. Severity of the regurgitant lesion, as well as the impact on the heart. Here again you see a floppy aortic valve with blood leaking back into the left ventricle. I'm
Sorry to
almost
interfere.
done.
2 more
Yes, I am
minutes.
done. This is my last slide. Pericardial effusion is a common finding, commonly seen in patients with hypothyroidism, as well as concomitant with pericarditis. You can have a pericardial effusion. Thank you.
Thank you, Dr. Anand, for an excellent presentation. Actually, echo is one of the commonly used tool for most of the cardiology diagnosis, and also in emergency setup, a lot of echo diagnostic tools were introduced nowadays. Thank you for the excellent presentation. Any questions regarding? next, I am passing mic to Dr. Arun for introducing the next speaker.
Thank you, sir. The next speaker of the day is another close friend of ours, Dr. Anusha V, another product of Trivandrum Medical College. She was an MBBS 1998 admission student of Trivandrum Medical College. After her MBBS, she completed her post-graduation in ophthalmology from AIIMS with New Delhi with gold medal. And she is now currently working as a vitreoretinal surgeon in Shankara Eye Hospital. And she has numerous publications to her credit in index journals. She's a wonderful speaker, a great teacher. I have great pride in introducing Dr. Anusha V for her presentation on fundus examination. Practical tips. Over to you, Dr. Anusha.
Hello, can you hear me? Am I audible?
Yes, very much.
Thank you, Dr. Arun, for that introduction. And at the very outset, I would like to thank my batchmate, my friend, Dr. Shabir, and would like to congratulate him for this online webinar, which has been excellently organized. And I would also like to thank him for making me a part of this conference or webinar year on year. So I'm here today to talk about the basics of fundus examination. Why is it really important? The fundus examination is important because it gives us a look into what is really happening inside the body. So I would concentrate basically on diabetic retinopathy. Are my slides visible? Are my slides visible?
Yes, visible.
Yes.
Please put it in full view.
Yeah, is it okay now?
Yeah.
Perfect.
Okay. So we have some audience here. I'm taking this call from my hospital. So we've got our first year DNB students here also. Well, so over to the topic. The basics of fundus examination, as I said, I would concentrate more on diabetic retinopathy because that is what is relevant as far as this conference is concerned. Just a minute. Diabetic retinopathy is responsible for 1.8 million of 37 million cases of blindness throughout the world. It is also one of the most common cause of new cases of blindness among adults 20 to 74 years of age. And during the first 2 decades of disease, nearly all patients with type 1 diabetes and over 60% of patients with type 2 diabetes have retinopathy. So that is the reason, that is why this topic becomes more important, because as diabetologists, if you screen the patient for diabetic retinopathy and refer to us at the earliest, early institution of treatment will prevent blindness. So before we know what is abnormal, we need to know what is normal and how we look at it. This is how the optic nerve looks like. These are the vessels arising from the optic nerve and dichotomously branching. And this is a fovea and this is a macula, which is responsible for vision. This is how in historical ages, this is how fundus examination used to be carried out with just a mirror to focus to converge the rays and the examiner holding another mirror. But thanks to the recent development, why isn't it not moving?
Yes, it is moving.
Yeah. So now what are the different methods of examination? Now that we don't need to really hold a mirror in front of the patient, but so what are the other methods? One is a direct ophthalmoscopy. The second is an indirect slit lamp biomicroscopy, where we use a slit lamp and a handheld lens to sort of converge the rays and observe the retina. And the third is an indirect ophthalmoscopy. So this is a direct ophthalmoscopy. Why is it called direct? It is a direct ophthalmoscope as the image forms directly on the retina and there is no intermediate image akin to that seen in an indirect ophthalmoscope. So what you see is what is formed as opposed to an indirect ophthalmoscope where it is an indirect image. Charles Babbage was the first one to develop his practical ophthalmoscope. It was just a simple piece of mirror with a silver patch rubbed off from the center to make it see-through. And von Helmholtz is the first one to have described the optical working of an ophthalmoscope, and he is recognized as the inventor of the direct ophthalmoscope that we use today. Now, this is how we use it. So you need to go close to the patient. So obviously in this COVID era, we are not doing direct ophthalmoscopes as frequently as we used to do before. Now here, the light source from the batteries is reflected at 90 degrees using a mirror placed in the head portion. So this is how the ophthalmoscope is. And there is a mirror here and there's a source for light. When you turn on, the light goes on and you can sort of focus the light into the patient's eye. And the examiner looks through the hole. So this is how, before we know the abnormalities, again, it is important to know the instrument. All the diabetologists, medical specialists may be walking around with a small pocket retinoscope, ophthalmoscope, and this is how it looks like. So the front view, it has a reading window and it has the diopter disc to adjust for the refractive status. And this is a back view which has a reflecting mirror, and this is the aperture to adjust the light source. So the illumination system, and there's an observation system. The illumination system consists of a light source, condensing lenses which are inbuilt, reflecting prisms, and a series of apertures. The observation system consists of a peephole and a bank of spherical lenses, that is which is in the dioptric disc. So again, so the lens, you have to keep adjusting this till you get a clear focus. This goes on to the body, and this is the bulb in here which connects to the rheostat. There's a concave mirror with a hole in the center, and this is a peephole through which the examiner views. And these are all the different sizes. You can turn this so as to select the light, the filter, the grid, and all that. So this is, yeah. So this again is to adjust the power. This is to adjust the aperture, and this is to adjust the power. Now, what is the principle? From the observer, once you throw the light, the correcting lens focuses the light onto the patient's eye. The patient's eye reflects the beam of light. It is converged by a prism, which is focused again by a condensing lens, and that's how it works. So the methods of ophthalmoscopy is a distant direct ophthalmoscopy and a direct ophthalmoscopy. So before you go on to a direct ophthalmoscopy, you first see from a distance of 25 inches to see what the glow is, whether you're getting a red glow, whether the glow is altered. So the patient has cataract, or if the media is hazy because of a vitreous hemorrhage, then the glow may not be red. So you view the ophthalmoscope from 25 inches, you view the eye from 25 inches and look at the glow. If it's a red glow, you move on to the direct ophthalmoscope and you move closer to the patient. So first you look far away, and once you see a good glow, you go closer to the patient. The closer you go, you start adjusting your the dioptric disc so as to attain a clear view of the disc. So the steps would be to explain the procedure to the patient. You dim the lights in the room, and to examine the right eye, you must stand on the right side of the patient. Use your right eye to look into the patient's right eye, and for the left eye, it's the left eye. You stand on the left side and use the left eye. Now you select 0 on the lens dial. Place your index finger on the lens dial to enable you to change lenses quickly. And you ask the patient to look straight ahead and focus on an object in the distance. And then keep the reflex in view and move slowly closer to the patient. When you are about 5 centimeters away from the eye, the optic disc would come into view. So when the patient is looking straight ahead and you are focusing with your retinoscope, you slowly move your dial and go close to the patient such that you see the optic disc. Once you see the disc, you will see all the vessels emanating from it, and then you can see the discs and you can finally come to the macula. So when you see that optic disc, this is how it will look like. This is a normal optic disc. You look for the size, the shape, the color, the margins, and the optic disc cup to disc ratio. You can see that it is widened in a case of glaucoma. So this is a glaucomatous disc, and this is a normal disc. This is a normal cup, which is around 0.3:1 is a ratio of the cup to the disc. And here you can see the disc is totally obliterated, and what you have is a total cup. Then you observe the blood vessels. You observe the diameter, the tortuosity, the color, the crossings, the light reflex, and also the AV ratio, which becomes more important, especially in case of hypertensives. The macula appears darker. It is around 2 disc diameters temporal to the disc. And this is what it is. The magnification that is offered by the direct ophthalmoscope is around 15 times. And you see about 15 to 70% of the fundus. So now we come on to some of the abnormalities that we might frequently encounter. Now this is, all of us would have learned earlier on that in hypertensive retinopathy, we get some AV crossing changes because of arteriosclerosis, which kink the vessel. So here there's different hypertensive retinopathy changes, you see that the arteries are sort of thickened off. You have a silver wiring or a copper wiring. You have this kinking of the veins. The veins have been kinked by the overlying artery. Again, you can see some arteriovenous crossing changes here as well. And this would give an idea that the patient has some evidence of hypertensive retinopathy. This especially becomes very important, especially in pregnant females when they look for effect of PIH on the eye. The next is the age-related macular degeneration. It's again a very, very frequent problem is seen in elderlies. So you can see a lot of abnormalities here. There is some blood here, and there's some exudates here. And this is another form wherein you can see multiple yellowish deposits all over the fundus. So this is the wet form, what we call, and this is the dry form, again, which is responsible for visual loss. Early detection of all this would help us in initiating early treatment and again preventing visual loss. And hence I just covered all the important ones a little bit. Now we move on to diabetic retinopathy per se. What we need to know is whether the patient is suffering from any diabetic retinopathy at all, or if is it non-proliferative, in which case it could be mild, moderate, or severe, or is it proliferative, or does the patient have any macular edema, which is causing a decrease in visual loss. So this is a patient with mild NPDR, and this is what you would see. So once you ask the patient to stand in front of you, explain the procedure, ask him to look straight, and then look at the disc, and then move away from the disc onto the vessels. Along the vessels, you would see these small, tiny dots, red dots, and these are the microaneurysms, which represent the earliest stage of diabetic retinopathy. Since diabetic retinopathy and the kidney disease generally coexist, so with the onset of diabetic retinopathy, it is mandatory to screen the patient for a kidney disease as well, a diabetic nephropathy. Now, this is a slightly more advanced stage of diabetic retinopathy where you can see there are small white, these red dots here, but along with that, we also have some hemorrhages. So these red spots are the hemorrhages and these yellows are the exudates. So the diabetic retinopathy has progressed one stage up and it is now called a moderate diabetic retinopathy when you see these hemorrhages around. This is also a part of the diabetic retinopathy. These yellowish lesions are actually what we know as the cotton wool spots. They represent infarcts in the retinal nerve fiber layers, and they also are a part of the moderate diabetic retinopathy disease spectrum. Again, you can see that the exudates are there all over the fundus. You can see hemorrhages here, again exudates. So these are all cotton wool spots, hemorrhages, and this is what we know as a succinate retinopathy because of those microaneurysms which are leaking. Now, then we have the severe or the very severe NPDR, which is a little ominous, and it signals the onset that the patient can move on to a proliferative diabetic retinopathy very quickly. So at this stage, we really need to intervene, evaluate the patient systemically, as well as from the ocular point of view, and initiate treatment that would be pan-retinal photocoagulation or ocular laser. So this is what you see as some vessels which are abnormal, which are arborizing. There is no definite pattern to it, to which we call as an intraretinal microvascular abnormality. So there's a 4-2-1 rule where if you have 4 hemorrhages and microaneurysms in all 4 quadrants, if there is venous beading in 2 quadrants, or if there are these intraretinal microvascular abnormalities in at least 1 quadrant, it could contribute to a severe or a very severe NPDR. So this is a venous beading which I was talking about, and you can see these very, very fine and tortuous vessels, which is actually the IRMA or the intraretinal microvascular abnormalities. You can see the venous beading also here. So this is how venous beading looks like. This is another patient, a diabetic patient with a visual loss, and what you would see is the presence of these hard exudates, and this is responsible, along with the amount of fluid, responsible for visual loss, and this contributes to diabetic macular edema. Again, this is an investigation that we generally do for patients with diabetic macular edema is a fundus fluorescent angiography, wherein you can see these small leaking aneurysms here. What you can see as these small red spots are now throwing up fluid, which is responsible for the visual loss in macular edema. The last, or a serious manifestation of diabetic retinopathy is a proliferative diabetic retinopathy, where you could have a neovascularization of the disc. You could have the presence of new vessels elsewhere on the retina, some pre-retinal hemorrhages, vitreous hemorrhages, and retinal detachment. So this is how a proliferative retinopathy looks like. And this is the presence of new vessels over the disc. You can see them proliferating all over. They look very, very angry. The presence of new vessels here. Again, a lot of vessels arborizing randomly. Again, here you can see these hemorrhages. These vessels they're very, very flimsy. They can bleed at any time and can lead to visual loss. You can see these vessels have now bled, and the patient now has some amount of bleed which is developed here and here. So this contributes to proliferative retinopathy, which is again a very advanced stage of diabetic retinopathy. Another manifestation is a vitreous bleed, where it is just not confined to beneath the retina, but comes out, the blood comes out into the vitreous and leads to vitreous hemorrhage and visual loss. This is a form of tractional retinal detachment, again an advanced stage of diabetic retinopathy where the retina itself is detached, and you can see these numerous angry looking vessels which are pulling onto the retina and causing it to detach. Again, the presence of new vessels in the iris, again, is an end stage contributing to glaucoma and an absolute eye, which is the neovascular glaucoma causes the eye to become painful and red, the intraocular pressure rises, and it leads to loss of vision. So again, to summarize, this is a relatively good looking fundus. You can see these small red spots here and there occasionally. So it would be a mild non-proliferative diabetic retinopathy. Here, slightly more than that, but you see some hemorrhages, some white dots, some hard exudates scattered all over. So this would be moderate diabetic retinopathy. There are some flame-shaped hemorrhages all around the fundus in almost all the quadrants. So this would be a severe NPDR. And this is what would constitute a macular edema, where you can see these hard exudates around the macula and the fovea. In this page, this is the kind of patient who would present with visual loss. The challenging part of it is that patients with proliferative diabetic retinopathy with the NVD might still have a vision of 6/6. So unless the patient is screened early, the patient can bleed at any stage with resulting in visual loss. So again, this is a patient with a florid NVD, and here you have vessels elsewhere. So this is NVE. There are a lot of hemorrhages here. So there is a pre-retinal hemorrhage, and it has caused severe traction on the retina, pulling it, resulting in a tractional retinal detachment. So another method of evaluating is an indirect ophthalmoscopy. That was a direct. Again, this is used to screen for diabetic retinopathy after dilatation. Here you use a headband, you use a condensing lens, and it is used to foresee inside the eye. There are other modalities to image the eye, such as a fundus fluorescent angiography, an optical coherence tomography, which evaluates the retina. It's like a it's like a CT scan of the eye, which gives you a slit of the different sections of the eye and evaluates for the presence of any underlying disease. An ultrasound, which picks up the presence of any diabetic vitreous hemorrhage. Now, this is how a patient is treated with proliferative diabetic retinopathy. We need to treat with laser, and these are how the laser spots are administered, and this is how it looks like. So these are the fresh laser spots, these white spots, and these are the black marks are the old laser marks. So this is how a patient treated with diabetic retinopathy or proliferative diabetic retinopathy looks like. The treatment would involve the presence of anti-VEGF injections or surgery, which can be done only if the patient is detected early or screened early, referred early, and the treatment is initiated early. So what's my take-home message is, all of you there who general medical practitioners, diabetologists, please do get a retina examination to see what diabetes is doing back there, because it's important to prevent complications, which can be done with early detection, early treatment, even when asymptomatic, by routine fundus examination following referral to an ophthalmologist. Thank you so much. Thank you so much, Shabir, once again for this opportunity. Happy to be a part of this webinar. Thank you.
I think Arun is. Thank you, Anusha, for an excellent presentation.
Thank you, Dr. Ben.
I think Arun is not there. Any questions regarding, any doubts? I think there is no doubts regarding. Actually, your presentation was an excellent narration of most of the doubts regarding this examination. I think you have covered excellently well in that area. So we can move to
Okay,
Sure.
thank you,
Thank you.
Dr. Benny, and thank you, Dr. Benny and Dr. Arun Bina, for sharing that session. And next, we will go to a very important session, which is about food and diabetes. And to chair that very important session, let us invite Dr. Mahesh Sukumaran, who is a senior consultant endocrinologist in National Hospital, Trivandrum. Over to Mahesh.
Hello. Hello, Shabir, am I audible?
Yes, you are audible, Mahesh.
Okay, and okay.
Your video is not visible.
Video is not visible.
Video.
Okay. Now it is visible. Start video. Okay. Okay, no problem. Video.
You can
video is
unlock
not
the video.
I can. Yeah, I did that, but it is not coming.
No problem. You can continue.
Okay, can continue. Thank you, Shabir, for making me a part of this diabetic today, 2020. Our next topic is one of the important topics, food and diabetes. One of the toughest problem we are faced with when treating diabetes patient is to find those patients early enough to be able to save their feet. Usually what happens is this patient present to us with a full-blown ulcer or bone. Frequently it is infected and many times we have to take this patient right away for surgery. And it is way too late. So today we have two eminence in the field of diabetic food management, Dr. Ajit and Ajay Kumar sir. So Dr. Ajit is a chief consultant in Department of Hyperbaric Medicine and Diabetic Food Care, SP Fort Hospital. Director and consultant physician, Dr. Ajit, Total Diabetic Care Center, Trivandrum. And he's a DGCA pilot medical examiner. He will be speaking on diabetic food, the newer therapeutic modalities. Over to you, Dr. Ajit.
Slide.
A very good evening. I think, am I audible?
Yes, audible.
Okay, thank you. Very good afternoon. First of all, I think today is a sad day for all of us because we had faced two tragedies yesterday. I think with that note, I would like to thank the Diabetes Today team, especially Dr. Sabir, for inviting me for this topic. I think thanks for the nice words by Dr. Mahesh, one of my dear friend. I think we'll be discussing about the topic which is relevant in our day-to-day practice. The title is diabetic food, newer therapeutic modalities. But in the field of management of diabetic food, I think the newer therapeutic modalities are only few in last 4 or 5 years. Whatever we are using for the last 20 or 30 years, we are just modifying it in the what we call with the genetic engineering technology and using it for the day-to-day management of diabetic food. So as Dr. Mahesh said, it is one of the real issue in our day-to-day practice. The famous article which came in Lancet, it says that every 30 seconds a lower limb is lost due to the diabetic consequences. So whenever we are treating a diabetic food, our aim should be whether we are focused on whether only addressing or are we managing, or our aim is to heal the wound. So these are the things, because it may be the range of diabetic food may be from a small ulcer, trophic ulcer, to ischemic resulting in a amputation, or sometimes it may be a severe diabetic foot infection with leading into sepsis. So this is the burden of diabetic foot ulcers. I think the third line is very important. A person with diabetes has got 25% of chance of developing diabetic foot ulcers, maybe a small ulcer, maybe a moderate or a severe kind of an infection in his whole lifetime. And it is one of the leading cause for the non-traumatic limb amputation all over the world. And it says that 25% of diabetes related admissions are due to a diabetic foot infection. The reality of diabetic foot is this: the poor fellow has already been underwent below knee amputation, and the next limb is also getting gangrenous, and it is easy to do an amputation, but the later evidences says that as far as possible, by whatever the available method, if we can save at least by the heel pad region and prevent a major amputation in the form of a BK amputation or an above knee amputation, we are doing benefit for the patient. This shows the consequences of wound. You can see that the 5-year mortality is, if you compare with the leading causes of malignancy, you can see the 5-year mortality is associated with ischemic ulcer or amputation or neuropathic ulcer. And subsequently, once an individual undergoes an amputation of a limb, there is high chance that he will develop a cardiovascular event in the next 3 to 5 years time, and that may cause severe damage, and we may lose the patient. This is a triangle of the wound assessment. Basically, I won't go into the basics because it is basically we are concentrating on the available newer modalities of treatment. There, any patient comes, you just assess whether, irrespective of your specialty, whether you are a surgeon or a diabetologist or an endocrinologist or a physician, you can manage diabetic foot. There is no issue, but you should know the basics well. So look for the wound bed, look for the type of the tissue, whether it is a clean granulating wound or a slough is there. Assess the severity of the infection. Wound edge, you should know whether it is a macerated or a dehydrated thing. Peri-wound area, that is very, very important. Peri-wound, examination of peri-wound area is very important because if there is a callus or anything is there, you have to go for a proper debridement of callus. Unless the callus will always lead to future generation of ulcers. So debridement of callus is very important. These are the wound bed areas, is the type, whether it will be a necrotic as predicted in the slide, it is a ischemic, and then there will be granulating, that is a typical red color, that is granulating, and epithelialization. And you look for the exudate, that kind of the exudate, whether it is a purulent or a mucopurulent kind of a discharge is coming or not, and assess the infection. Whenever you assess the infection, you just ask for any systemic symptoms, whether the patient is having a fever or a tachycardia or nausea, vomiting, or aversion to food or anything. This indicates that it is a severe condition, and you have to be admit the patient, and you have to give the proper treatment. So these are the things you can see. In the left side, it is a macerated wound, maybe because of the high exudation of the wound, and moist content will be very high. Sometimes the second one is a dehydrated wound. You assess the edges of the wound for the moisture level. And whenever we use any dressing material for any wound, our aim is to keep the wound moisture. Then only the wound will heal properly. And this is an example of undermining edge. The rolled edges, this may be seen in, sometimes it may be seen in vasculitic ulcers also. So the wound assessment is very important for your management plan. Based on the wound assessment, whether it is a viable tissue or a non-viable tissue, you go for debridement, and you select the local wound agent which you want to use based on the appearance of the wound bed. So wound assessment is very, very important. Based on that assessment, you go for the management plans. The conventional management of diabetic foot wounds experiences, you keep it clean. As I said, you have to keep it moisture levels correct. You support all the stages of wound healing. Once the slough tissue has gone, the little bit of granulation comes. Based on the changes in the local wound status, you select your modality of treatment, or you can change the what you call the local application agents which is available. The gold standard in management of any diabetic foot, if it is in the sole aspect, it is offloading of the area. You have to offload wound, otherwise it is very difficult to heal. And you treat the infection, you do the culture and sensitivity, that will be the ideal thing. Based on the local available susceptibility of the organism, you go for empirical antibiotics, but once you get the culture and sensitivity, you change the antibiotics according to the sensitivity and pattern. And you debride all the non-viable tissue. Next is, again, it is considered one of the gold standard modality. Wherever or whenever you can revascularize an artery, if it is possible, you do it. Never hesitate to undergo a revascularization procedure, whether it is a peripheral angioplasty or an endovascular procedure or in a surgical bypass. You just do that. because you are saving the limb from amputation. Last but not the least, the most important thing is a proper glycemic control. But but even after you do all these things, it may not be always enough to get a target treatment. So these are the factors which influence healing, because there will be growth factor receptors will be there, the cells will, senescent cells will be there, the biofilm, that is one of the major factors for which is detrimental to the wound healing in chronic wounds, especially long-standing diabetic would we use a lot of local antibiotics. That local antibiotic preparation will promote the generation of biofilms because of the resistance, and this is very, very important, the local tissue oxygen deficiency. So wherever there is hypoxia is there, unless you don't overcome the hypoxia, all the cellular factors won't work, because once the tissue PO2 goes above 40 millimeters of mercury, our cellular function will happen. So you have to overcome hypoxia, you have to overcome the infection, and you have to overcome the other factors, which is the level of certain enzymes, that is proteases and other things, by the local available methods. But the ideal one will be whatever the method you choose, if you can overcome the hypoxia, the wound is, whether it is a revascularization or modern technology that we will discuss in the subsequent slide, overcome the hypoxia. You give importance to overcome the hypoxia, then your wound will heal. These are the therapeutic armamentarium. The dressings will be there. The devices, as I said, a lot of devices are nowadays available. The drugs are there. You can do the surgery. You can use biologics, combination therapies. Is there any potential for a single magic bullet? It will be very, very difficult. It should be a combined approach. That's all the things says the latest article says that you combine the modalities of treatment by a single modality, you won't be able to achieve the target whenever you treat a diabetic foot. So dressings alone won't heal the wounds. It is a complex process, as I said. You assess the underlying and the metabolic, systemic and metabolic factors, the renal function, the cardiac function, the diabetic glycemic control, all these things we just assess the local factors like any deformity or any pressure points or underlying Charcot joint. All these things you have to identify, and you have to go for a combination of treatment, starting from the offloading to the angioplasty. The current dressing categories, because I won't go into the details of each product, but I will say you have the basic dressings of our 3-layer dressing. Absorbent dressings are there, antimicrobials are there, films are there, hydrocolloids are there, hydrogels are there. Each has got its own advantage and disadvantages, but you have to select the following agents based on the wound assessment, as I said earlier. My preferred choices are usually hydrocolloids or hydrogels, and I always try to avoid the use of local antibiotics, unless otherwise it is that indicated. I won't use local antibiotics. Alginates are again good options, and you can give protease modulators. All of things you can use based on the wound status. Other modern dressing materials are, a lot of materials are there in the market, but as I said, these things are little costly. The hemostatic, the gel, semi-gel occlusive dressing, anti-MMP, these are costly things, but you can use the semi-permeable film. Our old generation third 3-layer dressing, foams, alginates are not that costly. This is chitosan. Chitosan, it's a new kids and block. It's a lot of research are happening in a nearby center in Trivandrum, that is Shikitra Periphery Institute, that's in Pujapura. They are doing a lot of research based on the making the chitosan as the base product, and a lot of chemicals are attached to it and keeping it in the local area. It's in the a lot of research are going here, but worldwide literature, chitosan molecules are available. It is good. It will help in the delivery of the regular peptides into the wound sites to promote the local fibroblast growth factors, and it will promote the collagen deposition. This is again nanofibers. The ultrasound scaffolds are made from bioresourceable suture polymers, and this is good to attract the healthy cells from the adjacent tissue and the creation of an acute wound. I don't have any experience of using the nanofiber. Chitosan I have seen. This is again an interesting thing, that color changing dressing in presence of infection. It releases a fluorescent dye, thereby you can know that whether the individual is having an infection or not. If it is there, the nanocapsules will break, and if the toxic bacteria is present, and it will give a fluorescent color by indicating that there is a presence of infection. This is epidermal cell grafting. It is very useful. I think certain companies are providing machines for this. I think one sitting will comes around 8,000 to 10,000 rupees. It's like same like skin grafting. You can see on the right side, the machine will be applied to the donor site, and from there it will be taken. And if you look at the left side, the microderms are applied out the wound with an adhesive sticky bandage. This is how they prepare the donor site, apply the machine, and you harvest the skin in the micro column 60 seconds to 120 seconds. Then you will get some the basic skin follicle cells, hair cells, and you keep it on the as a dressing over the wound. So it is an easy procedure, not that much painful, and you want to have a big wound like what you do it in a split skin grafting. This is the way you can harvest these skin micro columns. You can convert a micro scopic holes will be created, and you can take it and place it over the what you call the sticker, and put it over the ulcer site. So it's very useful. I have done it in few patients. I think it is good, but only problem is sometimes it will be based on the size of the wound. It will be 8,000. It will be going up to 12,000 or 13,000. The topical oxygen therapy has got some evidence to support, because as I said, the overcoming the hypoxia is the most important thing, because it's helping the VEGF growth factor expression, that is the vascular endothelial growth factor help. The promotion of VEGF, and the topical oxygen therapy is useful, and it is helpful in wound closure. Electrical stimulation methods are a lot of methods are available. I have seen this transcutaneous electrical neural stimulation TENS. I have seen, and there are pulsed electromagnetic energy is there, low intensity direct current is there. A lot of things are there, and interestingly, a few days back, one patient had come to me. I have seen somebody is using in North Kerala. One center is using even the what you call the ozone treatment. This is a topical application of platelet-rich plasma. I think 1 or 2 minutes is left. I'll go through the slides. Any doubts we'll discuss during the discussion time. Topical platelet-rich plasma. Again, you can use the dehydrated human amnion or chorion membrane. With all these things that the studies have shown that it is improvement. These are the maggot treatment is there. And stem cell therapy is also there. Stem cell is also useful. And growth factors creams are also there. 30 seconds more, please. Fibroblast growth factor. You can use the TGF beta as a local preparation, platelet derived growth factor also. And EpiFlow transdermal continuous oxygen therapy. The Nanogen Acti gel is also available. And the word about hyperbaric oxygen therapy, it is an intermittent inhalation of 100% oxygen in a specialized chamber. That is what every day I am using for treating the diabetic foot, because it's based on the principle of wherever you increase the pressure, the dissolved amount of oxygen will be more available in the plasma, and that will help in the supersaturation of tissues with oxygen, and by that the cellular workload will be improved. And two ways you can give it is a monoplies and a multiplies. All the components of wound healing will be potentiated by HPOT. Basically, the hypoxia will be overcome. There will be neovascularization, and there will be potentiation of antibiotics. I think all the things will. I think I'm almost finished. And wound care, we have to look for the evidence. Wound care management and dressing and wound healing. A lot of things are available. You choose according to your what you call experience. And word of negative pressure wound therapy is also you can use it for as a wound healing method. And you always go for a synergistic wound healing, and you use 2 or more advanced wound care technology to hasten the wound healing. I'll stop here with this famous statement from Paul Brandt. So thank you all, and once again thanks Shabir and Steve for this wonderful opportunity. Thank you all. Have a good day.
Thank you, Dr. Ajit. That is a very excellent and elaborate presentation. I know it is a very short time, but you have mentioned almost touched all part. I think we will have the discussion after the next topic, or
anyway, no problem. The next topic, okay, no problem.
Okay, so then we will go to the next topic. That is a high-risk food: how to identify, evaluate, and manage. It is our speaker is Dr. Ajay Kumar sir. He is a concerned laparoscopic and bariatric surgeon and diabetic food specialist at Saraswati Hospital, Trivandrum. He is also the consultant at Saraswati Diabetic Food Care Cochin. He is also the professor of surgery at Trivandrum Medical College. He is a visiting bariatric and metabolic surgeon, Badalasama Group of Hospital, Muscat. He is trained from the prestigious Tata Memorial Hospital, Mumbai, in breast surgery. Over to you, sir. Sir, your phone mic is muted. Please unmute it.
Yeah, I'm unmuted.
Am I audible now?
Yes, audible.
Respected chairperson, dear friends, Dr. Sabir, Dr. Ajit, Dr. Preeta, and my dear friends. At the outset, let me express my sincere gratitude for giving me this opportunity, and I congratulate Dr. Sabir and team for the perseverance and making the annual event better and better every year. With these words, I will share my screen, and the topic given to me is high-risk food. How to identify, evaluate, and manage. I have made the presentation in such a way that the practitioner of any walk of specialty will be benefited. Any doctor who treats diabetes, whether it could be a family physician, could be a gynecologist, anybody. So this is a very important concept, that is food at risk. So I will go to the presentation proper. I bring greetings from Saraswati Hospital, Medical College Trivandrum, which is my alma mater. And this is my first slide. Dear friends, just look at the first picture. The very outset, you may miss these lesions. In the second picture, the callosities are so obvious, isn't it? But as a doctor treating diabetes, you should give attention to some points here. See, the food, it is hyperemic. It is pink in color because of the autonomic disturbance and the microcirculation regulation is in chaos. Second, you can see the callosities. One at the fifth metatarsal head, both so heel, then fourth metatarsal head, first metatarsal head, etc. Okay, and the one which you may not notice is the thickness of the pad, the sole pad, the soft tissue of the sole is very thin. Only the skin, bone, and some amount of subcutaneous tissue. So these are the things which make this food a high risk one. See what will happen if you ignore this food? This becomes a bad callosity. See, right? You can see the callosity here. You can see the subcallosal hemorrhage. Can you see that bluish color? Okay. And what will happen if you continue like this? You are going to ulcerate that callosity. What is happening is very simple. Callosity is hypertrophy of the skin, localized hypertrophy. It is just like a pebble inside your shoes. You hit or it will press against the soft tissue and there is bleeding underneath. It breaks down, it becomes an ulcer like this. Okay, right? Is very clear? And see this foot. She is a 42-year-old lady. You can see the scar of a diabetic foot infection treated surgically. This is the dorsal aspect. You can see various other things. You can see severe inconvenience and all. But what about this foot? This foot is nothing but a biomechanically deranged foot. Once your diabetic foot infection is treated surgically by debridement, removal of structures, finally heals by secondary intention and scarring, the biomechanical properties of the foot changes. the weight transmission, the beautiful mechanics, the gait cycle, everything is altered and food becomes a high risk food like the other first one. What about this food? You can see severe pest plants. What is pest plants? Flat food. And even not flat food, it has become a rocker bottom, just like the boat, under surface of the boat. It has become a rocker bottom and a very bad callosity at the summit, the convex end of the rocker bottom. And this is the situation if you do this. Understand? That high risk food, if you keep on walking, this will happen. See, this is a poor man having multiple complications of diabetes, severe neuropathy with some equinus deformity. See what has happened? You have ulcer over the forefoot due to severe burns. Patient was standing on a hot concrete terrace without using a footwear. The man burned his sole, but inadvertently, totally neuropathic foot. See, this is a very common condition called intertrigo. What happens if you and me develops intertrigo? We have discomfort, we have itching. We will go to the dermatologist, treat it properly. But the poor diabetic patient has no symptoms. His toes are overcrowded. Moisture is harvested every time in the interdigital space and wound infection by fungus. And if you ignore, naturally it will be ignored because it is asymptomatic. What will happen? It will ulcerate. So my introduction was with 3 or 4 photos. One was a callosity. Second was a surgically treated diabetic foot infection. Third is a intertrigo. Fourth is a neuropathic foot. So with this introduction, let me introduce the topic proper, that is high risk foot. The foot at risk of ulceration. It is the one that develops one or more of the following risk factors: neuropathy, ischemia, deformity, history of previous ulceration. What is the significance of the last one? If your patient says, "Sir, I had disarticulation of 5th toe 5 years back," or "I had diabetic foot infection 2 years back," indirectly he is telling, "Sir, my foot is a high risk foot because I have neuropathy, I have vasculopathy, I have structural deformities. Then that is why my foot got ulcerated and the ulcer healed, but the remaining risk factors are still there. So treat me as a high risk foot." That is the meaning of the 4th point. Dear friends, when you get a diabetic foot or a high risk foot, you please see, is there any loss of protective sensation? Is there any deformity or limited joint mobility? I will tell 2 sentences about this one. As you all know, your hemoglobin is glycosylated, your soft tissues are also glycosylated in chronic diabetes. Your elasticity, your suppleness, your dynamic nature, pliability of the joint is gone. What will happen? There will be rigidity. That is called, take the example of first metatarsophalangeal joint. That is hallux rigidus. So you have to examine it. I'll show you in the next slide. And ask another question. Is there any previous history of ulceration or amputation, which I have explained in detail? And our aim is to find out the 3 things: peripheral neuropathy, peripheral arterial disease, structural abnormalities. So when you examine a patient in detail, the 3 things you will do are: 1, you determine the patient's risk status. Second, determine the patient's educational needs. Third, you should have a complete management plan, starting from education to even amputation or rehabilitation, whatever. So who can all do clinical examination in diabetes? Foot assessment and clinical examination need to be undertaken in all patients with diabetes. Why? On the day of diagnosis of diabetes, as all the diabetic practitioners listening to this talk now know, you might have had neuropathy already. So who will do all these things? It will be done by any person. It can be entrusted to your nurse, your paramedical staff, your wound care worker, or anybody who is trained under you. So you don't think that it needs a lot of time, the busy practice of modifying the doses and starting newer modalities. I don't get time to go to all this ABPI business, so I'll send the patient to somebody else. No, you can do this along with your practice without sacrificing time by your paramedics. So these are all clinical things, history. Then when you examine the foot, look for nails, skin condition, foot deformity, vascular assessment, neurological assessment, foot wear, ulcer assessment. These are the certain things which are self-explanatory. This is a indwelling toenail with paronychia, then two long toes with nails projecting and producing trauma. Then you can see the wrongly cut nails, which produces infection, and fissures, intertrigo, the one which I have showed, callosities, and severe intertrigo with secondary infection. And this is the one which is a very good indicator which can be done by anybody. Just try to extend or dorsiflex the first metatarsophalangeal joint, and normally it is around 70 to 90 degree. And if the joint mobility is less than 50, think about limited joint mobility, and the patient is supposed to have many other deformities now or in near future. So the foot deformities or toe deformities which are very common are hallux valgus, toe, plotos, pes cavus. Pes cavus is nothing but high arched foot. Then your rocker bottom with ulcer, then Charcot's with a lot of advanced complications. These are the diagrammatic representation just for the information. Hammer toes are hyperextension of the metatarsophalangeal joint and flexion of interphalangeal joints, that is claw toes. But in hammer toes, the interphalangeal joint flexion is not there, so that becomes a hammer. This is a claw, that is a difference. Then your hallux valgus is supposed to get another problem called bunion on the medial side of the head of metatarsal. Then this is a Charcot's joint with disorganized joint and loss of joint configuration and all. And this is a very important picture which all the practitioners should keep in mind. See what will happen in a case of chronic diabetes. Your TA, that is tendo Achilles, is very much short. So it will pull your heel upwards. Then you get weakness of the intrinsic muscles, isn't it? So what will happen? There is more strain and stress at the Lisfranc joint. What is Lisfranc joint? It is a tarso-metatarsal joint. So what will happen is when you press or when you walk, slowly the plantar arch straightens like this, and finally it becomes a rocker bottom deformity. I just wanted to show you how a deformity develops. It is multifactorial. Then comes the vascular assessment. As you all know, the three parts as dorsalis pedis, posterior tibial and anterior tibial. Then your ankle brachial index, very, very important. You have to see, unless you correct the vascularity, your management is definitely going to fail. So just put a BP cuff on the calf, take the ankle pressure, then divide the ankle pressure by brachial pressure. It is on in you and me. In a patient with ischemia, it is less than 0.9, and more than 1.2 is also not. Then neuropathy. You know, neuropathy is a silent killer, and it will This unperceived trauma leads to various infections, scald, burns, foreign bodies. So neuropathy is very important. What you have to do is use this simple device called monofilament. 10-gram monofilament will tell you how to categorize the patient and just apply pressure so that the monofilament bends, and these are the classical sites, and you can very well say it is neuropathic or not. Then your classical tuning fork, and this is a very handy instrument. What you do is you have vibration generated by the machine and the millivolt which generates the probe will be shown in the dial. You start from 10 millivolts and raise up to the 50 and more. And if the patient has got good sensation at the 10 millivolt itself, patient will perceive vibration. If the vibration perception threshold is less than 2, less than 10, it is normal. 10 to 25, it is mild. 25 to 50, it is moderate. And more than 50, it is severe neuropathy. Skin temperature will tell you whether there is any acute charcoals. And the other thing, the foot pressure, which we were discussing, is very, very important because it is the forerunner of ulcer. So the localized pressure points are very well detected by various sophisticated scanning machines, starting from computerized scanning systems, which will give you many, many details. But at least you should know a basic one, that is Harris mat. What you do is you on a rubber mat, you apply the ink the used in stamp pad, then put a paper and take a imprint like this and put it on the scanner in a software. You get a report like this. The red areas indicate higher pressure, the yellow moderate pressure, and the green normal pressure. And velocities are very well seen as localized one, as you see in the big toe. And a very important examination is footwear examination, or FWE. Inspect the patient's footwear. It looks very beautiful, isn't it? But it may not be the case always. See, this poor man presented with a diabetic foot infection due to a penetrating injury at the first metatarsal head. See the corresponding part of the footwear is all worn out. See, there is no sole here. So the footwear will tell the story or the history of his foot care, the cause of his injury. So footwear will tell you how the pressure points are being tackled, how badly all these things are compensated by a bad footwear. So footwear examination is always necessary in diabetic foot infection. And an X-ray, very simple one. I am discussing about the evaluation of high-risk foot. See, when you take an X-ray, you see like this. This is a microfracture of the navicular bone. What is this indicate? This indicates a Charcot's arthropathy. Charcot's arthropathy is nothing but ischemic osteoarthropathy, neuroischemic osteoarthropathy of the small bones and joints of foot. This is the beginning. You can see the various deformities. Pes cavus. You can see the pointing first metatarsal head, then hyperextended toes. Here the fracture has come. And the third one is an advanced Charcot. You have complete loss of ankle joint with complete dissociation of long bones and short bones, a flail ankle. And vascular evaluation, very simple. The Doppler study will tell you the ABI, the level of occlusion, the turbulence of the flow, the velocity, everything. So if you have a Doppler positive patient, you subject the patient for angiogram because you want to operate upon this patient. Take the example of this angiogram, the typical site of distal femoral artery occlusion. You can see there is complete absence of femoral artery on both sides, probably in the Hunterian canal, femoral canal, and there is some collaterals outside. So this patient needs a femoral or an iliopopliteal bypass. This is an MRI showing the MRI is a very good investigation for Charcot's foot. You can see the destroyed bones here, and you can see an ulcer also in the second one. And 2 minutes examination in your busy practice, previous ulceration, previous amputation, deformity, ingrown fusion. Third, second foot examination, 4 test checks, and management of HRF. For local care, you need correction of deformity, footwear, and education, and pedicure. Then conclusion, the concept of iris foot should be popularized among all doctors treating diabetes. Diagnosing HRF and initiating preventive podiatric care is a must to prevent ulceration, infection, and amputation. Diagnosing HRF is simple and can be done in your consultation room itself. Third, second foot examination, followed by 2 minute foot examination, followed by simple investigations. So that finishes my talk, and thank you very much for the patient hearing.
Thank you, sir, for the wonderful presentation. Now, because this is a common topic, we can have questions together with Dr. Ajit and Dr. Ajay Kumar. Any questions? Ajit, I have a question for you.
Yes, Manish.
This epidermal cell grafting, okay, how is it done by yourself or with the help of plastic surgeon?
No. Actually, that is very easy. I think the company people will have a technician with them, a person trained in harvesting the follicles. It is a very simple thing. It's like a square thing you apply on the local area and apply some negative pressure. The few follicles will come that you just place a sticker kind of a dressing, and you keep it over the granulation wound. You should do it on the granulation wound, not on the wound with the slough. I think it gives good result. There is no need for any plastic surgeon or a thing. I think the technician itself will do, and it takes hardly around 20 to 30 minutes time to do that. I have done it in 8 to 10 patients. I think it was good. But only problem is our patient, the cost is the issue. I don't think it is too costly, 8,000 to 10,000 rupees. And patients are always worried that what will happen to the donor site. But it won't produce to wound like what we do it in split skin graft. It is a easy, good procedure and gives good results if you apply it on a granulation wound. I think Ajay must have maybe doing as a routine procedure.
Can I comment on Saluto? Okay, this is a very, the basic principle of this epidermal grafting is you are taking only the most superficial layer of the epidermis, the stratum corneum and stratum spinosum. So what happens is it doesn't produce any ulceration, just like a tough massage on your skin, you get exfoliation. Similar thing, only thing it is done under negative pressure, and there is a knife, and there is a perforated knife through which bubbles like projection of the epidermis will come, and it will be cut when you press that one, and it is put on a tegaderm. There is a film, and you place that film on the ulcer. But it should be small, it should be infection free, and it will take around 10 days to heal. It is not useful for bigger ones, just 2 into 2 or 3 into 3 centimeter clean wounds. The donor site will have nothing. There is no pain and there is no ulcer.
Thank you, sir. Is there any other questions? If there is no more questions,
thank you, Shabir and team.
We will move on to the other one, but I think there is no elaboration. Thank you, Ajit, and thank you, Ajay Kumar sir, and thank you, Shabir, for making me a wonderful e-conference. Every year it is improving. The topics is also different. I congratulate Shabir and thank you all.
Thank you. Welcome.
Thank you.
Thank you for the wonderful session. So before going into our next section, we will have our theme music. Our next section is Gestational Diabetes Mellitus Syndrome Symposium, and to chair the session, let me invite Dr. Ajit Kumar sir, Dr. Deepa ma'am, and Dr. Vivek Krishnan. Over to you.
Thank you, Dr. Shabir. Once again, we'll move with the presentations because we are running short of time. I think next is a symposium, the Gestational Diabetes Mellitus Symposium. I think it is a very important topic in day-to-day practice because the women and diabetes issues are gaining more significance in our day-to-day practice. We have, I think, 5 to 6 topics will be discussed in this symposium. The first topic will be presented by Dr. Danya G. Krishnan. I think she is alumnus of Trivandrum Medical College. I think she'll be presenting a topic on preparing a woman with diabetes in pregnancy. It is a very, very difficult scenario. The patient will have stress, the consultant, the doctor will have some issues because maternal complications, the high chance of maternal complications and perinatal complications are also there. So how you can prepare a woman with diabetes in pregnancy, it's a very important topic. For that, I invite Dr. Danya G. Krishnan. She is currently working as a junior consultant gynecologist in Women and Children Hospital, Tekkal, Trivandrum. Over to Dr. Danya.
Am I audible?
Yes, you can start. No issues.
Okay. Thanks, Dr. Ajit Kumar, for that introduction. And at the outset, let me thank Dr. Shabir for giving me this wonderful opportunity. And let me share the content. So the topic assigned to me is preparing a woman with diabetes in pregnancy. First, let us go into the definitions. Gestational diabetes is any degree of glucose intolerance with onset or recognition during pregnancy. Then, what is pregestational diabetes? And it is diagnosed when the woman has diabetes before pregnancy. No, it's not moving. So the magnitude of the problem. Worldwide, 1 in 10 pregnancies are affected by diabetes mellitus, and out of which 90% of it is GDM. In UK, almost 5% of pregnancies are complicated by diabetes. 87.5% GDM, 7.5% type 1, and 5% having type 2 diabetes. In India, 10 to 14.3% GDM complicates pregnancy. Then before we counsel the woman regarding how to prepare for her pregnancy, we should know the risk. We should explain to her the risk because of the diabetes, and she has an increased risk of cesarean section. The risk for preeclampsia increases by about 2 to 4 times, and there is a risk for polyhydramnios, preterm labor, PPH, temporary worsening of renal function, progression of the retinopathy. Then there is increased incidence of infection, severe hyperglycemia, hypoglycemia, decay, and in future pregnancies, she can have recurrent GDM pregnancies and risk of developing type 2 diabetes mellitus. And what are the complications the infants can have? Earlier, in the early part of pregnancy, they can go in for spontaneous abortions. Stillbirths can occur in 10 to 30% of pregnancies. Congenital malformations can occur like neural tube defects, cardiac defects, caudal regression syndrome, even though rare, can occur. Then macrosomia can occur, visceromegaly, respiratory distress syndrome, asphyxia, birth injury like shoulder dystocia, Erb's palsy, diaphragmatic paralysis, and facial paralysis can occur. Then in the neonates, there can be hypoglycemia, hypocalcemia, and magnesium deficiency, which can present as apneic episodes and fits. Polycythemia can occur, which can result in hyperbilirubinemia and jaundice, which may need partial oxygen transfusion. All these we should know to explain to the women. Now, what do you do in a pre-pregnancy counseling? You are assessing the suitability for pregnancy. We are looking for complications of diabetes and evaluating and treating complications prior to the onset of pregnancy. And you are achieving optimal control prior to and during very early pregnancy. And you are providing an opportunity for pre-pregnancy advice and follow-up supplements. Now, the counseling should include diet, body weight, and exercise. You should explain to them that the risk of hypoglycemia is more, and how nausea and vomiting of pregnancy can affect blood glucose control. And there is a chance for lag for gestational baby leading to birth trauma, induction of labor, and cesarean section. And you have to stress upon the assessment of diabetic retinopathy and nephropathy before and during pregnancy. And then you have to stress upon the need for adequate blood glucose control even before pregnancy. And she should be told that there can be temporary health problems in the baby during the neonatal period, and the baby may require admission to the neonatal unit. And in the long term, baby can develop obesity and diabetes. Now, the pregnancies, all women with diabetes, they should have a planned pregnancy, and the choice of contraception should be personal depending upon the medical eligibility criteria. They can use oral contraceptives if there is no standard contraindication according to the medical eligibility criteria. And you have to explain that the risk is proportional to the duration of diabetes mellitus. More the duration, more the risk. Contraception should be continued till the ideal blood glucose control is achieved, and that is monitored using the HbA1c. And she should be told that we should review frequently the blood glucose targets, the glucose monitoring, diabetes medicines, including insulin regimens, and the drugs which are used for diabetic complications before and during pregnancy. And also she may need frequent visits, that is more than a normal antenatal woman, maybe once in a week or once in 2 weeks. And you should give diet and dietary supplements, and you should stress upon the ideal body weight. And when we're giving dietary advice, it should be individualized. We should take into consideration the risk of hypoglycemia. If the BMI is about 27 kilogram per meter square, you should advise on how to lose weight. And folic acid should be ideally given 3 months prior to conception and should be continued until 12 weeks of gestation, and that's to reduce the risk of having a baby with neural tube defect. And the weight reduction, you should advise that severe calorie restriction should not be done. Like 50% reduction in weight, it can lead to ketosis and impaired fetal brain development. And you can have a moderate calorie restriction like 1,600 to 1,800 kilocalories per day, or 33% reduction in weight. And what are the target blood glucose and HbA1c levels in the preconception? It's like in the type 1 diabetes range. You should keep the fasting plasma glucose level between 5 to 7 millimoles per liter on waking, and at all other before meals, it should be 4 to 7 millimoles per liter. And the target HbA1c, what we say is 48 millimoles 48 millimoles per mole, that is 6.5%. Anything above 86 millimoles per mole, you should advise strongly against getting pregnant. So you should advise her to continue contraception till the HbA1c, ideal HbA1c is achieved. Now, the diabetic medications in pregnancy, you can use metformin as an adjunct or alternative to insulin. All other OHs should be discontinued before pregnancy and insulin should be substituted. Rapid acting insulins, the studies say that there is no risk to the infants, to the fetus, sorry. Now you can use isophene insulin as a first choice for long-acting insulin during pregnancy. Then she may be on other medications like ACE inhibitors and angiotensin 2 receptor antagonists, which are used for preventing the complications. As soon as or when she is planning for pregnancy itself, all these medications should be stopped, and statins should also be discontinued. And from the adolescent period, they may be having diabetes. So even from the adolescent period, you have to train them and prepare them and you have to give information regarding proper blood glucose control from the adolescence itself. And now the retinal assessment in the preconception period, you have to offer retinal assessment to women with diabetes seeking preconception care at the first appointment, unless it has been done in the last 6 months, because retinopathy can get worsened. If she's having already retinopathy, it can get worsened during pregnancy. And the retinal assessment is done by digital imaging with mydriasis using propicamide. And those women, you have to advise against rapid optimization of glucose control until the retinal assessment is done, because that can worsen the retinopathy. Then, not moving. Okay, then renal assessment of a woman with diabetes, a renal assessment including a measure of albuminuria before discontinuing the contraception. Now, you have to refer to a nephrologist may be needed if the creatinine is abnormal, like 120 micromoles per liter or more, or when the urinary albumin or by creatinine ratio is greater than 30 milligram per millimole, more than 30 milligram per millimole, or the estimated GFR is less than 45 ml per minute. Now, she should have her thyroid functions assessed, because uncontrolled hypothyroidism can result in decreased fertility, increased risk of spontaneous abortion, and increased risk of impaired fetal brain development. I can go for a serum TSH and thyroid peroxidase antibodies checking. And the BP should be in the normal range. That is, it should be ideally less than 130/80, because preconception uncontrolled hypertension can increase the risk of adverse outcomes. So finally, to conclude, aim to empower women with diabetes to have a positive experience of pregnancy and childbirth by providing information, advice, and support that will help to reduce the risk of adverse pregnancy outcomes for mother and baby. And also explain to women with diabetes who are planning to become pregnant that establishing a good blood glucose control before conception and continuing this throughout pregnancy will reduce the risk of miscarriage, congenital malformations, birth, and neonatal death. It is important to explain that risk can be reduced but not eliminated. So thank you.
Thank you, Dr. Danya. I think you was on time. That's a great achievement. I think if anybody has got any question, I think she'll be ready to clarify.
Yeah, I think, Dr. Ajit, we will have the discussion at the end. Since this,
okay,
we'll have the discussion at the end.
Okay. Okay. Next, we'll move on with the next topic. I think the next is next topic will be presented by Dr. Preeta. It's about the gestational diabetes mellitus and the diagnostic dilemma. Preeta is an alumni of Trivandrum Medical College. She is currently working as senior consultant gynecologist and at Medicina Hospital in Tirunelveli. She's a what do you call a specialized in infertility evaluation and management of infertile patients.
And the screen.
Any problem? Okay, and she did her MS from Kasturba Medical College, Mangalore. I think she did her fellowship in minimal access surgery also. A great practitioner. And my close friend's wife also, Dr. Preeta. It's over to you.
Respected chairs, am I reasonably audible for you?
Yes, no issues.
Yeah.
Keep going, no problem.
Yeah. Let me share the screen. So respected chairs, seniors and dear friends and colleagues. Good afternoon.
Yes, Preeta.
There is some problem with your sound audio.
One second, just a second.
Yeah,
Let me just share the camera.
Yeah, perfect.
See the screen?
It's about to share.
It's about to share. Just wait. You keep talking, no issue. You keep.
Yeah, at the outset, thank Dr. Shabir and the Diabetes Today 2020 team for giving me this opportunity. And I have been given the topic gestational diabetes mellitus diagnostic dilemma. So why this dilemma? Because despite decades of research and debate,
No. We cannot view the slides, Preeta. If it's not practical from your side, can you please send it to us? We will share it.
No.
You try once more. We'll wait. I think some issue with your internet connectivity.
Actually, sharing your screen, that's what's coming.
Yeah, it's coming. Just wait. Hey, Preeta, go share the PowerPoint. I think you are sharing something else. Yeah, okay. Fine.
Is it coming?
Click the PowerPoint. That icon, PowerPoint icon. You just go to the
this screen, then
you just go to the bottom side. There is a taskbar. There is an icon point. This is the one. One icon with some P and all. Share it once more.
Is it actually yesterday I shared? I don't know what happened. Where is the icon actually?
You the thing is that you have to activate that PowerPoint. You can see that PowerPoint icon, one with P and all.
Yeah.
Just click it once more.
I click.
And go to WebEx. Go back to WebEx. Try to share. You click share.
Yeah. Share. It is not coming. That share is not in not active.
Okay, Preeta. Can you mail it right now? Can you mail it? Is it practical?
Yeah. But it will take time, no? So we'll go for the next talk, then I'll come back. Otherwise, we will you lose your time.
I think Shabir, that will be a nice idea. The next speaker can have his talk, then
Okay, I
speaker
think.
can come back. That will be good.
I think it has come now.
Wait.
Yeah.
Yes.
Prida, please go on.
It came?
Yeah, perfect. You just activate that PowerPoint mode, slideshow mode.
Yes, keep going.
Okay, just I'll start. Actually, the classification by was already dealt by Dr. Tanya. So I'll just go to the, the definition and classification has already been dealt by Dr. Tanya. So gestational diabetes mellitus, it can be either de novo pregnancy induced, some are type 2, that's 35 to 40% type 2 diabetes, and 10% have antibodies. So our dilemma lies mainly in the screening and diagnosis. So the timeline for major criteria and trials involving gestational diabetes starts from WHO criteria to Australian carbohydrate intolerance study to DIPSI to IAD-PSG to ADA. The recent consensus have shifted towards accepting ADA criteria, which is a two-step study, two-step test as the most useful for diagnosing gestational diabetes mellitus. However, in the community health centers, pregnant women are reluctant to undergo ADA procedure for two reasons. The first one is the number of blood samples drawn are many. Second, after was created for diabetes procedure. And no consensus among international bodies whether this gestation is and whether the use or selective screening is most appropriate. The best way would be to develop a definitive test, research preparation, and digital time to perform without requiring imposition of screening test, and which could be applied to the population. And in countries like India with a high diabetes, universal screening would be more appropriate. Like the time, so many guidelines have already come from WHO 1999 criteria, which the WHO dropped in 2013, and they accepted the IAD-PSG criteria. The IAD-PSG guidelines, they recommend performing the test at 24 to 28 weeks period of gestation. The 75 gram 2-hour OGTT is used, and the GDM is diagnosed if any one values exceeds this threshold, that is fasting more than or equal to 92, 1 hour more than or equal to 180, and 2 hours more than or equal to 153. We should know a brief history in the Indian, because some of the Indian pioneers have recommended some guidelines which have even come in the FIGO. In India, the first fetoplacental maternal unit was started at the Institute of Obs and Gynec Maternity Center, ECMOR, by Professor Moses, Professor Phillips, and Professor Skishia. Is much named in the FIGO also. In 1985, they organized the first international colloquium on diabetes in pregnancy in Chennai, followed by the formation of DIPSI in 2004. So what's the Indian scenario? Government of India released guidelines in 2014 to address the need of high prevalence of GDM in India. The present guidelines by the Maternal Health and Family Welfare Government of India, published in February 2018, has been prepared based on the recommendation of experts and available international faculties. They recommend using a 75 gram glucose through oral glucose test, irrespective of the level, with a threshold value of 2-hour blood sugar of 140 milligram per deciliter. So they accepted DIPSI guidelines. Whom and screen. They gave 75 gram glucose with single plasma glucose value at 2 hours. It's a universal screening. It's not a high risk or low risk screening. It's a universal screening with more than or equal to 140 milligram per liter considered GDM. More than equal to 120 milligram per deciliter is considered gestational glucose intolerance, and more than 200 milligram per deciliter is considered diabetes. If the first screen is negative, then we have to repeat at 24 to 28 weeks and then at 32 to 34 weeks. So why in India separate guidelines? Indian females have 11-fold increased risk of GDM than Caucasians. The prevalence, particularly in Kerala and Tamil Nadu, is around 16.55%. Universal screening detects more number of GDM, and a single measurement is ideal because it's more economically feasible and more patient compliance. First, be done during antenatal contact as early as possible in the pregnancy. There should be at least 4 weeks gap between the two tests. The test is to be conducted for all the pregnant women, even if she comes late in pregnancy for ANC at the time of first contact. Only 1/3 of GDM positive women are detected during first trimester. So, if it could not be done during this time, then it should be repeated at 24 weeks period of gestation. And if she presents beyond 28 weeks period of gestation, the first point of contact, we have to do the GCT. So what's the methodology and test for diagnosis? 75 gram glucose is to be given orally. Approximately 300 ml of water, whether the pregnant woman comes in fasting or non-fasting state, irrespective of the last meal. The intake of the solution in 5 to 10 minutes. A plasma standardized glucometer analyzer or not analyzer should be used to evaluate the blood sugar 2 hours after the oral glucose load. As it is a hyperosmolar solution, it is difficult to tolerate. So if the vomiting occurs within 30 minutes, particularly in the first trimester of oral glucose intake, the test has to be repeated the next day. If vomiting occurs after 30 minutes, the test continues. So in the pregnant woman, test for GDM at the first antenatal visit by 75 gram glucose, followed by 2-hour blood sugar value. If it is positive, consider as GDM. If it is negative, repeat the test at 24 to 28 weeks. If it is positive, consider as GDM. If it is negative, continue the test at 32 to 34 weeks and see the value. Everywhere there is a controversy. Even though we accepted the DIPSI guidelines, one recent study by which it says that diagnosis of GDM by DIPSI criteria leaves 22.36% undiagnosed, which may easily be detected IID PSG criteria. And again, a recent Sri Lankan study showed that a non-fasting test will miss as many as 60% of true GDM. We have to take the message like the convenience of performing DIPSI test is its chief advantage. The National Guideline for Diagnosis and Management of Gestational Diabetes in India endorses a single-step test for diagnosis GDM using a 75 gram glucose through oral glucose tolerance test, irrespective of the last meal, with a threshold value of 2 blood sugar more than 140 milligram per deciliter. Guidelines advocate for universal screening for all pregnant women at first antenatal contact. If test is negative, the second test should be done at 24 to 28 weeks period of gestation. Thank you for the patient hearing, and stay safe and stay healthy.
Thank you, Prida, for the wonderful presentation. I think there was initial few technical issues. Okay, it's not any problem. I think we'll move on. No issues. We'll move on with the symposium. I think next topic will be antenatal care and glycemic monitoring in pregnancy. I think the topic will be discussed by Dr. Sukesh RS. I think, can I get this introduction slide, please? Dr. Sukesh is alumni of Trivandrum Medical College. I think he's currently working as a senior consultant physician and diabetologist in TRS Hospital, Trivandrum. He's a regular speaker in many regional and national forums, and he's an excellent writer. He's a poet and my close friend. He has got many publications to his credit. I think Sukesh is an apt person to discuss about the antenatal care and glycemic monitoring in pregnancy. Over to you, Sukesh.
Thank you, Dr. Ajit Kumar, for the nice words, and thank you, Dr. Sabir Rashid, for inviting me as a faculty again for another DIVE conference. So my topic for today is antenatal care and glycemic monitoring in pregnancy. I hope everyone can see the slides. Yes. So diabetes mellitus, we know, is associated with maternal morbidity and mortality. Actually, before insulin was discovered in 1921, these diabetic women rarely reach the reproductive age or even survive pregnancy. In fact, pregnancy termination was routinely recommended for those with diabetes because of the high mortality rates. Around 87% of pregnancies are complicated by diabetes are estimated to be due to GDM. And nowadays, even type 1 diabetes in pregnancy is also increasing. So diabetes is one of the most important medical disease complicating pregnancy, and the risk starts even at maternal glucose level below those traditionally considered as diagnostic of GDM. Actually, this poses a serious health consequence for both the mother and the baby, which has been discussed in the earlier slides. Women diagnosed with GDM are at increased risk of future diabetes, predominantly type 2 diabetes, and also their children. GDM offers an important opportunity for the development, testing, and implementation of clinical strategies for diabetes prevention. Therefore, a timely action is necessary to control the diabetic state in pregnancy. So this chart I'm just skipping because this has been already discussed earlier. The prevalence of GDM in India varied from 3 to around 21% in different parts of the country, and the urban areas are more prevalent than the rural areas. For a given population and ethnicity, the prevalence of GDM corresponds to the prevalence of impaired glucose tolerance in non-pregnant adults within that given population. Universal screening for GDM in all pregnant women is recommended to improve outcomes in those women. It is recommended that the GDM screening should be performed at 16 weeks of pregnancy and followed up with a second screening between around 24 to 26 weeks and third after 30 weeks of pregnancy. So as a pregnant woman walks into the antenatal clinic in the fasting or non-fasting state, these women should be given a 75-gram oral glucose load, and at 2 hours a venous sampling should be done. There are so many criteria proposed by the ADA, ACOG, NICE, and even DIPSI. ADA guidelines recommend screening as early as possible, even at around 16 weeks. Repeat the screening during the third trimester is actually suggested by DIPSI guidelines between 32 to 34 weeks of pregnancy. ADA and NICE recommend a 75-gram and 100-gram oral glucose tolerance test, while ACOG recommend a two-step, that is, first you give a 50-gram followed by a 100-gram OGTT. The Australasian study again recommends a screening with a 50-gram or a 75-gram oral glucose challenge test, irrespective of the meal intake. Now, fasting glucose and the postprandial peak level around 90 and 120 milligram per deciliter is actually the recommended target in a lady with diabetes in pregnancy. Actually, the titration is the ideal way is to do a 7-point monitoring, but it's very cumbersome because 3 before and 3 after each meal and 1 in the middle of the night around 3 a.m. is very difficult. So to compromise, 1 fasting and 3 levels each after breakfast, lunch, and dinner at least twice a week is more acceptable. So this is an easy thing to follow up your patients. Do our plasma glucose more than 140 milligram per deciliter, just like an impaired glucose tolerance in a normal subject, should be diagnosed as GDM in a pregnant lady. So this criteria, you can just note a criteria like more than 2 or postprandial glucose more than 200 can be considered a proper diabetes in pregnancy, and outside pregnancy also it is diabetes. Where if it is more than 140, it is a GDM, and if it's an outside pregnancy, it's called as impaired glucose tolerance. This is very important. The third part, 2-hour postprandial glucose more than 120 can be considered decreased gestational glucose tolerance, DGGT, in pregnant ladies. A single test procedure has been developed by the DIPSI, and this is the antenatal single test procedure is when a pregnant lady comes to your clinic, you give a 75-gram oral glucose load, whether she's fasting or non-fasting, and you collect the blood sugar at around 2 hours. And if it's more than 140 milligram per deciliter, your lady is having GDM. If this is another thing, if the 75-gram glucose packet is not available, from a 100-gram packet, you remove around 5 teaspoons of glucose, and your 75-gram glucose load is ready. So why this is why the rationality of the test is so like this, because most of this pregnant ladies won't be in a fasting state when they come to your clinic. So even after a meal, a normal glucose tolerant woman would be able to maintain euglycemia despite the glucose challenge due to the brisk and adequate insulin response. So this is more advantageous because this will eliminate the false positivity in the diagnosis of GDM. By following the usual recommendation for screening between the 24 and 28 weeks of gestation, there is actually a chance of detecting unrecognized type 2 diabetes before pregnancy is likely to be missed. So if the 2-hour postprandial glucose is more than 200 milligram per deciliter in the early weeks of pregnancy, the women may be having diabetes even before the pregnancy, and an A1C of more than 6.5 is confirmatory. So a pregnant woman found to have a normal glucose tolerance in the first trimester should be tested for GDM again in the 24 to 28 and also in the 32nd to 34th week. So this is OGTT and the other diagnostic glycemic goals. It's already known to all of you. So the vast majority of the people are screened for, only around 90% of these people around the world are screened properly for GDM. Around 14% are only screened very less frequently. So diabetes and pregnancy, actually, there are two types. One is GDM and also a pregnancy, the diabetes complicating pregnancy. So what should be actually thought of or considered? Actually, in the pre-consumption period itself, management of the diabetic woman is a complex process which should begin before conception. In the pre-consumption period, the insulin regimens can be modified to improve glycemic control. Cholesterol lowering medication should be discontinued. ACE inhibitors can be should be changed to a calcium channel blocker, and folic acid therapy can be instituted. To evaluate the risk in pregnancy, an eye evaluation can be performed, and genetic risk also can be addressed. Counseling specific risk and expectations also should be provided. So this is a simplified chart. You can see the optimal glycemic control, A1C of less than 7 or as close to 6 should be maintained. Medication should be actually verified because you have to discontinue statin, stop ACE inhibitors or ARBs. Nutrition counseling is very important. BP goal should be less than 140/90. And a retinal examination, nephropathy assessment should also be done in those people with diabetes entering pregnancy. Thyroid assessment is also very important because the TSH should be maintained less than 2.5. So in the first trimester, what should be actually done? Hospitalization may be required to reevaluate the diet and adjust the blood sugars accordingly. Education regarding the importance of the dietary intake and glycemic control to the health of the fetus. Hypoglycemia in pregnancy is common mostly in the first trimester. And lab studies to actually assess whether the patient will be a candidate to develop preeclampsia also should be thought of. So the lab investigations include LFTs, renal function test, HbA1c, 24-hour urine for protein and creatinine clearance. And also the nuchal translucency can be used for early screening for not only chromosomal problems, but also to detect congenital heart disease. In the second trimester, the insulin requirements actually increase than the first trimester. You can do a targeted ultrasound for the congenital anomalies at 16 to 18 weeks and a fetal echo at around 20 to 22 weeks. And also subsequent ultrasound for the fetal growth should be monitored every 3 to 4 weeks. The other maternal screening can be helpful. Serum screening can be helpful in screening for the other fetal defects. In the third trimester, actually, the insulin requirements may go up to 140% of the pre-pregnancy doses. For example, if your diabetic lady is taking an insulin of around 10 units before pregnancy, in the third trimester, it may go up to 24 units. In women with hypertension and IUGR, testing can begin at 28 gestational weeks. The contraction stress test and the biophysical profile are generally used when the NST is non-reactive. And the Doppler assessment of the umbilical artery can be done to assess the IUG or suspicion. And the cesarean should be reserved for other obstetric indications, fetal compromise, and if the fetal weight is more than 4.5 kilo. In the intrapartum, actually, tight glycemic control helps to decrease the neonatal hypoglycemia, and women should be instructed not to take their basal or a long-acting insulin when in the labor or the day prior to the labor, and to begin on insulin infusion. After delivery, the infusion can be discontinued, or if a cesarean delivery was needed and a full diet is not instituted, it can be continued, but the insulin dosage should be decreased. In the postpartum period, actually the insulin requirements decrease quickly and most of them can be weaned off the insulin. The insulin dosing can either be decreased by around 40 to 50% or can be changed to the pre-pregnancy doses. Women with diabetes who breastfeed have lower daily blood glucose levels and generally require less insulin. And breastfeeding may also have a protective effect against the development of type 1 diabetes in childhood. So this is a logistic algorithm which actually in your GDM patients, you start with a premix insulin around 4 units before breakfast. Every 4th day try to increase by around 2 units till around 10 units. And if the fasting glucose is even more, even after this is more than 90 milligram per deciliter, advise 6 units around breakfast time and 4 units in the dinner time. And review with the blood sugar test and adjust further insulin dosage accordingly. Initially, if the post-breakfast plasma glucose is very high, you can start on a premix of 50-50 concentration. If the GDM is diagnosed in the 3rd trimester, there is still chance that your patient can be off insulin still. So a medical nutrition therapy is actually advised. And if it fails, you can start on an insulin. If the 2-hour postprandial glucose is more than 200 at diagnosis, a starting dose of 8 units of premix insulin could be administered straight away. And then it can be titrated. So regarding the lifestyle management, actually the lifestyle management is very much important because the fasting glucose in your patient should be less than 95. The 1 hour postprandial should be less than 140 and 2 hour postprandial should be less than 120. So medical nutrition therapy has been proposed in a very important way nowadays. And the food plan should be based on a nutrition assessment with guidance from the dietary reference intake. Actually, the DRI for all pregnant women recommends a minimum of around 175 gram of carbohydrate, a minimum of 71 gram of protein, and a 28 gram of fiber. So, as it is true for all nutrition therapy in patients with diabetes, the amount and type of carbohydrate will impact the glucose level, especially the post-meal excursions. So, insulin is a first-line agent recommended for the treatment of GDM. This is regarding the pharmacotherapy. And insulin may be required to treat hyperglycemia, and it should follow the guidelines below. Both the multiple daily injections, that is the multiple injections, or the subcutaneous insulin pump are reasonable alternatives, and neither has been shown to be superior during pregnancy. So metformin, what about the metformin? Metformin was actually associated with a lower risk of neonatal hypoglycemia and less maternal weight gain than the other drugs in the 2015 reviews. And furthermore, nearly half of the patients with GDM who were initially treated with metformin needed insulin at a later stage. And umbilical cord levels of blood metformin are higher than the simultaneous maternal levels. So what about glyburide? Because some centers are using glyburide in very difficult cases or very rare cases you can use that. But still the concentrations of glyburide in the umbilical cord plasma are approximately 70% of that of the maternal level. And actually it is more associated with neonatal hypoglycemia and macrosomia than insulin or metformin. So insulin, you know that is confirmed that it is a preferred agent for management in both type 1 and type 2 diabetes because oral agents are insufficient to overcome the insulin resistance which is seen in pregnancy and diabetes. So what about preventing preeclampsia? So in most of your patients with diabetes, actually, in whatever type of diabetes, you start on a low dose aspirin between 60 to 150 milligram per day from the end of the first trimester to lower the risk of preeclampsia. In pregnant patients, you have to maintain a BP target of less than 130 or even 120, the systolic and less than 80 millimeter in the diastolic thing. And teratogenic medications like ACE inhibitors, ARBs, and statins should be avoided in even those even planning for pregnancy. These agents has to be stopped. So to summarize, the cost and standardization of glycated hemoglobin are major issues for consideration because some centers are not even doing HbA1c in diagnosis or treating GDM, a large survey conducted all over India covering 24 states reveals that more than half of the diabetologists or endocrinologists and gynecologists in India do not follow any of the recommended guidelines. Even though the guidelines are a lot, they do not follow any of these guidelines. The A1C is not possible to perform in the less resource countries, not only because it is expensive, but also due to lack of technically qualified staff. So antenatal workup and antenatal care is very important in your diabetic patients. Thank you.
Sukesh, time up. Okay. Thank you, Dr. Sukesh. I think we'll move to the next speaker. I think the other faculty will be introducing the next speaker. Over to you, Shabir.
Without wasting much time, we will go on to the next topic. The next topic is exercise in pregnancy, which is a very important topic. And to deal with this, we have an eminent speaker, Dr. Roy Chandran, who is an associate professor in the Department of Physical Medicine and Rehabilitation from the Government Medical College in Calicut. And he has many publications to his credit, around 12 original research papers in national and international medical journals. And he's a regular speaker in many national and regional forums. And he has received many awards as IMA National Award 2018 for the Best Local Branch President. So over to you, Dr. Roy Chandran, for dealing with the topic.
Hello. Please allow me to share the comments, please. Hello, kindly allow the slide sharing.
Yes, you can share now.
Okay, thank you. Okay, is it visible? Hello?
Yes, it's
yes.
visible. Yeah.
Yes. Yeah. Respected chairs and dear friends, the moment a child is born, the mother is also born. She never existed before, the woman existed, but the mother never. A mother is something absolutely new. It's words by Guru Rajneesh. And you know that we need to, our mothers and children to be healthy. And one important intervention for the same is proper lifestyle. And this is again one important part in this management of several diseases and also in the complication, to avoiding complications of pregnancy. And unfortunately, again, neglect. Pregnancy is one of the most divine things. And for some, pregnancy is a disease, and some, pregnancy is an opportunity, and for some, pregnancy never prevents them from reaching their goals. Say this, in 2017 Australian Open, Serena Williams was a winner, but she was 8 weeks pregnant at that time. So there was an editor in The Guardian, Serena Williams' pregnancy victory reminds us how amazing women's bodies are. So we should protect the women bodies. We can avoid, there are so many problems with pregnancy and after pregnancy. Many of them can be prevented by proper lifestyle. Coming to my topic, this is a traditional advice during pregnancy for exercising women to reduce their habitual levels of exertion in pregnancy. For non-exercising women to refrain from initiating strenuous exercise program. This is based on the concept that exercise could affect the early and late pregnancy outcomes by increasing the core body temperature during embryogenesis, increasing the risk of congenital anomalies like neural tube defects, shifting oxygenated blood and energy substrate to the maternal skeletal muscle away from the developing fetus, leading to growth retardation, and risk of maternal musculoskeletal injury due to changes in posture and center of gravity, fetoplacental injury due to blunt trauma or stress effects from sudden motion. So the research over years have shown that several of this have shown that in pregnancy, physical inactivity and excessive weight gain have been recognized as independent risk factors for maternal obesity and related pregnancy complications, including GDM. And these are the benefits: the higher incidence of what? Vaginal delivery and lower incidence of excessive gestational weight gain, gestational diabetic mellitus, gestational hypertensive disorders, preterm birth, cesarean section, and higher birth weight will be less in active pregnant ladies. Also, other benefits like essential factor in the prevention of depressive disorders, very important thing in the postpartum period, decreased postpartum recovery time, and increased placental surface area. That means an effective placentation which can prevent the PIH. And moreover, consider the risk of not participating in exercise activities during pregnancy will cause loss of muscle and cardiovascular fitness, development of varicose vein, as well also DVT, higher incidence of physical complaints such as dyspnea and low back pain. In mothers with pre-gestational medical conditions like chronic hypertension type 1 or type 2 diabetes, prenatal exercise reduced cesarean section by 55% and did not increase the risk of adverse maternal and neonatal outcomes. See, coming to the examples of exercise that have been extensively studied in pregnancy and found to be safe and definitely beneficial, like walking, stationary cycle, not otherwise, stationary cycling, aerobics like Zumba and other dance forms, hydrotherapy, water aerobics, resistance exercise using weights, elastic bands, etc. There are a few contraindications to exercise in pregnancy. You know that? Absolute contraindications are ruptured membranes, preterm labor, hypertensive disorders of pregnancy which are uncontrolled, incompetent cervix, growth restricted fetus, triples and above, placenta previa after 28 weeks, persistent second or third trimester bleeding, uncontrolled type 1 diabetes and uncontrolled thyroid disorders, and the relative contraindication where aggressive exercise are contraindicated. We can do moderate intensity exercise like previous spontaneous abortion, previous preterm birth, mild moderate cardiovascular disorders, respiratory disorders, anemia of less than 10 gram, malnutrition, teen pregnancy after 28, etc. And the other question is when to start an exercise program. The best time, is it a second trimester? Some say that it is second trimester when the nausea, vomiting, and profound fatigue of the first trimester have passed and before the physical limitation of the third trimester begin, but ideally before conceiving. All women without contraindication should be encouraged to participate in aerobic and strength conditioning exercise as part of the healthy lifestyle before, during, and after pregnancy. There is, that is something called a farmer dex for pregnancy for the women who are ready for exercise during pregnancy. Who have been exercising prior to pregnancy can continue their exercise if there is no contraindications. And previously sedentary should start with small exercise programs, low intensity, like 15 minutes, continuous exercise 3 times a week, gradually increase to 30-minute sessions 4 to 5 times a week. Intensity, this is a classical thing I've presented in the last before noon session. This is the thing: 220 minus age. That should be a moderate intensity with 50 to 70% of maximum. But this won't be effective in pregnancy because there is an increase of 10 to 15 beats per minute in resting heart rate in pregnancy. After that, a maximal exercise level, there is a blunted heart rate. It won't be increased to higher level. So, and also in the first trimester, there is a vasodilatation, decrease in preload and tachycardia. The third, there'll be expanded blood volume and increased stroke volume. So these physiological changes will make it difficult to attain the heart rate were calculated with 220 minus age. So again, you can use the TALK test. The simple thing I have talked regarding this in the previous session. We should target it on moderate intensity in the talk test. That means you cannot sing, but you can talk, and it don't reach the vigorous level. You can use this one. So very important thing: the Bogues rating of perceived exertion. You should target between fairly light to hard. That means 12 to 14. Anaerobic exercise or resistance exercise should be there. The most distinct changes during pregnancy, that as weight gain and shift of the point of gravity that results in progressive lordosis and LVA. More than 60% of all pregnant women experience low back pain and almost 50 to 70% thereafter. And strengthening an abdominal and back muscles could minimize the risk, can improve glycemic status, and can be used if aerobics are not tolerated, like walking is not tolerated in the third trimester. There's a simple exercise like pelvic tilt. These are bridging and anterior pelvic tilts. We can strengthen the core muscles. But the thing is, this can be used in the first trimester. Maintaining a supine position during exercise after 20 weeks of gestation may result in decreased venous return due to the compression of the vessels, that, leading to hypotension. So we should modify this exercise after 20 weeks of pregnancy, like sitting pelvic tilt or standing pelvic tilt or knee to knee wrist position exercises or sitting exercises and kneeling exercise with back stretch and also squats. And women should stop exercising when there is excessive shortness of breath, chest pain, pre-syncope, painful uterine contraction, leakage of amniotic fluid, and vaginal bleeding. And one exercise which is absolutely contraindicated is scuba dive, because the fetus is not protected from decompression sickness and gas embolism. And caution should be taken in horseback riding and cycling. Static cycling you can do, but gymnastic and cycling should be avoided or used with caution. And high altitude, more than 2,500 meters. Coming to the GDM, you know that this during the second half of pregnancy, insulin sensitivity falls, and there's a demand of insulin increase, and the placenta may not be, the pancreas may not be give more and enough insulin, and that result in GDM. And C, avoid high intensity exercise after the first trimester. Definitely, even if you are very, very active, you should avoid high intensity after the first trimester. And the pre-pregnancy physical exercise can reduce the GDM risk by 55%. Regular physical activity in the early pregnancy was also associated with the reduction of risk, but not as pre-gravid stage. See, these are the improvements in exercise in GDM, improvement in insulin sensitivity, improves blood supply to the active skeletal muscles, decrease in insulin secretion, decrease maternal weight gain, normalize blood glucose, avoid fetal macrosomia. See, in GDM, better to avoid weight training. As you know, that is weight training, not strengthening exercise. Weight training is an anaerobic exercise which uses glucose and there is high chance of hypoglycemia. And I will stop my presentation by saying, see this by Jill Churchill. There is no way to be the perfect mother, but a million ways to be a good one. See, this is Serena Williams practicing with her 2.5-year-old daughter. Her name is Olympia. Both are healthy. And salutes, this is Lady Alicia Montana, who participated in 2014 US Indo Games. See, she was 34 weeks pregnant at that time. And this is my reference. Thank you very much, Dr. Shabir and team, for giving this opportunity. Thank you very much. Over to the judges.
Thank you, Dr. Roy, for an excellent presentation on exercise in pregnancy. So, the discussion will be at the end of the symposium. We'll straight away go to the next topic by Dr. Wasim. He is an upcoming, very promising, young, dynamic physician and diabetologist working in Kraft Hospital. And he has graduated from Government Medical College, Tanjavur, with a fellowship from CMC Vellore. And he has many publications in index journals. And his topic will be how to initiate and titrate insulin therapy in pregnancy. So over to Dr. Wasim Ahmed for the topic.
Yes, Wasim, you can start. I think everything is ready. We can, yeah, we can see the slides. Okay.
Yeah, am I audible now?
Yes, yes.
Yeah. Thank you, Sabir sir and the team Diabetes today for giving me this opportunity. Dr. Sukesh has almost touched upon insulin and the management during pregnancy. So I'll be discussing more about, what, why, where, when, and how, and in whom we have to start on insulin. So pregnancy is always special, but sometimes due to the impaired insulin sensitivity and the increase in the insulin resistance, there is surge in the plasma glucose levels, and which can lead to adverse pregnancy outcomes, which can in turn lead to maternal and fetal complications. We have to tackle the trio presentation, that is the subset of people who have increased glycemic surge during the pregnancy, that they can be already a diabetic patient or a person who is turned with gestational diabetes during pregnancy. There is something called target and range, which according to me, the new TIR, we are very familiar with the time and range, but in pregnancy, there is this target and range which needs to be tackled. The HbA1c cutoff, it's to be maintained less than 6 according to the recent guidelines as well, but this can be relaxed up to less than 7 in case of severe hypoglycemia. That is only at the cost of a severe hypoglycemia if a pregnant woman is suffering from. And the fasting plasma glucose should be less than 95, 1 hour less than 140, 2 hour less than 120. It's already well discussed. Below, you're seeing a graph where this is the GDM diabetes patient who was planning pregnancy, and the basic sugars are almost well maintained. So it's said that the average sugar levels should be maintained around 105 to 110 for good results. So all the guidelines or all the organizations give the same cutoff 95, 140, 120, and most women do well with only lifestyle interventions. And the pharmacotherapy, be it insulin or OADs, can be started once the glycemic control is inadequate with MNT. So the ADA and the NICE as well as stick on to the same guidelines, but NICE in a good way also points out that in case we find out a fetal macrosomia happening around, then there is a need to start on insulin. Probably it could be because of the unidentified glycemic excursions, the hypoglycemic therapy. India is closely related to PPG because our food is most rich in carbs. So as you see, the postprandial glycemic surge happens almost half an hour to 1 hour later of the food consumption. So the insulin is definitely needed to control this glycemic surge. Although we take into consideration the 2 hour cutoff according to the Indian guidelines, but the international guidelines also say the 1 hour cutoff. So the prime reason behind this 1 hour cutoff and the 2 hour cutoff is that it definitely makes sense that both 1 hour and the 2 hour cutoff should be normal or within that range, that is less than 140 and less than 120. There is no point having a 1 hour postprandial values around 200 and a 2 hour postprandial value around 120. So it definitely makes sense that even the 1 hour cutoff should be made less than 140. Suppose we target the 1 hour cutoff to be less than 140, then definitely in most of the times the 2 hour cutoff is well below 120 according to my clinical experience. And this is the insulin secretion, the physiological secretion which happens. We have a bolus and a basal phase which is happening. This is the same type of insulins we have in the market as well in the artificial forms. The bolus has 2 peaks as you see, and the rest is with the help of the basal, that the sugars, the intermeal sugars are maintained in the normal. Insulin aspart, lispro, glutathione, which are all the rapid acting insulins. Then the detamol, degludec, and glargine, which are long acting, and the NPH, which is an intermediate one. And the ones I have marked in the red, circled in the red, they don't have much of clinical data, whereas glargine at present has some good studies upcoming with safety data available, and degludec is also under trials to be used in pregnancy. So let's look into the action profile of all these insulins. You see the effect starts very early when compared to the short or the regular acting one. That is the usual atrapid used earlier days. And the rapid acting, it starts very early and it gives a very good acting as well when compared to the usual regular insulins. If you see, the regular insulin lasts for almost, say, the effect if you start if you start the regular insulin, the effect of it's almost lasts about 8 hours. But it's not so with the rapid acting. It starts soon, sets off the postprandial excursions, and then comes back soon to the normal. So the NPH or the intermediate one, it usually peaks around between 6 to 8 hours or 8 to 10 hours usually, and then it waves off around 12 to 14 hours. The long-acting and the long-acting detrimer, glargine, and degludec usually have a kind of almost a flat profile, with degludec having a very flat profile. As you see, the rapid-acting insulins have a better PPG control and have a low risk of delayed hypoglycemia, which can happen with the regular insulins. And say the glargine and as well as the degludec, they have a good 24-hour post fasting or a pre-meal coverage and have a low risk of hypoglycemia when compared to NPH. Last, but it's fast. This is one of the fastest insulin which is available. You see, the pancreas secretes in this way, and the regular insulin secretes in this way, acts in this way, and the rapid acting, which we discussed, the lispro, aspart, and the glulysin, they act in this way. But the one in the orange, it is called the insulin Fias, which is recently available in the market in the last 2-3 years, and it has a good fast, quick onset of action, and it also gives us an advantage of timing the insulin even after the meals. Say 10 minutes after the meals is also fine. But when we start the regular insulin, we need to space it around 30 minutes before the meals. But with the fast-acting, ultra-fast-acting Fias, we can place it just soon after the meals as well. This is the list of insulins which are available. The ones marked in red belong to the C category, although FDA after 2015 has said that this labeling is not needed. But still, degludec and glargine are not to be used in because of medical legal issues, because they are not recommended. They don't come under the CADP. Basal insulin in pre-existing diabetes women. So we usually switch over people who are on glargine or degludec to NPH or detrimer during pregnancy. But glargine has shown us some safe and successful pregnancies. Even in my practice, I have used in almost quite a good number of patients, and they appear to be relatively safe. No fetal problems or any kind of anomalies or maternal complications have occurred so far. And the glargine and the degludec are unlikely to cross the placenta, and they don't have a compelling evidence to switch over to NPH. But there is no evidence as such for detrimer in case you have hypoglycemic episodes. Even with that, or you feel that the number of pricks are too much for the women, then you can use glargine if the patient is also accepting it equally. The RSSTI ESI consensus also say the same, that the rapid acting insulins are very much effective and safe during pregnancy. And they also mentioned that there is no safety or efficacy data available on the use of glargine, glulysin, and even detrimer in pregnancy is what they say. According to almost all the guidelines, our experience is almost the same as the evidence. We all know that the rapid-acting insulin gives very good results in controlling the postprandial sugars, and the NPH and the detrimer can be well used as basal insulins. And the regular insulins, the newer human insulins, are very less immunogenic and can be safely used during the pregnancy. This is the typical insulin requirement which we have been reading from the UG days. The first trimester requirement around 0.7 units per kg, second 0.8, third 0.9, term 1. And in extremely obese lady, the requirements can go even up to 2 units per kg. But this requirement is something which we need to think about. Let's go deep into the requirement. Say during the first initial period, there is an increase in the insulin resistance. And because of that, the insulin requirement is high. Later on, between 10 to 16 weeks, the insulin resistance drops up. Third, there is also an increase in the insulin resistance and the insulin requirement. And at the term, it almost plateaus off. Even to half of the pre-pregnancy values. One thing which we need to notice in this is that between the 10 and 16 weeks, if we have a patient who's already on insulin, make sure that you have an eye over this patient, because this patient can land up into hypoglycemia at any moment, and we need to adjust or titrate the doses or reduce the doses accordingly. It is said that after 16 weeks, for every week of pregnancy, there is a 5% increase in the insulin dose which is required. And the insulin regimens for hyperglycemia in pregnancy, there are two options which we can take: either a weight-based dosing or a trimester and a weight-based dosing. The weight-based dosing is from 0.7 to 1 units per kg per day into divided doses, and the trimester or a weight-based dosing, it's what I already discussed. If you take this into consideration, 2/3 of the total daily dose can be given in the morning and 1/3 in the evening. Out of the 2/3 in the morning, you divide it into 1/3 into a rapid acting, 2/3 into an NPH. Really complicated. Let's work it out in a case scenario. Or there is also a one dose for all regimen, NPH 20 and 20 in the night, 20 in the morning and 20 in the night, and rapid acting insulin 10 in the morning and 10 in the night. This is something flow chart. As you see, the 0.7 to 1 units per kg we already discussed, and 0.7, 0.8, 0.9. You calculate the basal dose, and the remaining 50% divided between the 3 meals as short or rapid acting insulins. This is another way of representing the same. You give a 50% of the basal insulin at bedtime, and you monitor the fasting sugar levels. If it's still high, then we'll have to increase the basal insulin by about 2 to 4 units. And we give the 50% basal divided into 3 meals, and we monitor the 1 hour, 2 hour sugars. And if it's well within cutoff, fine. If it's more, then we'll have to increase the dose by 2 to 4 units as well. Taking all these guidelines into consideration, let's work it out on a case. A 27-week primee, 60 kg weight, on
Sorry to
medical
interrupt.
nutrition therapy.
Please make it fast, doctor. But 2 or 3 minutes left.
Tablet metformin TID. Suppose we are going to take this lady into consideration, we'll have 48 units per day. And this is actually a very huge requirement and may not be necessary for this lady. So a fasting plasma glucose of greater than 110, we can start basal or intermediate acting insulin. PPG, if it's uncontrolled, you can start with a bolus insulin of 4 units. And if basal bolus is not convenient for the patient, you can always change it to a premix regimen. There are conditions where situations where people come, they don't accept for insulin, but you have to consider insulin postprandial. When the postprandial surge is greater than 200, definitely. If it's between 160 to 200 in the first and second trimester, try for MNT for 1 week and initiate insulin accordingly. And in third trimester, if there is greater than 160, then you have to start insulin immediately. There is no conclusive evidence for the threshold value at which clinicians should start the medical therapy. And it's basically pure logic where how we have to titrate between the pre-meal and the post-meal sugars. We have to titrate this accordingly. You can take a screenshot of that, and in case you have any doubt, you can just contact me, because the fasting pre-lunch and the pre-dinner all work well with the intermediate and the basal insulins. The post-breakfast, post-lunch, and post-dinner are controlled well with the short or the rapid-acting insulins. So the Indian government has already given us a flow chart of how to titrate and monitor the sugar levels. For want of time, I'm just skipping this slide. The technique during pregnancy is also almost same. There is no change in the insulin site. Lateral parts of the abdomen can be used safely. During the third trimester, when the abdomen is very much distended, the skin fold can be raised a little bit for proper injection. So antenatal steroids and insulin, these are situations where the pregnant lady almost escape, but sometimes they have to take insulin. Particularly in type 1, we have to start on insulin infusion, and when it comes to type 2 or GDM, during the day 1, the requirement almost increases about 25%. Day 2, it's almost 40 to 50%. Day 3 is the same. After day 4, it almost tapers off. The intrapartum management is also equally important. The latent phase of labor, the requirement of insulin is usually stable, but in the early phase, it's not that much. And we need to avoid the maternal hyperglycemia in want of to reduce the neonatal hypoglycemia and the fetal acidosis. This is actually a chart which you can just take a screenshot, can be used in your day-to-day practice.
Doctor, sorry, time is over. Please make it fast.
The mom returns back to normal, you can always reduce the dose to 0.5 units per kg per day. And this is something which I wanted to discuss in want of time and just skipping it. The good clinical practice always involves taking into consideration the socio-cultural background. And there are few situations where people can be allowed to take cheat meals as well. And between the multi-dose insulin and the continuous subcutaneous insulin infusion, there is not much of difference. And we should take a shared decision making with the patient, and a personalized precision medicine is the need of the hour. Thank you very much for the opportunity given.
Thank you very much, Dr. Wasim, for an exhaustive presentation on insulin therapy. So, going to the next topic, I invite Dr. Purvi Chawla, who is a consultant diabetologist and a clinical researcher at Dinar Diabetes Research Center and Mumbai Diabetes Research Center. She is also an honorary consultant diabetologist at Bharatiya Arogya Delhi Hospital, Mumbai.
Hello.
She was the organizing secretary for Women and Diabetes 2020 and organizing committee Challenges in Diabetes 2018, 2019 and 2020. And she is a trainer for several courses like NDEP and courses for dietitians and nutritional experts. So the topic is role of OHAs in diabetes in pregnancy. Over to you, doctor.
Thank you so much for that kind introduction. Can I share the slides? Thank you, Dr. Sabir, for this lovely invitation. The speakers were fantastic before this, and I've enjoyed every single presentation. Although the camera was off, I was listening and following everything. Can I share my screen, please? Is that visible?
Yes, visible.
Okay. So just a short prayer for all the victims last evening and their loved ones who have to bear this tragedy. And with that, we go on to the main topic. So with all these, 6 lectures before me, I think any degree of glucose or carbohydrate intolerance with onset and first recognition during present pregnancy as endorsed by IADPSG and DIPSI as well since 2014 is no surprise to this august audience. The IDF 2019 Atlas said that 16% of prevalence of hyperglycemia in pregnancy existed, impacting about almost 20 million live births, and 84% were attributed to GDM. So that's a huge number we are dealing with. India too is no less. The prevalence is anywhere between 4 to 21%. As you can see, across the states, it's slightly different, with the highest prevalence in South India. And this prevalence is also expected to increase by 15%, reaching the final figures to almost 80 million by 2030. So that's a huge number we are talking about. Asians with their predisposition to type 2 diabetes, this is definitely something that should be alerting each one of us focused on diabetes care. Again, this audience already is well informed about the transgenerational risk, diabetes begets diabetes, and it's beautifully shown here in this diagram. I will not belabor much on this point because I think it's made well throughout all the presentations. With this, we urge everybody to improve the pregnancy outcomes. And again, lot has been talked about how we improve the pre-pregnancy care, and I will not deliberate on that. But for pregnancy outcomes, we need to control the glycemia better and improve the time and range. Again, continuous glucose monitoring is also going to improve the outcomes. Diet, exercise, limit weight gain is the mantra for pregnancies. With that, I think medical nutrition therapy controls almost 70 to 80% of GDM. The role of metformin has changed gears a bit in the last few years, and we'll see how in the subsequent slides. And insulin is definitely the mantra again, and it was beautifully described. The technique, the different types of insulin, everything was described very well in the previous presentation by Dr. Basim. So with that, I want you to focus on metformin. Metformin is nothing but a biguanide derivative from the Galega officinalis plant, which the picture of which I have put here in the slide. We have over 65 years of metformin use experience with us. And this is a drug that gets highly concentrated in the small intestine, liver, and kidneys. It is positively charged, concentrates again in the mitochondrial level up to 1,000 folds due to the organic, the cation transporters. The remainder is excreted in feces with no active metabolites. So this is the drug we are talking about. Besides the primary action in the liver, where it suppresses gluconeogenesis through the AMPK pathway, it has pleiotropic effects on multiple tissues, including anti-cancer effects, the change in gene expression, positive microbiome effects, and anti-inflammation. So metformin is a wonder drug. And let's see how its use has been promoted in pregnancy. And then, there was a sudden break. And let's see the data or the scientific evidence we have so far. So the MIG trial, or metformin in gestational diabetes study, one of the largest randomized controlled trials of metformin in GDM, where 751 women with GDM were randomized between 20 to 33 weeks of gestation to either receive metformin with or without supplemental insulin or insulin alone. The primary outcome in this trial was a composite of neonatal hypoglycemia, respiratory distress, the APGAR scoring, birth trauma, need for phototherapy, or premature baby. The secondary outcomes were also markers of neonatal and maternal health. And what did we find? This is the primary MIG trial result conclusion published in 2008, that amongst these women, which had almost 46% Caucasians and the rest Polynesians, Asians, and even Indians in the study, they found that almost 46 or 50% in the metformin arm failed therapy or did not reach glycemic targets and required supplemental insulin. And the overall conclusion was that in women with GDM, metformin alone or with insulin is not associated with increased perinatal complications as compared to insulin. And women globally preferred metformin to insulin therapy. This is no surprise. So this was in 2008, and since then, everybody was using metformin and even glyburide for GDM, for managing, controlling glycemia during GDM. Now, in 2017, there was a sudden break on this trend of metformin use by ACOG, where ACOG is the American College of Obstetricians and Gynecologists, and they suddenly brought insulin much higher up, and they said insulin was the choice of agent. And the ADA also took a similar stand, saying insulin was the preferred choice of GDM management. The next year, the following year, they softened their stand a bit because there was a lot of protest from the obstetricians or some sort of resistance, because simply because insulin is not cheap and not very easy to use or convince the patient to take it. Hence, they withdrew that stand and then they softened it, saying that metformin or glyburide could be a reasonable alternative choice. And we need to explain to the patients the lack of long-term safety data and also the fact that some of them may proceed to receive insulin in future. The Society for Maternal and Fetal Medicine in the same year stated, in fact, they brought up metformin a bit and they said that metformin is reasonable and safe first-line pharmacological alternative to insulin, recognizing that half will still require insulin. So there was a sudden shift again in 2018. And let's see what the data was and why did they suddenly say so. So this is the MIG tofu trial, which is nothing but the long-term follow-up of the original MIG trial, which I showed you the results of, published in 2008. This was almost 10 years later, 2018. It was released, and this was the body composition and anthropometric outcomes of at 7 to 9 years of age in the offspring. So while the original trial was analyzed as a single or a total cohort, they decided to analyze the offspring data in terms of two separate cohorts. One was from the Adelaide side and one was from the Auckland side. And the Adelaide one, they found that there was less insulin use, but there was increased LGA or large for gestational age found in the metformin arm versus insulin. At 7 years, there were no differences found. Similarly, in the Auckland cohort, they found that there was more insulin use, but there was no difference in LGA found. And at 2 and 7 and 9 years of age of the offspring, they found increased anthropometric measurements and increased body fat as seen by MRI. So this was the turn that suddenly brought the long-term fetal effects of metformin to light. Another study, a very important study released last year by Lancet Child and Adolescent Health in March 2019, the PEDMED study, which was nothing but the 5 to 10 year follow-up of the original PREGMED study, found that in 141 children who consented to participate, they found that children in the metformin group had higher BMI scores, significantly higher waist circumference, and also weight in the metformin arm rather than the control arm. So this was again some more corroborative data to the MIG tofu results. This is nothing but the follow-up of two randomized control trials that evaluated metformin in PCOS pregnancies and the outcome at 4 years of age in the offspring. They
Again,
found
sorry to
2.2.
interrupt, ma'am. Please make it fast. 2 or 3 minutes.
I'll need 5 minutes more. 2.2
Only 2 or
times
3 minutes.
increased.
Please make it fast.
Increased overweight obese at 4 years, and this trend almost started at 6 months of age. So in 2019, this wonderful review by Dr. Barber and Frege, they concluded that metformin does not prevent GDM and modestly lowers glucose. And they also reflected that if there was an inability to adapt to postnatal environment with nutrient excess in infants exposed to metformin. Another review also sang the same song. They questioned the long-term effects of metformin and they said that we need further studies to look into that. So again, in terms of, and this is the latest paper, 2020, in May itself, they compared various pharmacological agents and they did a systematic review and meta-analysis of the effect in GDM, and they found that long-term data was required. So what did we do? The ADA Standards of Care 2020 clearly endorsed they clearly endorsed insulin, but said that in case insulin is not being able to use, then metformin is a good alternative to that with some exceptions. And they said in case of PCOS pregnancies, metformin should be discontinued at the end of the first trimester. In terms of several other guidelines world over, again, they all have said the same thing, that women who are non-adherent to or refuse insulin, glyburide, or metformin may be used as effective agents. In fact, there are Indian authors also who reflected on all this data, and they said that maybe it could be considered in milder forms of GDM where glycemic goals were not attained by lifestyle changes. So we are awaiting two major trials, MIGHTY and MIGHTY Kids, which will throw some further light on that. With respect to glyburide or glibenclamide, again, a major trial was reported, and they found that they concluded that in women with GDM, glyburide is a clinically effective alternative to insulin therapy. But because there is a lot of conflicting data or controversial data from different studies, the overall conclusion is that long-term follow-up data of children exposed to glyburide in utero to establish the long-term safety is required. Alpha glucosidase inhibitor, carbos, has also been studied, and there are some encouraging reviews, but none of the guidelines endorse that. So with that, I come to the Indian guidelines, and what do they say? That metformin or insulin therapy is the accepted medical management of pregnant women with GDM not controlled on medical nutrition therapy. Insulin may be started at any time. However, in pregnant women with GDM before 20 weeks, if MNT fails, then insulin should be started, but metformin may be used at 20 weeks of pregnancy if MNT has failed to control the blood sugars. Metformin in the dose of 500 milligrams twice daily orally up to a maximum of 2 grams per day is again endorsed by them. And if blood sugars are still not controlled with the maximum dose of metformin and medical nutrition therapy, insulin to be added. They also reflect that hypoglycemia and weight gain with metformin are less in comparison to insulin. And if insulin is required in high doses, again, metformin may be added. This is our homegrown Indian guidelines, which endorsed by DIPSI as well. So my take-home message for today is that GDM management for several reasons is extremely important. Pharmacotherapy is required if medical nutrition therapy fails to achieve our glycemic targets. Insulin is the choice for GDM. Metformin is truly a multitasking oral anti-diabetic agent with several pleiotropic effects. Even though metformin is not teratogenic, insufficient evidence to continue metformin after conception in patients of PCOS is present, and definitely best avoided in placental insufficiency. Thus, metabolic agents that cross placenta with multiple mechanistic actions have to be used very cautiously because fetal programming in utero is an important consideration guiding our choices to control maternal hyperglycemia. Thus, the best suggestion would be to follow local guidelines and look out for important trials outcomes data. So metformin may be used wherever it is not possible to initiate insulin after 20 weeks, but with adequate caution. Thank you so much for a patient hearing.
Thank you very much, Dr. Purvi. It was an excellent presentation. I think you have covered almost all the aspects of OHA usage in pregnancy. So the floor is open for discussion. One or two questions. So one question to Dr. Purvi. If a lady around 25 years come with a already a diabetic, she is a type 2 diabetic, and if she is already taking on a sulfonylurea like glimepiride, and her HbA1c at the first visit itself is 7.8 or something, what will you advise? Will you advise her to continue it or change over to insulin?
Okay, so again, I think this is a very important topic where continuing or discontinuing drugs in case of type 2 diabetic patients who get pregnant, and we commonly refer to this as pre-GDM. My take on this is that I would discontinue the glimepiride and switch the patient on to insulin. We don't have adequate data with glimepiride. There may be anecdotal evidence. Several experts may say that it's completely safe if you use it well, but our guidelines currently don't say that. So, and there are these two big trials that are underway, which have been specifically designed to look at the continuation of metformin or glimepiride in patients of type 2 diabetes who get pregnant. So we'll wait for those outcome trials also to be reported. But until then, I think I would switch to insulin for sure.
Thank you, ma'am.
And of course, medical nutrition therapy, because half the battle can be won there itself.
Any other question? For the want of time, I think we can close the session if there are no more questions. And thank you, Dr. Sabir and all the organizers for giving me this opportunity.
Thank you, Sabir and team.
Over to the organizers.
Thank you. So before going into the next session, we will have our theme music. So, moving on to our next session, something different. To chair the session, let me welcome Dr. Chaco Varghese, Senior Consultant Nephrologist, SUT Hospital, Pattam, and Dr. Ravindran A.V., Specialist in Internal Medicine, Badr Al Sama Hospital, Oman. Welcome, yes.
A very good evening to all of you. Let me at the onset congratulate Dr. Sabir for organizing this wonderful update 2020 on diabetes mellitus. Now let us move on to diabetes and the kidneys. The topic for the next session is diabetic kidney disease, diagnosis and management. As we all know, more than 50% of patients on dialysis all over the world are due to type 2 diabetes mellitus, and it is becoming a big economic burden for countries like USA, Europe, and India. And to talk about this very important topic, we have with us today Dr. Rajesh VV, who is a consultant nephrologist, who is American board in internal medicine and nephrology, a specialist in clinical hypertension, clinical adjunct professor in Texas University Health Science Center, and medical director at Davita Dialysis Center. Over to Dr. Rajesh, please.
Can you all hear me well?
Yes.
Okay, thank you. Thank you for the kind introduction, Dr. Varghese, and the introduction and the kind words. Let me go ahead and share my content. Can you all see my slides?
Yes.
Okay. Thank you. Let me Dr. Shabir Rashid and his team for this great effort to organize this wonderful event. I've been watching also all the great talks, especially I feel grateful to be part of this, especially in my hometown. And also I would like to thank his team to give me the opportunity to talk about this topic today, which will be approach to diabetic kidney disease with special focus on diagnosis and management. So the topics I'm planning to discuss today are epidemiology of diabetic kidney disease, a few aspects of the historical events that happened, pathophysiology of diabetic kidney disease, diagnostic methods, conventional therapy, as well as novel agents. Now, I got to admit that I won't be doing justice to the topic in the 15 minutes that I'm planning to talk. But so I'll be highlighting the renal aspects of the main sections of the topic. So as we all know, diabetes has reached epidemic proportions around the world. The 2019 IDF data, 463 million people, approximately 9% of the world population is having diabetes and 77 million in India. So from the word go, the diabetes mellitus had always had some connection with the kidneys. The word diabetes is a Greek word which means pass through, and mellitus is a Latin word which means honey sweetened. So for many centuries, diabetes was regarded as a disease of the kidneys. Even in ancient India, around 400 BC, the great physician Sushruta, he mentioned about madhumeha or honeyed urine disease. Later on, a lot of works were done by several great physicians and scientists, including Dr. Richard Bright, which many consider as the father of nephrology, who described proteinuria, which later on was called as Bright's disease as well. And we all also know about the Kimmelstein-Wilson also, who described the peculiar diabetic lesions in the glomerulus of the kidney, which we'll be checking out in the histology sections. So now we know diabetic kidney disease affects 20 to 40% of all diabetic patients, including type 1 and type 2. It remains, as the chair mentioned also, the primary single cause of end-stage kidney disease or causing dialysis therapy in the patient. The incidence of diabetic kidney disease cause of the end-stage kidney disease keep on rising every year. So diabetic kidney disease is considered a progressive renal disease. It's a complication of prolonged hyperglycemia. It's very uncommon within a decade of the duration. Like I said, the highest incidence are seen 10 to 20 years after the onset of disease. So you still have a lot of time to work on to prevent this complication. So this is a conceptual model which was proposed to show the events which is happening. As you can see, from left to right, you move years after the onset of diagnosis, and the hyperglycemia, if you let it persist for those many years, you can see these changes especially happening in the kidney. So it starts as cellular injury, and if it persists, continues to cause mesangial expansion and inflammation of the kidney. So clinically, what you see is you start seeing proteinuria, then microalbuminuria, macroalbuminuria, and also the overt nephropathy. Initially, you see GFR rise and then normal, and you can see a drastic a drop in GFR as well, and you start seeing other complications of diabetes too. So I will explain a little bit detail in this slide. This is a beautiful study done by Mogensen and et al. To show the natural history as well as describe the stages of diabetic kidney disease. As you go from zero at the onset of the disease to very many years, you can see it going through the different stages of diabetic kidney disease. The first stage is called glomerular hyperfiltration, where you can see the red line is what it says about the GFR. So initially there will be a hyperfiltration, an increase in GFR, which can sometimes fool us too as clinicians. If you do the ultrasonography, you might see an increase in kidney size. As you all know, kidney size typically is 10 to 12 centimeter, and you might see an increase in the size in the kidney. You don't see much proteinuria. This blue line shows the proteinuria, which you may not see much during that stage. The second stage is something called silent stage, where the hyperfiltration is over and you see a normalization of GFR. You might see structural changes happening in the kidney, and you might or might not see microalbumin. By the third stage, incipient stage, which lasts from 5 to 10 years, you start still the GFR relatively stays normal, and you might start seeing the rise in proteinuria, especially to the microalbumin range, which is like 30 to 300 milligram per day. If you continue to let the hyperglycemia persist, then you see the stage 4, which is overt nephropathy, where you see a drastic reduction in GFR, as you can see from the graph, and a big rise in the proteinuria, especially to macroalbumin range, which is more than 300, or even to nephrotic range proteinuria, which is 3000 or 3500. You start seeing increased incidence of hypertension in these patients. You start seeing retinopathy changes, and kidney size might, due to the lesser hyperfiltration and all, you might see a normal kidneys with the ultrasound. And that stage usually is seen clinically between 10 to 20 years. And if you still continue to let the hyperglycemia persist or proteinuria persist, then you might unfortunately see the end-stage renal disease stage, where patient have to depend on peritoneal or hemodialysis. So as we looked at it, all these changes usually happen as hyperfiltration in the glomerulus, which can lead to a lot of hemodynamic, metabolic, and inflammatory changes, as well as intracellular changes, leading to all these pathological changes that we talked about. So this is on the left side, you have a normal glomerulus, and this diagram depicts what happens in the glomerulus. As you can see in the green structure here, you have the glomerular basement membrane, which is much thickened compared to this. You see loss of podocytes. You lose loss of podocytes on the right-hand side, as well as effacement of the food processes here. And the main thing is also about the mesangial expansion that happens compared to this normal slide. This is also a picture of the normal glomerulus here, and you can see stages of inflammation happening, and more mesangial expansion to the point where you can see the Schimmelstein-Wilson nodules, like I mentioned in the historical section, that these are pathognomonic of diabetic kidney disease. This is an electron microscopic picture. It's a normal glomerulus. As you can see the basement membrane not much thickened, as well as you can see the food processes there, but which is not very appreciated in diabetic kidney. You can see the mesangium is much expanded here. You can see the thickening of the basement membrane, as well as loss of those food processes. So let's move on to the diagnostic methods. The gold standard remains renal biopsy, but fortunately, we don't have to go for renal biopsy as being an invasive procedure. We don't have to rely on it, as we are able to, as good clinicians, we are able to take good history and lab evaluations to make the diagnosis. The diabetic kidney disease is defined as persistently high urinary albumin to creatinine ratio, more than 30 milligram per day, or reduction in eGFR below 60 ml per minute, and long duration of diabetes as explained in natural history, around 10 years, as well as diabetic retinopathy. So screening recommendation for diabetic kidney disease is with urine protein to creatinine ratio, as well as serum creatinine and eGFR measurement. It's recommended annually for type 1 diabetes beginning 5 years after the diagnosis, and annually for all patients with type 2 diabetes beginning at the time of diagnosis. So in like I mentioned, in patients with proteinuria, diabetic retinopathy is a strongly suggestive of diabetic kidney disease, and the preferred test for proteinuria remains urine albumin to creatinine ratio. A spot sample is fine, preferably in the morning, and you should at least have two out of three samples positive, collected over 3 to 6 months period, just to make sure the proteinuria is persistent and not just transient proteinuria. The eGFR should be calculated based on the serum creatinine concentration. You could use CKD-EPI equation or MDRD equation. Both are acceptable. So like I said, biopsy is not typically considered, but some of the scenarios we may have to rely on biopsy to make a diagnosis, especially there is atypical presentation of kidney disease. Like I mentioned, if there is absence of retinopathy, especially in type 1 diabetes, or if you see albuminuria less than 5 years or more than 20 or 25 years after the onset of disease, if you see immunological markers or patterns of nephritic syndrome or hematuria or a rapid decline in renal function, you may have to depend on the kidney biopsy to make a diagnosis. So let's move on to the therapeutic area, or how you approach the therapy of diabetic kidney disease. 60 years ago, a diabetic patient with proteinuria might have only survived to 3 years. So thankful to all the great clinicians out there and all the new drugs that we have, the survival is much longer now, but we still have seeing a lot of great burden in the in morbidity area. So early diagnosis is still the key and have shown better treatment outcomes. So therapeutic goals should be to prevention of diabetic complications, especially diabetic kidney disease, by long-term intensive very early on in the course of the disease. Why? Because the intensive glucose control after the onset of complications, or if you let the diabetes run long-standing, then it has not shown much reduction in the progression of the disease or even into improving overall clinical outcomes. So target A1C should be around 7% with the kidney patients. For dialysis patients, we recommend around 7 to 8%. The lower A1C goals of 6 to 6.9 hasn't showed much reduction in cardiovascular or microvascular complications in this population. And also you have to keep in mind the risk of severe hypoglycemia and its deleterious effects. So American Diabetic Association recommend target based on age, comorbidities, or life expectancy. Again, I have to mention that if you look at different, as you all are aware, like different association may have different guidelines. I just have to stick with few, and you all can read about it. So ADA recommend more stringent goals like A1C of less than 6.5 very carefully. If patient is younger with shorter duration of diabetes and not much complication, or if they have longer life expectancy. But if the case is otherwise, like older age with more complications and limited life expectancy, better to have A1C less than 8, again to the risk of hypoglycemia. So regarding each agents in different class, sulfonylureas are still used a lot. Better to use short-acting glipizide or glimepiride. Biguanides, metformin, like mentioned by the previous speakers, like a wonder drug, we still consider as wonder drug, still have a lot of good effects. But kidney-wise, you should be avoided with a GFR of less than 30 ml per minute. Always be careful with acidosis. Renal dose of rapaglinide and natiglinide can also be used. Regarding DPP4 inhibitors, linagliptin does not need much renal adjustment. Sita and Saxa does. Thiazolidinediones like pioglitazone are typically avoided, especially with the presence of edema or CHF. Alpha glucosidase are also not much recommended. Insulin therapy is considered, especially if patients fail therapy, and always start with a lower dose. You don't need much dose adjustment if GFR is more than 50. Hemodialysis patient, we prefer oral. The hypertension management, we again for the type 1 diabetes, we see 5% of the patient having hypertension at 10 years after the onset, 33% after 20, and 70 after 40. We see a close relation between hypertension and albuminuria, and volume expansion and increased arterial stiffness is considered the culprit. Based on the different trials, the blood pressure goal, especially by JNCA recommendation is 140/80. Again, the recommendations might change. Regarding the initial agents of choice, you could have the thiazide diuretic, calcium channel blocker, or ACE or ARB. Especially if there is albuminuria, you need to include ACE or ARB. And combination is not recommended due to hyperkalemia and risk of acute kidney injury, and no much clinical benefit based on the on target and the VA nephron study. Beta blockers are less favored, as mentioned before, due to masking of hypoglycemia symptoms and reduced exercise tolerance. Carvedilol has shown some advantage. Alpha blockers should be avoided due to orthostatic hypertension. Lipid lowering agents should be considered. Lifestyle modifications should always be considered, including dietary intervention, regular exercise, weight loss, and smoking cessation. Regarding newer agents, there was extensively studied leader study and sustained 6 study. They have shown better cardiovascular outcomes and slowed the progression of kidney disease due to the mechanism of action like glycemic control, weight control, and direct effects on the kidney. So they could be used with caution even in advanced kidney disease like liraglutide, dulaglutide. Exenatide is used mostly early diabetic kidney disease. SGLT2 also been well studied recently, like studies like EMPA-REG outcomes study. They have showed lower rates of death from cardiovascular disease and heart failure, hospitalizations and death from other causes, and also shown better clinically relevant kidney outcomes like less nephropathy and doubling of creatinine. So they could be also used like DAPA, CANA, and empagliflozin, shown beneficial early kidney disease, not effective if GFR is less than 30. There are some novel agents being studied also targeting glomerular hyperfiltration, inflammation, and fibrosis. So in summary, we have talked about diabetes as a leading cause of kidney disease. We talked about the screening tools and criteria for albuminuria and eGFR. We talked about the goals of therapy, including A1C goal as well as hypertension goals. We talked about the agents of choice in each class as well as renal dosing. We talked about the newer agents as well as the cardiovascular benefits. So by that, I would like to thank you all for the attention, and again, thank you for the great effort put by the organizers in organizing this event and giving me this opportunity. Thank you all, and I'll be happy to answer any questions or hear any comments.
Thank you, Dr. Thank you, Dr. Rajesh, for that excellent lecture. I think we will take up the question answers at the end of the session. We'll take the question answers after the other sessions.
Okay, thank you so much. Thank you. I will be available then. Thank you.
You are welcome.
Hello, good evening to all. The next talk is on remote blood glucose monitoring system, a boon for diabetes management in pandemic. To talk on this, we have an eminent speaker, Dr. Manoj Chowda. He is a senior consultant diabetologist, Lina Diabetic Care, Mumbai, and is a lecturer for the postgraduate diabetology course conducted through CEP, Mumbai. He has been principal investigator for various global clinical trials for new anti-diabetic drugs. The co-founder of United Diabetes Forum and organizing chairperson for Challenges in Diabetes. He's a reputed speaker in many national and international forums. Over to you, sir.
Thank you, Dr. Ravindran. Pleasure being introduced by you, and thank you, Dr. Rashid and team, to invite me here. Okay, finally I can see my host rights to be able to share my slides. Okay, is my full slide seen, please?
Yes, sir. Yes, sir.
Yes. Sir. Okay, thank you. Right. So the topic that I've been asked to speak for is remote blood glucose monitoring systems, a boon for diabetes management in pandemic situation. There's a disclaimer that I've been asked to speak for this specific product, Contour, and their new glucometers, and emphasizing on the impact of SMBG in India. So maintaining a good glycemic control is, of course, crucial in the management of diabetes because it would otherwise be associated with micro and microvascular complications. SMBG today we realize is a simple and practical tool for maintaining good glycemic control. But when you look into the Indian perspective on SMBG, there clearly seems to be lack of education about the purpose of SMBG and the correct process and schedule. It's been pretty unclear in terms over the years about how often should you do it, what you should do about that data. And hence, over the years, because it's a self-pay market, it has led to very limited SMBG practice in India. And there's been an unmet need for country-specific SMBG recommendations till, of course, a few years back when some of us were invited as part of the RSSDI consensus on self-monitoring of blood glucose. This was led by Dr. Makkar from Delhi, and many other colleagues joined in to come out with the RSSDI recommendations for SMBG in type 1 and type 2 patients. Now, these are the recommendations that we came out with, which speak about the frequency for SMBG in patients with type 1 diabetes. Then in type 2, those who are on oral anti-diabetic drugs, type 2 on insulin with or without OADs. But what we also did was spoke about the SMBG frequency in limited care. So this is the ideal aspect as to the frequent readings required. And then in limited care, where there are issues with constraints of finances and availability, then we came out with limited care recommendations that there should be at least minimal SMBG done in these patients, again differing between the type 2 and type 1 group. We also spoke specifically about the recommendations for different insulin therapies. If somebody is on basal insulin, we spoke about doing fasting levels at least twice a week or once in 3 days. And then if somebody is on premix insulins or a basal bolus regimen, then an increased frequency from safety and lack of hypoglycemia point of view. Moving ahead, when we talk about the emerging technologies, which is changing the horizon of diabetes management, well, clearly today, when we speak about continuous glucose monitoring, then moving on to the more recent flash glucose monitors, which have become the norm, it's now moving towards the connected meters. So we're not looking at plain, simple glucometer usage, but towards connected glucometers, because all of this is making it extremely simple and convenient for the end users, that is the patient. It allows remote monitoring. That means the patient and the healthcare practitioner can share the data. And similarly, this can be shared with other families which may be anywhere across the globe. So extremely patient-friendly aspect, which is leading to an integrated diabetes management. Diabetes management is evolving. Greater connectivity within patients, healthcare practitioners, and payers. You have smart blood glucose meters, patients who are ready to do their lifestyle intervention, keeping their healthcare practitioners involved in their choices. All of this allows us to interconnect the diabetes management, because this is the need of the hour. The conventional aspect that we've been doing, an occasional SMBG, non-structured SMBG, or just going to the laboratory once in 3 months, getting a reading done, maybe even an HbA1c, we may be losing a lot of touch points as to where we can help the patients more. So an interconnected diabetes management, where the patient is not only checking regularly, but has the means of sharing the data with the healthcare practitioner and the family, which can keep a watch and keep guiding the patient, seems to be the need for the hour. So new opportunities for digital health to thrive. So mHealth or mobile health is defined as the delivery of health services and improvement of health outcomes via mobile and wireless devices. And this has been a boon, especially in the last 4 to 5 months of the lockdown because of the pandemic. This is what has allowed patients and us to remain connected. They've been doing more SMBG. They've been sharing the data through means of these kind of apps and technologies that we have, and allowing us physicians to help the patients to maintain good metabolic health. So mobile app technology can empower patients to better manage their disease, and digital health can be useful to not only support diagnosis, but the monitoring can lead to changes in behavior to support treatment and prevention. Let's understand and remember, in diabetes, unless you monitor, you will never know how you're doing. It tends to be a silent disease and a silent killer, and it's the only way to figure out as to how what kind of metabolic health you're maintaining. Monitoring is the biggest mantra for patients with diabetes. So the information, motivation, and behavioral skills model is what we are talking about. Information, people with diabetes require actionable information, and hence the kind of SMBG that they needs to do needs to be discussed and explained to them, which is structured and which is going to be effective. This also leads to motivation, where patients with diabetes need to be motivated to act on information. So spending time and explaining the required changes based on the information that they get through monitoring motivates the patients to do better. And of course, this also enables them to adopt behavioral skills, which will require them to, or help them rather, to improve for their metabolic health, whether it is changes in their lifestyle, changes in their exercise, changes in their diet, and so on and so forth. Here we are introducing the Contour Plus One system. This is the Contour Plus One system, which is a meter tailored to different patient needs. Well, it is informative. So patients are provided with instant feedback through the smart light feature. Those who even want to just tap it, they can start seeing the light to make sure that they are introducing the strips correctly. It is remarkably accurate as per the ISO standard, and it is a very simple to use machine. Now, this is the components of the Contour connected system. You have the test strip, you have the meter, and then you have the app, which can be downloaded easily on the iOS or the Android systems. And then, of course, this gets connected through cloud, maybe share information with doctor or any of the other family members anywhere in the world. Contour Plus One meter helps your patients to test their blood glucose with confidence. You can just double tap here, so you get the light. You introduce the strip here. In insert the test strip and apply blood to the contour plus test strip, as simple as it's seen here, which a lot of other meters also have, but this really makes it look much, much simpler. It has a smart light feature, I think, which is appreciable, and I'll tell you why. So the smart light feature instantly tells your patients if their blood glucose reading is within the target range, and you get the green color, above the target range where you get the yellowish orange color, and red, which is the below target range. Now, what is different as compared to some of the other systems is the other systems have given the color red if your sugars are in the higher range. But I'm sure all of you will appreciate that hypoglycemia is a bigger red signal and danger than sugars in the hyperglycemic range in the acute short-term period. And hence, I appreciate this color coding here, where the red is given the below target range as a sign and signal that the patient needs to take action. Of course, if it remains in the yellow orange zone for a long time, you need to consult your doctor as well. Importantly, we always hear from patients that by the time they could introduce or touch the blood strip, the glucose strip with the blood sample, the machine went off and the strip was wasted. Now, which is where they have improved here, that there is a second chance sampling. If somebody hasn't gotten sufficient blood through the prick, they can re-prick and get a drop of blood, and they will not land up wasting the strip, and of course not land up wasting the money. Because this has been one important reason, the improper usage or the wastage of test strips, which has led to patients not doing frequent SMBG, and machines and systems like these definitely are helping us in changing that. So blood glucose monitoring systems perform better when highly accurate. This has a smaller, less than 10% error of margin, which has been one of the landmarks and accepted levels. And then you have the Contour Diabetes app, which is an easy to use and easy to teach tool designed to manage diabetes, reducing the effort needed to capture the data. So automatically when you are using that through Bluetooth, the information gets transmitted and available in more than 50 countries. Contour Diabetes app contains insightful feature. So you can review your results. You can add events to the readings. If you see a high reading and today I had indulged, or there was a festival, there was a celebration, you can add that comment. You can also set up smart alerts that if my sugars are constantly, there's a pattern of it going low at a particular time or going above, I'll get an alert. Structured testing reminders, again, can be inserted into this app, and easy shareable results. Some of the selected app features which I'm showing here are my patterns. So here you can see that the patient can identify their patterns if they want to see what's happening to me on every Monday. For some reason, my Monday is different from other days. Maybe I have a holiday on Mondays, so is my pattern different? I want to see reports in a different format. I want to see the entire log. I want to see what's happening in the last 15 days. I can have my test reminder plans. Am I due for my testing? Am I due to see my physician? And of course, those who are on insulin, and especially the type 1 patient, those who want to enter the data for their carbohydrate intake and try and match the insulin to carb and measure the insulin to carbohydrate ratio, again, there is means of entering this data and matching the insulin and carbs. Now, this is a study which I'm quoting, which showed real-world evidence in more than 5,800 patients with people with diabetes, which showed that the use of Contour Diabetes app for more than 180 days significantly decreased the likelihood of hypoglycemia, significantly decreased the likelihood of severe hyperglycemia, which was more than 250, significantly increased the blood glucose testing to 4.5 times a day. So because this was accurate in helping the patients, the frequency increased in these patients and showed consistent beneficial effects on prevention of hypoglycemic events. The Contour Diabetes app also allows easy sharing of results. And this easy sharing, as I mentioned earlier, is a boon because sometimes when you're worried about your family and you're living separately, again, I refer to the times in the pandemic, families living separately, different cities, lockdown, different countries, you are able to monitor and track the health of your loved one because whoever is using the Contour and the app is able to share their data across with family as well as the healthcare practitioner. The structured patient reports can be sent directly to the healthcare practitioner, and that again is helping the digital connectivity in times of telemedicine today. We've been using a lot of these apps and the connectivity with the patients, asking them, those who are afraid to get out for testing, not even wanting to come to the clinic, stay at home, stay safe, monitor your sugars, please send us the data, and we'll interpret and help you with what needs to change, if something at all. How to install the app? I think very simple. You could get on to the App Store or Google Play, and this can be for every patient and user, they can install it. Finally, let me remind all before I end that SMBG as a component of the education and treatment program is extremely crucial. Even though there are advancing technologies, we may be using a lot of CGM and FGM, SMBG still continues to be extremely relevant and widely used. It's important for diabetes education and understanding, important for glycemic assessment, extremely important to introduce behavioral changes, and optimization of any therapy we use, be it insulin or the oral drugs. And the impact of all of SMBG towards improved metabolic and clinical health, the safety of the patient, improved quality of life, and of course, economics in the long run. Today, if you remain under control, you'll avoid the cost of complications in the long run. And that's what we need to explain to our patients as well. Thank you all so much for the patient hearing. Handing it back to the chairperson. And thanks again, Dr. Sabir, for inviting me.
Thank you, sir, for the excellent presentation. The topic is open for discussion. If there are any queries, please unmute and ask.
Thank you, Dr. Ravindran, for taking the queries here, because if there are any, I'll be happy to answer. I need to jump into another session in half an hour, so I may not be able to wait for the full session.
Okay, sir.
Any queries, please, I'll be more than happy to answer them.
I think if there are no queries, we will wind up the session. Thank you once again, sir, for your excellent presentation.
Thank you, and wishing you all the best. And hi, Dr. Sunil Kota, and I'll catch a bit of your presentation before I move out. All the best. Bye-bye.
Hi. Thank you.
Hello. We can now move on to the third topic, which is every ultrasound abdomen shows fatty liver. What to do? To talk about this, we have with us Dr. Sunil Kota, a senior consultant endocrinologist, diabetes endocrine clinic, Berhampur, Odisha, India. And he is a speaker in many national forums. Over to Dr. Sunil Kota, please.
Yes. Yes. Am I audible? Is my slide visible?
Yes, yes.
Yeah. Very good evening, everyone. Respected chairperson, respected esteemed audience, and thanks to Sabir for inviting me over here and asking me to talk on a very important topic, practical, I would definitely say, because this is one of the very common scenario that we frequently stumble upon when ultrasound shows fatty liver. What are we supposed through an index of 42-year-old female, banker, obese, not having any diabetes, hypertension, neither the family is having any history of diabetes, hypertension, dyslipidemia, or cardiovascular disorder, but she is on rosuvastatin for 10 milligram for last 1.5 years for hypercholesterol. And lab parameters showing elevated enzymes, liver enzymes, the triglyceride is high, and there is increase in both fasting and postprandial blood sugars. Ultrasound showing parenchymal hyperechogenicity of the liver and poorly visible intrahepatic blood vessels, which is classical to be depicted as a mild fatty liver. So with this background, I'm going to take you through my presentation proper. First of all, I would like to take you through the etiology. The causes obviously are the alcoholism. They stated more than 20 grams per day for males and more than 14 grams per day for females is associated on a long term with fatty liver. Obesity, hyperlipidemia, diabetes, genetic causes, starvation and rapid weight loss, hepatitis C, parenteral nutrition. Then you can see the fatty liver of pregnancy, some metabolic condition and inherent conditions of transport disorders. Then the medications like aspirin, tetracycline, amiodarone, immunosuppressive agents, valproate, and anti. So it is in Asian context, most of the guidelines state that for Asians, the weekly intake of alcohol should be less than 140 grams per day for males and less than 80 to 100 grams per week for females. And looking at the slide, you can actually calculate what is the amount of different types of alcohol. I don't think it's a news to anyone. So if you talk about the NAFLD, which happens to be the hepatic manifestation of metabolic syndrome, because I'm not going to talk about the alcoholic component, I'm predominantly going to talk about the non-alcoholic component. It is the metabolic component, the hepatic component of the metabolic syndrome, and it is associated with obesity, insulin resistance, dyslipidemia, and whatnot. And if you talk about prevalence globally, it is somewhere between 15 to 46%. And if you look at the Asian data, it is somewhere between 10 to 39%. And it is in India, you can see there are studies which have quoted the prevalence to the tune of 28 to 35%. And it is one of the most common cause of elevated transaminases, cryptogenic cirrhosis, and cryptogenic hepatocellular carcinoma. And thanks to so many conditions as it can be depicted on the slide, obesity, metabolic syndrome, urbanization, sedentary lifestyle, and so if we talk about the etiopathogenesis, we all understand the risk factors associated with NAFLD, obesity, type 2 diabetes, dyslipidemia, metabolic syndrome, and there are some other hormonal disorders like hypothyroidism, hypopit, hypogonad, polycystic ovarian syndrome, and obstructive sleep apnea as well. And a NAFLD risk prediction tool would always be handy. And you can see there are factors like hypertension, diabetes, the enzymes, sleep apnea, and the race. All these point to a score which would be telling us about the risk to progression to in the future. Then this is the two-hit hypothesis which is there since long way back in 1998. The first hit is by the metabolic alteration of hyperlipidemia and hyperglycemia, normal liver into steatosis. Then we have the impact of oxidative stress and inflammatory cytokines, which gives the second hit, converting it into a steatohepatitis. And if you look at the spectrum, either it is a fatty liver when more than 5% of the liver is having fat accumulation, NASH when there is accompanying inflammation and scarring, and cirrhosis when the scar tissue replaces the liver cells. And why it is important to differentiate between NAFLD and NSH, and if you can look at the slide carefully, over a period of 30 years, if the diagnosis is shifted to NASH or the steatohepatitis, there is a significant reduction in chances of survival. And if you look at the natural history also, 15 to 30% of the healthy liver would go on to NAFLD, 12 to 40% of these would go on to NASH, out of which 15 to 25% would go on to cirrhosis, 50% of them would die or have liver transplantation, and 7% would go on to have hepatocellular carcinoma. Then how do we diagnose this? That the evidence of hepatic steatosis has to be demonstrated either by imaging or histology, and we have to rule out all these secondary causes of hepatic fat accumulation that we have discussed earlier. And this slide basically tells us about the distinction between macrovascular and microvascular steatosis. And this is the guideline in American Journal of Gastroenterology 2012. There are two scenarios that they have pointed. The scenario one is whenever there is hepatic steatosis in imaging in presence of symptoms or signs of liver disease or have abnormal liver biochemistry, they have to be suspected and evaluated thoroughly for NAFLD. And the scenario two, when you find hepatic steatosis in imaging, but no symptoms or signs of liver damage or no elevation in enzymes, we have to assess and alternate cause of steatosis. So this is the guideline of elevated liver enzymes or evidence of hepatic steatosis in imaging. If the patient is subjected to any other surgery like bariatric surgery or cholecystectomy, you can straight away plan for biopsy. If not, the baseline workup can include the complete blood picture, platelet count, the enzymes, then glucose, lipid profile. Then you can give a trial of 3 to 6 months of diet and exercise. If unsuccessful, you can plan for liver biopsy in presence of high AST, ALT, high AST platelet, decreased albumin or platelet. If not, again, reassess after 6 to 12 months. Why ultrasound is picked up? Because it is very easily accessible, less costly, no radiation. The simple principle is that the echogenicity of liver is equal to that of renal cortex and spleen, and the intrahepatic blood vessels should be clearly discernible, and the posterior margin and the diaphragm should be clearly delineated. So if there is obliteration of all these parameters, these are graded according to the ultrasound grade 1, presence of echogenicity, grade 2, obliteration of blood vessel, grade 3, obscuration of diaphragmatic outline. So the disadvantages are also there. It cannot be used in obese patients, those who are having pre-existing chronic liver disease, and whenever the steatosis is less than 20 to 30%, and the degree of fibrosis can also not be graded, which is the most important parameter of mortality in this group of patients. CT scan is never used. MRI or MR spectroscopy can be used, but they do not tell you about the differentiation between NASH and NAFLD. So then there is the MR electroscopy, elastography rather. So it basically tells us about the advanced fibrosis diagnosis. So you can look at the bottom, the MRE stiffness, if it is more than 3.63 kilopascal, it is somewhat suggestive towards occurrence of fibrosis. As I was telling you previously, the most important parameter of mortality is fibrosis. So we need tests which will tell us about the fibrosis. There are some non-invasive tests like the elastography or the fibroscan, which we all are aware of. Then there are some non-invasive tests like NAFLD fibrosis score, which takes into account age, hyperglycemia, BMI, platelet count, albumin, AST-LT ratio. Then there are some number of scores, BARD score, FIB4 score, and this slide is for completion's sake. Look at the number of scores those are available to look at the fibrosis. There are some as well. The predominant ones are the cytokeratin K18 and terminal peptide of procollagen 3. Of enhanced liver fibrosis score, which takes into account 3 parameters of hyaluronic acid, PIINP, then PIMP, and look at the interpretation more than 9.8 suggestive of severe fibrosis. Fibroscan, it is a pulse echo ultrasound technique, non-invasive, more sensitive than the serological markers, evaluates a larger part of liver and might be unreliable in obese. So you can see it is graded from F0 to F4 depending on the kilopascal value of the elastography. And sometimes also require liver biopsy, especially in patients with NAFLD who are at increased risk to have steatohepatitis or advanced fibrosis, and in those where we want to rule out the competing etiologies causing NASH. So this is the scoring pattern. This is called SLB, steatosis, lobar inflammation and ballooning. More than 5 is suggestive of NASH. Then there is a fibrosis staging as well from 0 to 4. Again, 1 is divided as 1A, 1B and 1C. So now coming to the management options, non-medical, we all understand the importance of diet and exercise. I'm not going to harp much on that. How do we go to do that? But the treatment is basically to take care of the first hit. We need insulin sensitizers and anti-hyperlipidemics. To take care of the second hit, we require antioxidants and anti-inflammatory cytokines. So weight reduction is very important. So you can see a number of studies, all of them have given us good effect in terms of reduction of the histological activity score, the enzymes, the weight and all. And depending on the weight list, there can be improvement in liver fat and liver stiffness, improvement in NASH activity score. And with more than 10% weight loss, you can see 90% of the patients can also go for NASH revolution. Again, for the completion's sake, there are some anecdotal evidence in favor of these all diets, which have shown some beneficial effects in patients having NAFLD. But when it comes to pharmacotherapy for all these fatty liver, when do we treat it? So the population of interest is to treat patients having NASH, NASH with fibrosis, advanced fibrosis, NASH-related cirrhosis. But do not treat the patients who have only NAFL or steatosis alone. These are the patients for whom we should be doing thorough metabolic workup. Thiazolidines, we know insulin sensitizers, but the main mechanism is to decrease the hepatic fatty acid levels and they redistribute fat content from liver to peripheral adipose tissue. A number of studies are there, both in favor of pioglitazone and rosiglitazone, in terms of reducing the enzymes, in terms of improving the histological parameters. And the gastroenterology journal says it can be used to treat steatohepatitis in patients with biopsy-proven NASH, but long-term efficacy and safety is not established. What about metformin? Yes, there is weight reduction, improvement in insulin sensitivity, there is reduction in transaminase. Regards to histologic improvement, we have still data to gather. So as of now, it is not recommended to be used in patients having NASH. And one of the very significant molecules is the vitamin E, which is antioxidant and a free radical scavenger. Number of studies just to showcase what all it has in store for us. But this is the most important PIVENS trial where pioglitazone 30 and vitamin E 800 was compared versus placebo. Both the molecules were better than placebo in terms of histologic improvement. But if you compare vitamin E versus pioglitazone, again, vitamin E scores better in terms of enzymes reduction, in terms of weight parameter also. Though both of these are actually associated with reduction of insulin resistance, the weight is going up with pioglitazone. So where do we use the vitamin E? It improves NASH, yes. It reverses NASH, yes. But those who have NASH with fibrosis, there is no data, and there is no data with regards to improvement in long-term outcomes. And when do we use it? The guidelines are clear-cut. They says that it can improve liver histology in non-diabetic adults with biopsy-proven NASH, and therefore it should be considered as a first-line pharmacotherapy for this patient population. But for the one who have diabetes, one who have no liver biopsy report, one who have already developed cirrhosis or a component of fibrosis, probably this is not one such molecule to be used. But again, there are some studies showing increase in all-cause mortality, increase in risk of hemorrhagic strokes, especially for the older population, those who have hypertension should be avoided. And again, there is an increase in risk of prostate cancer as well. Number of others like vitamin E, vitamin C, polyphenols, the omega-3 fatty acids, all these are touted to be liver protectants and antioxidants. Pentoxifylline again is a phosphodiesterase inhibitor resulting in decreased activity of TNF and TGF. There are studies, but again, not much of activity in reducing the histologic scores. Orthodeoxycholic acid is being again used, but you look at the histologic parameters, it has no such beneficial effect. So it is stated that it is not recommended for treatment of NAFLD or NAFSH. And yes, we all are aware of the dual PPAR alpha and gamma agonist, the saroglitazar. It reduces the lipids, it reduces the glycemic control, it reduces the hepatic enzymes, and on top of that, in liver biopsy, it gives rise to reversal of hepatocellular steatosis, ballooning, and inflammation. Bariatric surgery, the secondary outcome, we have seen improvement in NAFLD. So as of now, it would be premature to consider for bariatric surgery as an established option to specifically treat NASH. Statins, yes, we have improvement in terms of enzymes, but histologically, we do not see much of significant improvement. So it should be used only in those group of NAFLD and NASH who have dyslipidemia. They cannot be used as a primary treatment for NAFLD. So others like gliptins, the glutides, the gliflozins, again, especially for the ones who have diabetes, they have shown good amount of reversal of NASH. There are a number of emerging therapies. In fact, I cannot spell most of their names also. These are they're mentioned on the slide for all of you. So there are some therapies which are associated with reduction in fibrosis like vitamin E, pioglitazone, obeticholic acid, cenicreviroc, then selononsertib. So probably, excuse me if I'm spelling it wrong. Lastly, how do we treat it? So predominantly, we have to exclude the secondary causes, take care of the risk factors. If these are present and the patient is willing, you can go for liver biopsy. If these are absent, lifestyle modification is the answer. And if liver biopsy is establishing a NASH, then the chance of lifestyle modification, pharmacotherapy, and bariatric surgery coming into the picture is. How do we follow up? Once in 6 months, weight and exercise has to be checked, and the blood platelet counts, the liver biochemical test, prothrombin time. Then the screening for cardiovascular risk has to be done once in 1 to 2 years, and liver biopsy again every 3 to 5 years, depending on response. NAFLD is definitely a significant health issue in India, and a fatty liver, ultrasound, try to rule out alcohol, then comes the NAFLD, and it is closely associated with metabolic syndrome. It is called as the hepatic component of the metabolic syndrome. Its presence also indicates co-presence of other metabolic disorders of diabetes, hypertension, and dyslipidemia. In 80% of the cases, it is a reversible benign condition. But if it not treated properly and if the risk factors are not addressed properly, 20 to 25% of cases can progress to liver damage. So lifestyle modification has the best result. Non-diabetics, those who do not have cirrhosis, those who do not have fibrosis, yes, vitamin E is the best one. If there is diabetes, then try to use the drugs like gliflozins and gliptins and the glutides, which can give rise to some sort of reversal. Pharmacological treatment is still evolving, and there is no single therapy which is clearly effective. Thank you all for the patient listening, and thank you again, Sabir sir, for giving this wonderful opportunity to interact with all of you. Thank you.
Hello. Hello. Hello.
We can hear you.
Yeah, good evening to all. The next topic is SGLT2 inhibitors and diabetic ketoacidosis. Points to remember in clinical practice. To talk on this, we have an Indian speaker, Dr. Ayanda Shanmugam. He is certified in internal medicine and endocrinology. He is a fellow of American College of Endocrinology, fellow of American College of Physicians, and he is a retired clinical professor of endocrinology at Texas A&M Health Science Center. Over to you, sir.
Can you all hear me?
Yes, sir. Yes, sir.
And am I able to share my slides? Let's see. Let's see if I can share my slides. Meanwhile, thank you all for giving me this wonderful opportunity. Is my slide showing up?
Not yet.
I'm sorry, I'm sharing the content. Let's see. I say share content. Does it?
Sir, you can share
on,
the content, sir, please.
I clicked on share content, and then let's see.
Sir, are you doing it from your mobile or laptop?
From my laptop. From my laptop.
Yeah, I'm sharing from my laptop. I need permission.
I'm pressing share content, and then what else do I have to press one more time, or?
No, sir, you can just. Yeah. Perfect, sir. Perfect.
Okay, thank you. Thank you all for this wonderful opportunity. And
please activate the slideshow, sir. Please activate the slideshow.
Okay. Okay, thank you.
Okay, sir. Perfect.
I would really like to thank Dr. Sabir Rashid for this, and all the organizers for this wonderful program, and I enjoyed every bit of it. It was nighttime most of the time, so we were sleeping. And when I woke up 3 hours ago, I've been enjoying every bit of it and all these wonderful speakers. And it is such an honor to be part of this program. I would like to thank Dr. Ravindran and Dr. Chako Varghese for moderating, and Dr. Ravindran for introduction. The topic given today is SGLT2 inhibitors and DKA points to consider in clinical practice. Can you all hear me okay? Can you all hear me okay?
Yes.
Okay.
Yes, sir. Sure.
Okay, thank you. We will briefly touch upon the pathophysiology of type 2 diabetes, and we'll talk about the role of sodium glucose co-transporters, DKA with SGLT2 inhibitors, diagnosis and treatment, and how to safely use sodium glucose co-transporters 2 inhibitors, which is otherwise abbreviated as SGLT2 inhibitors in type 2 diabetes. I would touch upon LADA, which is latent autoimmune diabetes in adults, and DKA, because it's very, very easy to confuse the SGLT2 inhibitors and DKA with the LADA. And we'll start off with this classic slide from the Banting lecture of Dr. Ralph DiFranzo, whom I call the godfather of diabetes. Met him several times, listened to many of his talks, happened to be there during this wonderful presentation he had on the Banting lecture in 2009, where he was given the Banting Medal of Honor by the ADA, American Diabetes Association. This topic he termed as from the triumvirate to the ominous octet. That is, from 3 causes of diabetes to 8 causes. He jumped from 3 to 8. And on the left-hand side of the slide, you will type 2 diabetes, as you all know, is a very complex metabolic disorder which ravages the body in multiple ways, more than one, with microvascular and macrovascular complications. On the left-hand side shows the increased glucose production from the liver, hepatic gluconeogenesis, increased glucagon secretion from the alpha cells of the pancreas, increased lipolysis from the fat cells, and increased glucose reabsorption, which is the main topic for today from the kidneys. On the right-hand side of the slide, you can see decreased insulin secretion from the beta cells, decreased glucose uptake, decreased incretin effect, and neurotransmitter dysfunction. So we will focus on the role of sodium glucose co-transporters in the kidneys. When we look at the glucose filtration reabsorption, about 180 grams of glucose is filtered by the kidneys each day. The action takes place mainly in the proximal convoluted tubule. As you can see, there's an S1 segment and an S3 segment. And the white little particles are the glucose molecules. And no reabsorption takes place in the loop of Henle or the distal convoluted tubule. 99% of the sugar is reabsorbed in the proximal tubule. So the urine is, in a non-diabetic patient, the urine is virtually glucose-free or minimal glycosidia occurs. This is an expanded version showing the proximal tubule and the blood vessels, and these are I'm pointing towards the white glucose molecules and the the sodium glucose. This is actively transported through membrane proteins called sodium glucose co-transporters, especially two, because the one is in the SGLT1 is in the intestine, and it does the same thing there. This has been known for almost 50, 60 years. Again, I showed you here the 90% of the reabsorption occurs in the S1 segment and 10% in the S3 segment. What happens in type 2 what we saw so far is a normal, non-diabetic patients. What we would see now is in a diabetic patient, a maladaptation occurs. So the kidney has a more than 32% increased capacity for glucose reabsorption compared with the kidney in a healthy patient. So what happens is that there is already hyperglycemia, and the renal threshold maximum is also increased from 180 to about 240 milligrams per cent. In other words, even up to the fact the blood sugar is 240 milligrams per cent, instead of glycosidia, you get more reabsorption. So you add insult to injury and you get hyperglycemia and you get more chronic glucotoxicity. The SGLT2 inhibitors came into existence about 7 years ago, 2013. Prior to that, we had a SGLT1 and SGLT2 inhibitor combination, which was called fluorescein, which was from the bark of an apple tree. And that didn't work because it was too toxic and could not be utilized. So we had to wait 30, 40 years, even after we knew this mechanism, before a drug that can be clinically used came into existence. Canagliflozin, dapagliflozin, and epagliflozin are the three: Invokana, Farxiga, Jardiance in that order. And what are the advantages of these inhibitors, SGLT2 inhibitors, is that oral administration as an AM dose, weight loss, modest weight loss occurs, potent A1C reduction, and no hypoglycemia unless used with insulin or sulfonylurea. And again, once a day, can be used along with most hypoglycemic agents and insulin. Subsequently, we found out that there are outcome studies. We found that there were more benefits, cardiovascular benefits were shown. And recently, in June of 2020, the Food and Drug Administration USA approved dapagliflozin or AstraZeneca's dapagliflozin as for congestive heart failure treatment, both with diabetes and even without diabetes, which is incredible, increasing the importance of these drugs, class of drugs. Reduction of cardiovascular events and death occurred with empagliflozin as a secondary prevention studies, not primary prevention as in statins. CKD with chronic kidney disease, delay in progression of CKD was known. The side effects being UTI, and the patient should be informed to drink more water. And as you can imagine, the urine is full of sugar, and you can, if the patient doesn't drink enough water, then you can concentrate the urine. That's a setup for risk of urinary tract infections. Genital myocardial infections, especially in women, about 10% of the cases, and 3% of the men can develop that. Those have these drugs are started on. Dapagliflozin has a very minimal association. I put a question mark there because it's in the PI, which physician information or the prescribing information. It's not advisable to be started in patients with a prior history of bladder cancer or active bladder cancer. Canagliflozin has a risk of lower limb amputations, fractures. The mechanisms of these are not clearly known, but be that as may, that's what we have. Precautions in the use of these drugs should be kept in mind. They are not to be used in advanced CKD or ESRD or patients with dialysis. That's any patients with a renal function of less than 7%, less than 30%, meaning a EGFR of less than 30, or dialysis. Not because they are nephrotoxic, but they're ineffective. They cannot cause glycosuria in those patients. And then they are not effective. History of recurrent UTIs, already you have a risk of UTIs, and if somebody has a history of recurrent UTIs, I would stay away from using these drugs, even though they have been used by some. History of recurrent yeast infections in a patient then may not be the right class of drugs to use because we have so many other classes to use. Type 1 diabetes, it's not indicated. Dr. Ann Peters out of California, UCLA, was one of the earlier ones that showed, she published in Diabetes Care, showing about 13 episodes, only 9 patients. That means there were more than one episode in certain patients. And if you can see on the right-hand side, about 7 of them had type 1 diabetes. So it's not approved, but they are researchers and they can use it. I'm more of a clinician, and I had clinical practice, and I was a teacher, but more of a, most of my time was clinical practice. And I would like to give a disclaimer that I was a speaker for all these companies for a very long time until I retired 4 years ago, and I'm not a speaker anymore. So just wanted to let you know I was a speaker for all these drugs. Two patients had type 2 diabetes in this particular study, and it occurred after post-surgical procedure. So pathophysiology and what are the risk factors? Presenting factors are that decreased insulin product secretion occurs in these patients because of normalization of sugars by the glycosuria, and or exogenous reduction of insulin by doctors because the diabetes gets tremendously improved and they may get hypoglycemia and they're already on other agents. So the reduction in other agents, especially insulin, is the first thing to go because patients don't want injections, as you can see. And so these patients are susceptible for DKA. Increased glucagon production occurs as a secondary event because of decreased insulin production, decreased insulin secretion. And so you get hepatic gluconeogenesis and ketogenesis occurs. Concurrent infections, decreased carbohydrate intake. One patient did not inform one of my referring physicians that she went on a keto diet, meaning completely off carbohydrates and only eating meat and vegetables. And she ended up getting DKA. And then after she was discharged, she was referred to me. So I have not really seen, even though I had thousands of patients on these class of drugs, I just haven't seen many of them. They're very, very rare. DKA is very rare with SGLT2 inhibitors. Dehydration due to nausea of ketosis causing less fluid intake is another reason. And glycosilia causes euglycemia or mild hyperglycemia. So euglycemic decay is much more common in these patients, in those who do develop, even though this is very rare. DKA in SGLT2 inhibitors is very rare. I just want to emphasize that. And it can occur with the blood sugars of, the first few patients were reported as the blood sugars of 191. So 191, 190 to 200. So we have to be very careful with these, with not diagnosing just because the blood sugars are not high enough. Because the definition of DKA is more than 250, as you all know. Nausea and vomiting, abdominal pain, generalized malaise, and shortness of breath. And I usually tell patients when I initiate them that to drink plenty of water, and if they have nausea, vomiting, or abdominal pain, they have to stop the drug and then report to me, and I may prescribe insulin as needed. Or we may send the patient for ketones, serum ketones, and even to the emergency room for further evaluation. So reduce the calorie intake, pancreatic insulin deficiency, alcohol abuse, surgical, post-surgical, and again, I want to emphasize, please do not use it on type 1 diabetes. That's where most of the DKA seem to have occurred because of the reduction in insulin dosing in these patients. Nausea and vomiting, abdominal pain, as I mentioned, malaise, hyperglycemia, and serum ketones, and euglycemia can also can occur, as mentioned. How much time do I have? I just have to pace my talk. 5 more minutes, 6 more minutes. Can you all hear me?
Yes.
Okay. The one main factor is it occurs even with mild hyperglycemia and no prior usage of insulin. This was shown in the Canadian study of retrospective analysis. But most of the patients, the reduction of dose of insulin was the cause rather than absence of insulin. And these authors concluded that pathophysiology was not well known, and it was only most of these are postulated. Again, this slide shows the comparison between the occurrence of decay in DPP4 inhibitors versus SGLT2 inhibitors. Both sections, both of the group of patients had more than 38,000 patients, and if you look at the actual incidence, it was only 0.14% with SGLT2. So, or 4.9 rate of events per 1,000 patient years, or 55 patients out of 38,000 patients. So you can see it's pretty rare. And that's where, the treatment of decay is very similar to any other diabetic ketoacidosis, the IV fluids, IV insulin. Patients quickly recover, preferably treated in ICU, and SGLT2 drug should be stopped immediately. I just want to quickly touch on LADA before I finish the talk. The LADA, or latent autoimmune diabetes in adults, occurs after the age of 30 with positive islet cell antibodies. 3 more minutes? Okay. Initially may be treated with diet, exercise, and metformin, and subsequently, for several months, or sometimes goes on for a long time, and almost always requires insulin sooner or later. It has mixed features of type 1 and type 2, sometimes called type 1.5. Why did I bring this up? Because many of these patients who were on SGLT2 and were thought to be type 2 and developed DKA actually had LADA. So the incidence may be even lower than what we saw, 0.14%, with SGLT2 and diabetes and DKA. So DKA, if not diagnosed properly in LADA and treated with the SGLT2 inhibitors, if the diagnosis was not made, LADA makes up for about 1 to 2%, it appears, of the entire type 2 diabetes. And I have seen a few which were referred to me, and subsequently I checked the hydroxyl antibodies and the C-peptide, and the C-peptide was near zero, and these patients needed insulin right away. I distinctly remember a professor of, I live in a college town, so many of my patients are professors and PhD, and one of them was a geological professor who does a lot of research on the Sea of Japan. And he, I kept telling him I didn't feel comfortable with him being thin and taking multiple tablets. And I gave him some insulin as samples to take with him when he went to the Sea of Japan. He emailed me back that he had to initiate insulin in small doses while he was there because he felt his blood sugars were rising up. Anyway, that's something that stays in my mind. The last slide is take-home points or decay with SGLT2 inhibitors. It's very rare, 4.9 per 1,000 patient years, as per the studies I showed you. Patients on SGLT2 inhibitors need to be educated about the risk of decay. If patients need to drink plenty of water. If they have abdominal pain or nausea or vomiting, they need to stop the drug and immediately report to the emergency room. The nearest emergency room. That's what I always instruct them when I initiate these drugs. The doctors need to be aware of the atypical presentation of DKA because of euglycemia and easy to miss. So glucose levels may be 190 to 250 milligrams per cent. Serum ketones are positive in these patients because if we do urine ketones, we may miss the beta hydroxybutyric, which may be predominant in these patients. We need to consider LADA since DKA is much more common in LADA than in classic type 2 diabetes. So when somebody comes in with type 2 diabetes diagnosed for 10 years, 20 years, or 5 years, and on SGLT2 inhibitors and develops these symptoms, kindly refer them maybe to a diabetologist, like most of the audience here, as well as checking those and be aware of that. I would like to finally thank all the wonderful organizers and Dr. Sabir Rashid and the moderators of this session introduction. And the best way to learn is to teach others. Thank you very much.
Thank you, sir, for your excellent presentation. The topic is open for discussion.
I think, Dr. Ravindran, we have some couple of questions in the chat box. One to Dr. Rajesh and one or two questions to Dr. Sunil. So I think Dr. Rajesh, one question. Can someone read?
I can read it. I'm here available. So it says how the CKD correlate with the cluster analysis, and am I doing the analysis in my area? So I think they're asking about a study, cluster analysis study about diabetes done mostly in Europe area. I think they've divided diabetic patients into 5 different clusters. First one mainly for type 1, like the previous presenter, Dr. Sharma mentioned about LADA. So they call it a severe autoimmune diabetes, called SAID, mainly for type 1 diabetes. Other 4 clusters were severe insulin deficient diabetes, or they call SIDD, SID, and severe insulin resistant diabetes, called SIRD, and mild obesity related diabetes, or MOD, and mild age related diabetes, MARD. The first one also, the first category or the cluster was positive for glutamic acid decarboxylase antibodies, and the other ones based on the clinical characteristic. We are not doing those kind of cluster analysis because there were some studies later on done even in Europe area mentioning that the clinical features are still good, but the outcomes and also we are also kind of using those clinical features mostly for the diagnosis and prognostic factors. But it's a good question. Thank you. I'm not sure who asked it, but I would like to comment the question too. Thank you.
Yeah, actually, one more question to me. So what are the approved therapy for treatment of NASH? So actually, I've already answered that in the chat, but to make it simpler, actually, as of now, only approved therapy seems to be vitamin E, which again is contraindicated in patients having diabetes and those patients having NSH with a component of fibrosis or cirrhosis. So by and large, as I understand, the biopsy is not a very frequently done procedure. The best standard treatment as of now is weight by diet and exercise. If you have diabetes, add gliflozins and pioglitazone. If you do not have diabetes, vitamin E to the standard diet and lifestyle. So that is the that should be the answer actually. And I have taken you through a journey of number of drugs just to tell you how many are but all of these are not approved.
Dr. Rajesh, what do you do for contrast studies in your diabetic kidney disease patients? What is the protocol you follow for contrast studies in your diabetic?
We technically use the GFR of 30 as the cutoff, mainly for the contrast study, and it depends on the type of the study they are using also, especially if it is for the heart cath and all, even less GFR less than 30, we may not be able to avoid that. We recommend them to minimize the amount of contrast, especially to the cardiologist, to minimize the contrast and use the low osmolar agents, and also select the patients very carefully. Keep their hydration status well. If they are on diuretics or metformin kind of drugs, we may have to hold it. If ACE inhibitor, I might hold it for a few days. And if patient hydration status is questionable, I might even ask them to give some IV fluids also around maybe 2 hours before the procedure, as long as they can tolerate the fluid volume that I'm giving. Severe CHF patients, I may not be able to. So I just have to work with the cardiologist in that regard. If it is for CAT scan, we have to work with the radiologist again. I have to ask the importance of the study. Is it could be avoided? Can the CAT scan be done without contrast and those kind of questions? And again, I have to select the patients very carefully. Regarding gadolinium for the MRI, typically again GFR less than 30, we try to avoid gadolinium contrast. Again, we try to ask them to do the MRI in other regards. And also, if dialysis patient needs gadolinium, we technically have to do the hemodialysis for 3 sessions in a row, 3 days in a row. That is a recommendation. A lot of times it may not be practical clinically, but that's what the recommendation is. Hope I answered your question.
Thank you.
Thank you.
I think we are running short of time. If there are no more queries, we will wind up the session. Once again, I thank Dr. Sabir and team for giving me this opportunity to chair the session. And thank you for all the delegates and speakers.
All great session.
So thank you everyone. It was an excellent session. Thank you, respected chairs and other speakers. Now we are moving on to a session that is something regarding thyroid. It's a symposium on thyroid. We have 3 different lectures on 3 different aspects of thyroid, and we have 3 eminent speakers for the session. And to chair the session, we have 2 senior faculties. First one is Dr. Balakrishna Valued sir. He's the professor of internal medicine, Medical College, Pariyaram, Kannur. And the second chair is our speaker will be Dr. Sunil Kota. He is a senior endocrinologist from Odisha, India. So I welcome both the chairs to the session. Over to you.
So, good evening. I'm audible for you. Hello?
Yes, sir. Please.
Okay. So,
Okay.
at the outset, let me thank.
Yeah, others can mute, sir. Others can mute.
At the outset, let me thank Dr. Shabir and his team for inviting me to chair this session. And I take this opportunity to congratulate Dr. Shabir. In spite of these adverse several factors, he has
Sir, can you enable my share screen, please? So it won't be time waste.
And he has ensured that uninterrupted diabetes conference for the last 4 years, in spite of this adverse climatic and other aspects. And this is a real pleasure to be chair this session. And now the next 1 hour will be moving through the thyroid symposium, and we have got an eminent speakers
for the session. And the first one is Dr. Suresh Damodar. And I would like to introduce Dr. Suresh Damodar, who was the honorary consultant of Different Hospital at the Plymouth, and is the consultant in diabetes and endocrinology, Sri Ramakrishna Hospital in Coimbatore. And again, he has done his basic, postgraduate, and super specialty in training in UK, and he conducts annual international and national conferences, popularly known as the DICON and the Para-DICON every year. And I had the opportunity to meet him in some other conferences 1 year back. I don't know whether Dr. Suresh remember me. We met once. And again, he is awarded the Donald D. Sphere International Scholar Awards presented by the International Diabetes Center, Minneapolis, in Minnesota. And he was the vice president of the Terminal Endocrine Society for the year 2018 and 19. And he has presented several papers, published many articles, abstracts in the national and international journal. And I heard his talk 2 or 3 times. He was a very, I think he's a very expert in this field, and he is the right person to talk about this topic on the practical approach to the person with an abnormal TSH. And I'm not taking much of time. You know that the TSH is the most simple and cost-effective investigation we all the physicians and the endocrinologists order. It has got very simple, cost-effective, but it has got a lot of limitations and complications. And we need an expert to talk on how to interpret and how to utilize these very simple investigations, the thyroid TSH. And I invited Dr. Suresh for his talk.
Good evening. Thanks for the wonderful opportunity. Can you see my screen?
Not yet.
Oh my God.
Not yet.
No, Dr. Suresh, please can you share it?
Share web browser.
Yeah, can you do it once more?
Oh my God. Can you see this?
Yeah, it's sharing. Just wait.
Yeah, change to PowerPoint.
This one? Can you see?
No.
Noted.
Suresh sir, come on without a bat.
What is that? Sorry? Share web browser or share me my meeting window?
No. It's not meeting window. No. It's the same app. Can't you share the have you tried to share the PowerPoint application? Close the other windows and see whether there is a PowerPoint. You are using PowerPoint, right? For
Yes,
presentation?
I do.
So please unshare this and stop sharing. And again, share PowerPoint or share the screen and take the PowerPoint.
Share the web browser. Okay.
Yeah, now pick up the PowerPoint from your taskbar.
Noted came.
Can you get the next speaker? I'll just get ready with this.
Yeah, thank you.
Yeah.
So the next speaker in line is Dr. Joe George. Is not unknown to anyone, I think. So actually, he's loved by everyone around him. We have sparred some times ago, and he's a wonderful speaker to whom we all would like to listen to. He's a senior consultant endocrinologist and director Endo Diab Clinic Kozhikode, former secretary Endocrine Society Kerala chapter, former secretary PACE, organizing secretary Kendocon, organizing secretary Mendoz, and best outgoing postgraduate student of KEM Hospital for the year 2006 and 7. So unending list of achievements. Over to you, Joseph.
Thank you very much. So thank you, Dr. Sunil and Dr. Balakrishnan sir. I hope I'm audible and my slides are clear. Can I start?
Yes.
Yeah, thank you. Thank you very much. Actually, I'm really thankful to Dr. Shabir and the organizers for giving me this opportunity. Actually, I felt a bit alienated and out of place to have a thyroid talk in a diabetes CME, because as I went through the agenda, this is the only thyroid session there. But anyway, it's a superb topic that he has given me, and I'm very thankful for that. So let me not delay things. I will just start with my presentation. My topic today is to discuss on hypothyroid in pregnancy and its management. Thyroid, probably the reason why it has come to today's topic is because there has been a lot of media attention and education, which has definitely improved the awareness among doctors and also the general public about diseases of thyroid, leading to an increased screening and more diagnosis. And actually, there have been a lot of discussion on the relationship between diabetes and thyroid and all sorts of things. So, but anyway, the awareness has quite increased, and almost all patients actually go on for all non-specific symptoms to the doctor. They get a TSH done. But when it comes to pregnancy, there it actually has a different level of awareness and treatment requirement that is there, because that is one place that we need to be very careful on managing thyroid, especially hypothyroidism. As with most of the scenarios, the thyroid physiology changes during pregnancy. There's an increased estrogen level, as pregnancy is a hyperestrogenic state, which leads to increased thyroid binding globulin and leading to decrease in free thyroid hormone, which leading to the increased pituitary stimulation of the TSH, leading to increased T4 and T3, which is there. And also, in addition, there is a placental HCG, which stimulates the thyroid hormone receptor, leading to increased thyroid hormone production. And then there is increased thyroid hormone degradation due to type 3 dehydrogenase. All these thyroid changes that happen in normal physiology during pregnancy lead to an alteration in thyroid function, which we need to understand. As you can see from the circle, this is a place where the maximum changes occur. And finally, as I already mentioned, the TBG level increases, and finally the T4 and T3 usually settles down to somewhere like 50% above the upper limit of normal. And also the HCG level peaks by around 12 weeks, and then it comes down, and that also has a direct stimulatory effect on the thyroid hormone. So what is the usual normal physiological change that happened during pregnancy? As I already mentioned, there is an increase in total T4 and total T3 level all throughout the pregnancy. And that's why we say that the normal T3, T4, we should consider as 50% above the upper limit of normal. Up to that level, we should take it as a normal value during pregnancy. TSH, because of the HCG effect, may be within normal range or even maybe decreased. That's why the Endocrine Society has put a trimester specific range for TSH in pregnancy. That is, in first trimester, any value between 0.1 and 2.5 should be taken as normal. Second trimester, 0.2 to 3, and third trimester, 0.3 to 3.5. This is the normal range. So any value, when you look at the lab normal range, you may see that the normal value is 0.5 to 4.5 or 0.5 to 5. That's the normal range that's described by the lab. But that should not be taken as normal in a pregnant lady. In a pregnant lady, for example, in the first trimester, if the patient comes with a value of 3, that is above the normal range. That's an important point that we should keep in mind when managing thyroid in a pregnant lady. Okay, so with that background of physiology, let me go into the hypothyroidism in pregnancy. Hypothyroidism in pregnancy is associated with a lot of morbidity and mortality. It has been proven beyond doubt that hypothyroid mother is at risk of preterm delivery, delivering a low birth weight baby. It is said that there is an increased risk of pregnancy loss by around 60% if the lady is hypothyroid. And the most important and actually most highlighted thing is the lower intelligence quotient of the offspring. So it's very important that the child IQ may come down if the mother is not treated properly. Gestational hypertension risk is increased by 22% and also preeclampsia risk. There is increased risk of fetal death and also increased risk of abruptio placentae and postpartum hemorrhage. There is an increased ending of that pregnancy with LSCS also. All these things actually make it very important that we properly diagnose hypothyroidism and treat it to the correct level that is described by the guidelines. See, this is a study which has been a very landmark study which came in NEJM. It's quite an old study. You can see that it was published in August 1999, which actually shows that children of women with high TSH IQ scores were 4 points lower than control and 15% of the population of those children had an IQ level which was less than 85. We know that the normal IQ is considered something between 90 and 110. So less than 85 is something of a lower intelligence level, which was seen in 15%, while a normal population normal or in the control group, it was 5%. So there was a incidence of more 10% of those children who were born to hypothyroid mothers were having a lower intelligence. And this is when the children of women with high TSH, when they were treated actually, but when they were untreated, it came as 7 points lower, and there was a lower than 85 risk was seen in 19% of population. And here we should understand that in the treatment group, the treated group, in the hypothyroid patients, the mean TSH was 13.2, and in control group it was 1.4. So the normal range was taken as, in the average normal range was in the 1.5, 1.4 group, and this is not a subclinical hypothyroid, but overt hypothyroid with the average TSH of 13.2. It's not like something like sky high TSH of 20 or 50 or 70 that we are discussing. Something even above 10 can lead to this much of a problem in the intelligence quotient score. This is a landmark study which came in NEJ. And also the antibody level, anti-TPO antibody level were significantly high at 77% in the women with hypothyroidism and only 14% in those who were euthyroid. So with that, we should actually define the upper limit of normal TSH in pregnancy. Although I already mentioned the normal range in endocrine society, but finally the incidence of hypothyroidism would actually depend on what cutoff do you use. Actually, this is a study from India which got published in IJEM, where if you actually take the TSH cutoff at 4.5, the incidence of hypothyroidism is close to 15% in various trimesters. But if you take the cutoff, more stringent cutoff of 2.5 or 3, the incidence comes to somewhere close to 1/3 to half of population who are pregnant. So it's a very high incidence if you take it as a very strict cutoff, which I mentioned of the Endocrine Society guideline. So that is the incidence. So it's very common. And also the anti-TPO positivity is around 20% in pregnant ladies in India. This is again an Indian study from 11 cities in 9 states. So it's a study that represents the whole Indian population. So what should we define as normal TSH? It's a very difficult question because overt hypothyroidism can lead to problem. But always the controversy is that what would be the problem with subclinical hypothyroidism? I would like to describe it with an example. What is the risk of fracture with the height of fall? If I ask that question, the common answer that I would get is that there is a certain height above which you can definitely say that there is danger and you are likely to fracture or you are likely to die. And there is also a height where you can say that you are definitely safe. Like if you jump from 50 centimeter height or 100 centimeter height, you are very unlikely to fracture, isn't it? You are pretty safe. So that's 2 levels where you are absolutely in danger. There is a level where you are absolutely safe. The problem is that there is always a borderline level where the risk is possible, but it is less definable and it would be definitely less severe. So what is that range? When you look at that from the available data, it is said that in pregnancy, if the TSH is above 4, the risk of danger to the child and the mother is definitely there. And if the TSH is below 2.5, it is definitely safe. So there is a borderline value of something between 2.5 and 4. Above 4, definitely abnormal. Below 2.5, definitely normal. So this is a study by my close friend, Dr. Vimal, which was done from when I was also doing DM at KEM Hospital, Mumbai. So this is a very interesting study from Indian population. That's why I want to quote this study. Here, you can see that in TPO antibody positive individuals, the average TSH was 3.88, while in TPO antibody negative individuals, the average TSH was 1.24. It is corresponding to the Western data, which says that in a normal non-pregnant lady, you are actually expecting a TSH only in the range of 1.24, around that range. And in an antibody positive range, it was only 3.88. And remember, this is more alarming. Even with that small TSH rise of 3.88, which is which falls within the normal range of the lab, actually the pregnancy miscarriage rate is 25%, which is very high. So even in that so-called lab normal range, which is actually abnormal for pregnancy, if the patient is TPO antibody positive, there is a higher risk of miscarriage from this data, which is from India, Mumbai. And when the TPO antibodies, the miscarriage rate is less as 7% when the antibody is negative and the TSH is within the normal range. So this is a very alarming change that happens in the risk to the mother and fetus when the TSH just goes up from that average of 1.25 to an average of 3.8. It's a very small change that we would always think that it's very small. What's there in that? But that creates a change in miscarriage from 8% to 25%, which is quite significant. So yeah, so in the sub-analysis of that, it was seen that high risk of miscarriage was seen in all patients who were antibody positive and also those patients who had a TSH above 4. So anybody who has a TSH above 4 or having an antibody positivity, the risk of miscarriage was high. So that's why the guideline. So what I'm trying to prove here is that we tend to follow the Western data exactly here, unlike the usual case scenarios where we say that we don't have Indian data. We actually have Indian data, and that replicates what we have seen in that NEJM study, which was published in 1999. That is, we have higher risk. Our mothers and the fetus has higher risk when the TSH is above 4 or when they have antibody positivity. So that's why the 2017 guidelines by the American Thyroid Association can be directly replicated to our population also, where they say that any TSH which is above 4 should be treated, and borderline TSH between 2.5 to 4 should be treated if the lady is having anti-TPO antibody positivity. So that is the final conclusion that we need to get. Also, another question that commonly raised is that how to manage pre-gestational hypothyroid in pregnancy. Here again, with the available data, we should understand that we have to keep the TSH below 2.5 because during pregnancy, due to the fetal increase requirement, the dose has to be increased. And usually the increase starts by around 4 to 6 weeks of pregnancy. That is even before the UPT is turned positive and the patient actually recognizes that she is pregnant, the dose requirement for thyroxine would have already increased. And the increase is by around 50 to 85% throughout pregnancy. And the final stable level is reached by around 20 to 24 weeks. So almost obviously, most of the patients would require the dose increase, and we should advise a lady who is planning pregnancy to increase the dose by 20 to 30% as soon as she knows that she is pregnant or she has just missed the periods. And a common way of doing it is to just ask her to take 2 additional tablets weekly of whatever dose she is taking of the levothyroxine. So what is a biochemical goal when you treat hypothyroidism in pregnancy? As I told you, less than 2.5 is the target, because when we above 4, we have to treat between 2.5 and 4, we have to treat the antibody positivity. And also, if we are, once you start treatment, you have to continue treatment all throughout pregnancy and also the treat to the level that the TSH comes below 2.5. How to monitor TSH during pregnancy? We should be monitoring it every 4 to 6 weeks till mid-gestation and maybe at 30 weeks, or sometimes I usually monitor before delivery also, because sometimes the gynecologist, especially if it's a surgery, they would want to know that the TSH is controlled, and also they would require a fitness from our part. So usually at 30 weeks and also just before the planned delivery or a planned cesarean, by 36 weeks, I also repeat it once for that purpose. So with all these risks that have been analyzed and proven, the question comes as to, should we screen all pregnant ladies for TSH, or once they plan pregnancy or once they are diagnosed to have pregnancy? The American Thyroid Association is actually conservative in this aspect, where they say that there is insufficient data for universal screening, but you should just screen those high-risk individuals. But here I feel we should go by the Indian Thyroid Society guideline, which was the guideline which was put forward by a group of eminent endocrinologists, which is led by none other than our own R.V. Jaykumar sir, and which says that all pregnant ladies should be screened either in the first antenatal visit or as soon as she gets a diagnosis of pregnancy by TSH. All pregnant ladies, not just the high risk, but everybody should be screened. That is the Indian guideline. I think that should be the common sense thing also. Why is it a common sense thing? That would come in the next slide. That is the high risk screening for pregnancy as American Thyroid Association recommends. See, when American Thyroid Association says that there is no need for universal screening, they still say that, yes, you need to screen those high-risk individuals. And who is high-risk? Anybody who is having a positive history or having symptoms suggestive of hypothyroidism, anybody who is having anti-TPO positive or having a goiter, having a history of head and neck irradiation, anybody who is more than 30 years, that's very important. That actually leads to a lot of patients who request into high risk. Anybody who has any sort of autoimmune disease, any history of previous pregnancy loss, previous preterm delivery, previous history of infertility, any lady who is having multiple pregnancies prior. So anybody who has already delivered more than two or more children, anybody who has a family history of thyroid dysfunction, anybody who is overweight with a BMI more than 40, anybody who has an history of administration to a high iodized contrast agent, or anybody who is residing in a iodine insufficiency. It's a very long, difficult list. But one thing I can tell you is that actually when you screen your patients by this criteria, again, almost around 80% of your pregnant ladies would be falling into one of these criteria as high risk. So finally, even if you start screening by the high risk, finally you will end up screening 80% of population. That's why our Jayakumar sir has intelligently pointed out, that group has intelligently pointed out that rather than wasting your time with high risk screening, just do screening for everybody, because we have a higher incidence of hypothyroidism in our population. Why to risk? It's a very eminently and easily treatable disease, so we can avoid it. And how to monitor a euthyroid anti-TPO woman? That is another controversial question. It is said that a lady who just has a normal TSH, but she is antibody positive, the risk of progressing to the hypothyroid phase is higher during pregnancy. Why? Because her requirement increases during pregnancy because of her fetus, and her thyroid may not be able to cope up with the increased requirement, and her TSH may again rise gradually during the pregnancy to more than 4. So even if the lady in the initial screening has a value less than 2.5, you should make sure that she has a follow-up evaluation which is done once in 6 weeks or once in 2 months throughout the pregnancy, because if she is known antibody positivity, there's a high chance that she may go up, have an increased TSH to more as the pregnancy progresses. And how should the levothyroxine dose be adjusted postpartum? We should just go back to the pre-pregnant dose. That's very easy, simple. A hypothyroid lady becoming pregnant usually would require a higher dose, and once she delivers, she would go back to the previous whatever dose she was taking. It's very easy. But the only question is, if she has been diagnosed during pregnancy or after the onset of pregnancy, we have a doubt. Was she hypothyroid before pregnancy itself, or is she just having a transient hypothyroidism during pregnancy because of the increased requirement? There the recommendation is again clear. If the patient had a TSH below 2.5 with a dose which was equal or less than 50 microgram per day during pregnancy, then you can try stopping it with delivery. But otherwise, if the requirement is more than 50 microgram during pregnancy, then you should not stop it, but reduce by 25 to 50% and continue postpartum. That's a recommendation. And also beware that most of the hypothyroid ladies are having hypothyroidism because of Hashimoto's thyroiditis. And most ladies who are having Hashimoto's thyroiditis, the risk of progression of the disease or increase in dose requirement in the postpartum period is high, because they are at higher risk of postpartum thyroiditis, and they may actually go. Initially, you may have to reduce it to prepartum dose, but because of the postpartum thyroiditis, in the next 3 to 6 months, their dose may go up further. So that is one thing that you have to be very careful about. So I'll just try to summarize things in the next few slides. So non-hypothyroid treatment, pregnant lady who gets pregnant, you may have to increase the dose by 20 to 30%, but definitely don't reduce the dose. And a patient on thyroxine treatment, don't stop it once you start the treatment during pregnancy. Whatever may be the report that you follow up, even if it is not range, don't stop it till delivery. And if a hypothyroid treatment again can develop a hyperemesis and a TSH transiently below 0.1, don't reduce the dose or stop the treatment suddenly. You may, if the TSH and FT4 is very high, you can reduce the dose. But sometimes I've seen that once you get a TSH in the because of superimposed hyperemesis, the people tend to just stop the treatment. Don't do that, because you may have a rebound high thyroid of very high TSH, which can lead to complications. So to conclude, if the TSH is below 2.5, no treatment is required. If the TSH is above 4, you have to treat definitely to keep the TSH below 2.5. And in the in-between range, you have to treat if the TPO level is positive. So if you need to read further, you can read 2017 guideline by the American Thyroid Association on diagnosis and management of thyroid disease during pregnancy and postpartum. Only problem is that it's a very big guideline with 162 pages, 111 questions, and 97 recommendations. Thank you very much. Thank you very much.
Thank you so much, Joe sir. On an expected note, it was a wonderful talk, and very informative and precise. So I think we would be having questions after each talk. So any questions to Joe sir?
Can I ask one question, Dr. Sunil?
Yes, sir, please.
Very nice talk, Dr. Joel. I enjoyed thoroughly. I have two real life questions. One is most often we see patients with TSH more than 100 and FT4 below T4, and people are willing to continue pregnancy. What to do? This is question number one.
Sure.
Second question from your own. Sometimes TSH is less than 2.5 with TPO positive. What to do in such a scenario?
Yeah, see, actually, to answer the second part first, even if the TSH is even if the TSH is below 2.5, but the antibody is positive, current American Thyroid Association guideline says that you should monitor it, because the chance of progressing, the TSH increasing further during the pregnancy, risk is around 20%. So TSH below 2.5, the antibody positive, you should monitor, but you don't need to treat until the level crosses 2.5. That's the second part. Regarding the first part, there is no recommendation as to end pregnancy by an abortion for any level. There is no recommendation. Even if the TSH is above 100,000, you don't need to. You can just continue the. Here we have to understand that there is increased risk of complication, there is increased risk of fetal loss, but we are not supposed to end it by ourselves, because if it's ending by the natural phenomena, let it go by that scenario, but we shouldn't terminate the pregnancy just for the sake of hypothyroidism. And another thing is about the IQ. Often people are worried about the slightly lower IQ in children that is born, but again we should always understand that success in life is not defined by IQ. There are a lot of other things which define success. So a lower IQ doesn't qualify him. He may end up having a much better success than whatever you and I are enjoying. Thank you, sir.
Thank you so
much. One more,
very nice.
And so one more factor that is pointed out is that the average IQ has shot up like anything. So even if it is uncontrolled, the IQ would go down by 8-9 points, and that actually doesn't matter on the ground.
Yes,
exactly. Because see, if the child may be if the child was euthyroid, if the mother was euthyroid, the child may be ending up with 120 IQ. Even if it comes down to 110, still it's normal. It's above normal. Yeah.
Very good. Thank you.
Thank you.
Oh, I think Dr. Suresh sir would start.
Suresh is waiting eagerly.
He needs to unmute himself.
Can you hear me?
Yes, sir.
Yeah. So I think, thank you very much for the wonderful opportunity. Can you see my screen finally?
Yes.
Yeah. Well, I think thank you very much for the wonderful opportunity. It's almost going to be the end of the evening, but it's very important topic, as Joe was mentioning in a diabetes conference. We're talking about thyroid levels, but I think it's very important practical one that we see in day in and day out. I have to thank Dr. Sabir for the wonderful opportunity, and thanks for all the chairperson. So to make it more interesting, it is a vast topic as its own with the TSH level. But to make it more interesting, I'll just go with some cases, and also on the way, just go through with some aspects of the knowledge that we need to know. So with that, oops. Okay. So this is my agenda. I'll just go through cases with each of the conditions. So thyroid anatomy, you know where it's located, and it's being controlled by hypothalamus, pituitary, and then it goes to the peripheral tissues to act on. And you know the follicular cells that is secretes the thyroid hormone, C cells to calcitonin. So with that, I think you need to know there is a cellular level action in the thyroid gland, and that from the colloid we got a T3 and T4 secreted, and it's normally protein bound, and it's the protein bound with albumin and globulin, and it's 99.98% is protein bound. So the thyroid hormone action is a very complex thing, but what you need to know as a practical thing to see the patients is primary and secondary disease is there primary hypothyroidism with elevated TSH and suppressed T4 and T3. On the other hand, it's other way around with the suppressed TSH and elevated T4 and T3 with the primary hyperthyroidism. So just go with the secondary one. You got suppressed TSH and low level of T4 and T3, and then both the levels goes up in secondary hyperthyroidism. So no confusion here. This is the basic thing that you need to know. So once that is there, the elevated TSH, which is hypothyroidism, we know it's a common disorder, and women is more common. It goes with the age. And in many major cities in India, it has been prevalence is being done, and it's published in IJEM. You can see the prevalence is almost 11%, and mostly is Hashimoto's disease, and iatrogenic and other causes are there. TB is one of the causes in India, and the viral what we are getting with COVID is also causing havoc in thyroid disease. So symptoms wise, it's quite a lot of things that I don't want to go into the details of. Unique features in children is short stature, delay in eruption of teeth, and precocious puberty and delay in puberty. So Hashimoto's disease is the very common thing. Antibodies are normally positive, but not necessarily always. So iodine deficiency is another one with endemic goiter, with 282 districts has been surveyed, and you got because of the iodine deficiency, there is subnormal intelligence and quite a lot of other symptoms that is present with the iodine deficiency, and there is a national iodine deficiency program is there. So again, just to summarize about the secondary hypothyroidism, the suppressed TSH and suppressed T4 and T3, it's very, very less common. The first case, we got a 10-year-old girl with a 126 centimeter and not gaining much of height, poor eating and not so active, and past medical history is nothing significant. But you got the parental height is okay-ish. You got the cardiovascular system is stable, respiratory system is stable, and the bone age is only 8 years of age. And you got a TSH of 36.1 and T4 of 0.6 with thyroid antibody strongly positive. No doubt in this young girl, we got a primary hypothyroidism with the diagnosis. Commenced on thyroid hormone replacement. You can see the height after the 4 months is 132. So it works like a magic. What you say is a poor man's growth hormone. So you really need to diagnose hypothyroidism for a young child to make sure that it's not a hypothyroidism that is causing the stunted growth. So that is the point made in that case, and also kids with the cretins are presented with various different things. So a second case scenario is a 67-year-old male with recurrent vomiting, 2 months history of nausea and recurrent vomiting, dizziness and decreased appetite. There's a weight loss as well, and cataract is done 2 weeks ago. That means he's metabolically fit to go ahead with the surgery. And it's a teetotaler. So the cardiovascular system is quite stable. Lying standing BP is okay-ish. The sodium is 120. So the sodium is 120. It's right to check the lying and standing BP. And we got LFTs are normal. What else to check for hyponatremia? What are the other investigations? So patient has got 2 admissions with a normal saline, but some improvement. And we have done GI endoscopy and ultrasound to look for any other significant lesions, but it's not normal. So the osmolarity is down, serum osmolarity is down, and urine osmolarity is up, and you got a serum sodium of 120, again with a glucose of 104. Any diagnosis you can think of, just going through your mind. The further investigations are done, and here we go with the short synactin test. It's adequate, but the free T4 and free T3 levels are extremely less compared to the TSH compared to that is relatively normal. So that gives you a diagnosis with the gonadotrophins also on the lower side, gives you a diagnosis of secondary hypothyroidism. So here, because of the eye thing, bitemporal visual fields defect is confirmed, and you can see that in the chart. And this is the MRI of pituitary. You can see a mass there, hydrocortisone treatment and thyroxine on the most of the symptoms. What she had settled completely with a repeat sodium of 140. TSH, which is the transsphenoidal hypophysiectomy, is done for the pituitary tumor. So the learning point with this is the secondary hypothyroidism is not uncommon. We should just open your eyes and just look for it. So the third case scenario is again a 59-year-old female found unresponsive in bed, 6 months history of profound tiredness and lethargy, and you got a constipation. Temperature is 95 but no goiter. You got a pulse rate very low with 48 to 52, and lying and standing BP is not, there is no huge difference of 30. So hypothyroidism is thought about, and with that, and the TSH was 1.4. So diagnosis of hypothyroidism is not that much possible. However, the free T4 and free T3 levels are low. And again, just to show the gonadotrophins, prolactin, the whole lot is down, indicating the pituitary is affected, and even the IGF-1 levels, which indicate the growth hormone status, and that is also in the lower end of normal. Well, it's not lower end of normal, lower, completely low. So here the possibilities are definitely it's a central hypothyroidism. It could be a hypopituitarism, and a pituitary adenoma or a pituitary infarction or apoplexy could be all be possible in this case. So again, so I showed you 3 cases. One is a primary hypothyroidism, and second one is pituitary mass causing a secondary hypothyroidism, and the third one is possible pituitary infarction or apoplexy. So coming to hyperthyroidism, which is the TSH is suppressed and free T4 and free T3 levels are high. It is worldwide. The Indian prevalence is almost 1.2 to 1.6. Normally it's Graves' disease, but other conditions are there, including toxic multinodular goiter. So how the Graves' disease is antibody mediated, and usually young group, women is more common. You can have ophthalmopathy. So this is the presentation of ophthalmopathy. That's Graves' ophthalmopathy with a pretibial myxedema. So you do a technetium uptake scan. You can see an uptake which indicates Graves' disease. What are the medical management? Normally it is cobimazole or PTU, but normally PTU is given in the early parts of pregnancy. Then the radio iron ablation is the other treatment, which may take a few weeks to work, but it can work beautifully. But the patient can become hypothyroid. That's what you need to do as a counseling when you counsel the patient. So surgery in a terribly refractory cases, I normally stick to medical and radioactive treatment, but not surgery in a big way. So toxic multinodular goiter, as I mentioned, is another possibility. There's a cause for hyperthyroidism. You do a technetium uptake scan to diagnose, and a single toxic nodular goiter is also a possibility. So just to bring up the case scenario for this, 56-year-old female with breathless and palpitation and breathlessness, increased palpitation and agitation. You got the temperature of 103, so it's in hypercatabolic state sort of picture. Pulse rate is 140, JVP is up. So we got bibasal crepitation. So somebody is in a severe palpitation with tachycardia and bibasal creps. So fast AF with CCF is the diagnosis. Chest sepsis or a thyrotoxic, because we got a thyroid talk, but the diagnosis should be made on the basis of the other blood investigations as well. So there is no evidence of infection. Here the ECG shows tachycardia and clearly AF with the fast AF, and TSH is fully suppressed with the toxic levels of free T3 and free T4, indicating a rare diagnosis of thyrotoxic crisis. But it can be potentially fatal condition. The normal precipitating factor could be a diabetes ketoacidosis as an initial presentation, or intercurrent illness, or surgery, or childbirth, the symptoms can be really bad with a complete sympathetic overactivity. So the normal treatment thing is anti-thyroid drugs and iodide, and normally steroids also being used in this condition with IV fluids as a lot. Beta blockade plays an important role. The short-acting beta blockers, esmolol, can be used. And as I said, the steroids is also one of the main treatment. But we have to treat this condition in ICU or HDU setup so that we can do all the other treatments as well. So coming to the next case scenario, so in hyperthyroidism, I've shown you hyperthyroid crisis. Here, we got a 49-year-old male with palpitation, sleep disturbance, and tremors, excessive sweating. So all the typical features of hyperthyroidism is present. But the past medical history showed dilated cardiomyopathy because there is an alcohol thing, but episodes of sustained VT, non-sustained VT is also present in the past medical history. For that reason, beta blocker is there, ACE inhibitor is there, and spironolactone, aspirin, and statin is all there. He got a strong history with the mother diagnosed of thyrotoxicose in 1955, and also hypothyroidism, and elder sister with hyperthyroidism. So strong family history of thyroid disease. So we got on clinical examination a small goiter with toxic clinical features in cardiovascular point of view, but there is no edema. So here we got a thyrotoxicosis, but we don't know the cause for it. We got a clearly toxic guy with no cause for it. So TSH is 2.9. So what did I mention in the previous slides? And you know the TSH normally suppressed with free T4 and free T3 elevated. On the other hand, we got a TSH being normal here with free T4 and being the higher side. So what is the differential diagnosis in this case? It could be a TSH assay interference, which we need to do an assay in a different lab setup, and resistance to thyroid hormone, which is a different topic altogether, and a TSH secreting pituitary adenoma is also a possibility. So here it is happen to be TSH-HOMA, which is a TSH secreting tumor from the pituitary, and the treatment is mostly surgery. So thyroid disease and pregnancy, Joe has touched upon. I'm going to skip that. So far, I've shown you hyper and hypothyroidism with a multiple case scenario of secondary hyper and a secondary hypothyroidism as well. Just very quickly about a thyroid nodule. 8 years history of left thyroid nodule, gradual increase in size. 2 FNACs is being done, but no history of thyroid cancer. But clinically perfectly well person with normal thyroid function test. So we got only 2.6 centimeter nodule there, but there's no calcification. So why I want you to show in an abnormal or how to interpret TSH is we got a goiter there and we got a normal TSH. So what you do in this situation, you do an ultrasound, but there is no calcification. So FNAC is benign. However, I think because of the size, patient went to total thyroidectomy and it showed a papillary carcinoma of thyroid. So just to show the whole lot of scenarios, I'm just showing you very quickly 2 case scenarios, which is very rare. You got a 61-year-old man went to nephrectomy for renal cell CA, but the post-operative thing was very complicated with acquired pneumonia. He was on enoxaparin and oxycodone, but the TFTs were obtained with some agitation because the TSH was shown 4.1 with a total T3 which been elevated free T4 levels were there. So we got a patient who's got agitation with a no prior history of thyroid disease with an abnormal thyroid function test, which confused the whole lot with free T4 being higher level. But here there is non-thyroid. It is not consistent with non-thyroid illness, but a patient has got normal TSH with elevated free T4 level. So the answer for this is the patient is being given intravenously or subcutaneously administered heparin, which can falsely elevate the free T4 level. So this is a practical point that I want you to know when you interpret the TSH. The last case scenario we got is a 45-year-old female presented with fatigue and weight gain. Several relatives have been diagnosed with Graves' disease and hypothyroidism. Multiple people in the family have been affected with thyroid disease. And here the TSH values is 15 and patient was started on thyroxine of 125 micrograms. but the patient levels are still about 14. So the thyroid hormone levels were increased to 200 micrograms. So what happened after that is the TSH remains 16, but we do an absorption test to make sure patient compliance is good and the absorption is good. But she passed all the tests and she had a pulse rate of 92. So that tells you that 200 dose is slightly in the toxic level to cause the patient to have symptoms. Patient has got TPO antibodies negative, which may or may not be significant in this case. But prolactin and pituitary MRI to look for what I've been telling you with a fifth case scenario of TSHoma. Here, everything was normal, but a month later, FT4 was normalized and TSH remained high. So again, the TSH consistently remained to be high. What happened is you are, whether you are dealing with TSH which is being falsely high, could it be a TSH be high due to subclinical hypothyroidism? What could be the potential cause of high TSH and a normal or high free T4? So this patient has got initially high free T4, but I think after that the free T4 level is normal with the replacement, and your replacing is almost up to 200 with the tachycardia has been there. So the point is the patient had a high TSH and a strong family history of thyroid disease, but with very, very non-specific symptoms consistent with hypothyroidism. This is a very important point that I want you to just interpret. When the patient is sitting in front of you, we got a TSH elevated, you really need to find out whether they got any symptoms. With the high level of TSH treating the thyroxine, patient is going into a really toxic state. But however, in spite of being using the high dose of treatment, patient remained and the symptoms remain the same. So the absorption is okay, the compliance is okay, but there is no evidence of TSH secreting tumor or any history suggesting of thyroid hormone resistance, which I mentioned earlier. So here we are dealing with a case where when you do increase the dose of thyroxine, not only her TSH did not improve, but she developed real anxiety and FT4 became very high, suggesting that we were doing a wrong treatment. Here, the case is due to high TSH was an interference with the TSH assay due to presence of heterophil antibody. And this is the point I want you to make. So, I touched based upon a few cases with elevated TSH, which is a hypothyroidism, and elevated TSH with a low free T4 and free T3 level, indicating a primary hypothyroidism. And the second case was about a pituitary tumor, which is an elevated normal TSH with the suppressed free T4 and free T3 levels, with other suppressed pituitary hormone indicating a pituitary tumor in the MRI, and also the visual field shows the bitemporal hemianopia. So the third case is pituitary apoplexy, again knocking down all the pituitary hormone. And coming to the hyperthyroidism, which is suppressed TSH and elevated free T4 and free T3 levels. I've shown you the primary hyperthyroidism. The Graves is the commonest cause. I've also shown you the worst scenario case, which is thyrotoxic crisis, which normally managed by antithyroid drugs and IV fluids in HDU setting, along with steroids, and watching the temperature and watching the cardiac monitor. And then I've also shown you a case of elevated TSH and elevated free T4 and free T3 level, indicating a TSHoma. And we also touch base upon a heparin-induced case of falsely elevated free T4 level drug-induced. And we also went through a case of nodular goiter with a normal TSH and how to deal with it. So, and also the last one, we dealt with the case of heterophil antibody. So that is my summary. So here we really need to, the take-home message is appropriate screening for thyroid dysfunction in selected groups can lead to early diagnosis once you got early diagnosis, you can do an appropriate treatment. So if in doubt, you can always refer to endocrinologist. But I think normally it is being dealt with a GP or a physician level in a big way. So what you do is you do the right treatment for the patient, not like the last case scenario. You give more and more dosage and then get to a toxic level, and the patient gets into a deep trouble clinically and also symptomatically. And thyroid typical, which is atypical, it means that you really need to open your eyes and work further rather than labeling as a complex thyroid or a hypothyroid blindly or a hyperthyroid blindly. So the last one I mentioned about the palpable thyroid nodules and nodules. Anything more than 1 centimeter really needs evaluation to look for a underlying malignancy. With that, I stop there, and hopefully it is useful for your practical approach how to do with the TSH. Thank you.
Thank you, Dr. So I will be asking one question. Is it audible?
It's audible, but very feeble. Sunil, can you hear it?
Yes, actually,
Yeah, the sound is very weak.
Some interruptions, I think.
Any questions for Suresh, sir?
Yeah, I will be asking one question to Dr. In an asymptomatic,
yes, sir.
In an asymptomatic patient, at what level of a TSH that you suggest a treatment or consider subclinical and suggest a treatment?
So when the patient is completely asymptomatic, you really need to go for a family history. You really need to get family history. There's a strong family history. If it is growing age, children and everything, small family, the antibodies are strongly positive and child is not growing. Anywhere from levels of 7, but the TSH more than 9 to 10 is the level that you really need to treat.
So we did subclinical. I think the pregnancy, Dr. Joas told that we go for a little lower level, probably the prevalence of hypothyroidism will be more, and in the general population.
But the challenge is with the general population now, the obesity prevalence is going up. With the obesity prevalence is going up, the change in the fat content, and therefore there is a change, big change in the leptin level, and the leptin is affecting the secretion in pituitary level of TSH. So these people who are slightly obese will have a slightly elevated TSH, which doesn't mean they got any primary thyroid disease. It means that the leptin is altering the thyroid stimulating hormone, and the thyroid stimulating hormones are falsely in the higher side. So we really need to take a careful history of patient history along with the antibody level, along with the symptoms. You go with all the 3 scenarios and look at the patient and then treat accordingly. Not blindly go with the slightly high TSH and go for a treatment.
Okay, due to one of time, I think we will move to the next and the last session.
Thank you very much, sir. Thank you.
Okay.
Sorry.
We'll be moving to the last session of the day. And our speaker is Dr. Rishi Shukla. Is he ready?
Yes, sir. I'm ready. Am I visible on the screen?
Yes, sir. You are visible actually.
Yeah, it is visible, and it's a pleasure to introduce Dr. Rishi Shukla. And he's head of the Department of Endocrinology at the Regents Health Kanpur and the Chief Consultant Center to Diabetes and Endocrine Disease in India. And he has got several publications. He was the invited faculty in European Association for Study of Diabetes, that is EASD. And he has an International Society for Pediatric and Adolescent Diabetes, that is ISPID, and to various national organizations. And again, he has contributed a large number of volumes in several textbooks, especially textbook of endocrinology by Endocrine Society of India, Then another book by our eminent late Professor Sadiko, textbook of changing diabetes in children, that is CDIC. And he was also published a monograph by the RSSD on insulin. And he was the recipient of the recognition award by the Economic Times in 2018. And is running regular patient education program for the last 25 years. And for the Society for Prevention and Awareness of Diabetes, that is SPAD, in city of Kanpur. Now today he will be deliberating on a very important topic, that is diabetes with the thyroid dysfunction. And diabetes itself is a very complex issue. And when it is again added by another very complex disease, the issue become more dangerous, and the outcome may be very, very difficult for a patient who has got the dual complexity of diabetes and thyroid dysfunction. I think we have got this an eminent speaker, and going to and over to sir.
Thank you, Dr. Bala, for good words. And thank you, Dr. Sunil, for chairing this session. And before I start, a big thanks to Dr. Sabir and Mr. Vinod from MacLeod for this opportunity. And it was truly a wonderful meeting. And I enjoyed these two sessions, and it was totally full with knowledge. And I wanted to interact it more, but somehow because of time lag, I avoided. And you gave me very nice introduction, Dr. Bala, but my original introduction is one-liner, and that is I am a storyteller. But today, because I'm going to having a cross-talk between thyroid and diabetes, and I realize this is truly important and much more important in day-to-day practice. So I'll be not telling you stories, I'll be telling you more science. So let us see.
It's clear, slide is clear.
Yeah, something is coming here in between. Can you see?
No, we can see.
What are the possible causes of losing weight of a type 2 diabetes in real life? Obviously, uncontrolled diabetes, patients of metformin. Sometimes patient-induced anorexia. SGLT2 inhibitors, we have it. Gastroparesis is another reason. And one very important reason that I realized, phobia that my blood sugar will increase if I eat adequately. So this is very subtle reason, but important. Associated sepsis, tubercular infection, but thyrotoxicosis and thyroiditis are again one of the important. Many times, and most of the time, they are asymptomatic. And when we investigate, we find the reason. Type 2 diabetes and hypothyroidism. Its prevalence in different studies is 6 to 20%, and it is much higher than general population. And hyperthyroidism is higher in females than males, we already know. Advanced age and presence of goiter are independent risk factor. And what is more important, it is more commonly associated with multinodal goiter than Graves' disease. We do see a lot of Graves' disease, but MNG is more common. Hyperthyroidism and metabolic effect on glucose metabolism. Increased food intake, increased glucose absorption, post-meal hyperglycemia is a more common. Increased glucose absorption in muscle and fatty tissue, increased insulin clearance, deranged control, and increased chances of ketoacidosis. So, and then effects on lipid. Increased free fatty acids, increased lactate production, decrease serum cholesterol and triglycerides, and decrease body weight. So because of by virtue of increased lactate production and increased free fatty acids, chances of insulin resistance increases. Coming to hypothyroidism, sorry, that was the prevalence I was talking about. Hyperthyroidism. Hyperthyroidism is much more common than general population, but type 2 DM and hypothyroidism, the prevalence is 6 to 20%. Hyperthyroidism is much, much less, but it is much more than general population. Same is prevalence is more than general population for hypothyroidism, and it was told by the previous speaker that it is the prevalence of hypothyroidism around 10.5% in India. Diabetes is also having more or less 8 to 10%, and both are common disorders. So we say, is it a coincidence or there is any real association? So it is much more than coincidence, and that's why we need to look into it. Significant increased risk is associated with increase if the age is more than 65 years, female gender, obesity, and presence of thyroid antibodies. It is more than a coincidence, and TSH is positively associated with increased insulin resistance and hyperglycemia in euthyroid patients. So this is very important. Even in euthyroid range, if TSH is gradually going up, then insulin resistance goes up. TSH may have direct effect to increase leptin secretion from fat cells, and type 2 diabetes has a higher leptin levels, which has effect on thyroid receptor hormone. The thyroid TSH increases expression of glucose and 6-phosphate and phosphoenol phosphocarboxylase amino. So nutshell is that by virtue of increased expression of glucose 6-phosphate, there is increase in sugar level in the body. What is the correlation? If you look at TSH in euthyroid patient, it is associated with the increased prevalence of diabetes. Type 2 diabetes is significantly increased with each microunit ml rise in TSH, even in euthyroid. And so this is very interesting. I mean, normally we consider 4.5 as a normal, and from 2 to 4.5, with every increment of 1, there is increase in the prevalence of type 2 diabetes. There is a close correlation. I mentioned about leptin, I mentioned about TRH. In prospective trials, progressive increase in TSH and fall in T4 is associated independently with high risk of diabetes. Progressing from pre-diabetes to diabetes is strongly associated with high TSH and lower FT4 levels. I mean, this is not a pathological high, this is physiological high. Upper limit of high and lower limit of normal TSH is important. Then another thing, statins, thyroid and diabetes. This is again a very interesting thing, because in diabetes practice, all of us use a statin. Hypothyroid patients and statins are independently considered as a risk to develop diabetes. We can discuss later, but if you look at this combination, hypothyroid patients on statin are more prone to develop diabetes. Statins and hypothyroid both affect mitochondrial dysfunction, the common effect to induce diabetes. So something happens at the level of mitochondria and it leads to diabetes. Type 2 DM and hypothyroid relationship, there is increased risk of converting subclinical hypothyroidism to overt hypothyroidism, which may deteriorate control of blood sugar. So this is again important. And a progression of 5% per year was reported from subclinical to overt hypothyroidism among people with type 2 diabetes. So hypothyroidism, any type of hypothyroidism, subclinical or subclinical more than 10, the chances of converted or progression of thyroid dysfunction is higher in presence of type 2 diabetes. And the duration of diabetes is a risk factor, but it is for type 1, not for type 2. Hypothyroidism, what are the metabolic effect on glucose metabolism? It decreases glucose absorption. It decreases hepatic glucose uptake. It decreases gluconeogenesis, decreases insulin clearance, and so chances of hypoglycemia increases. What are the metabolic effects on lipid? All of us know it increases cholesterol, triglycerides, and LDL. Weight gain is there. And what is most important thing is that by virtue of increase in triglycerides and LDL, the free fatty acids are little more and insulin resistance is reported. But serum insulin levels are higher with lower clearance. So this is again in both hyper and hypothyroidism, insulin resistance is reported. Sometimes in hypothyroidism, we see higher fasting values. Coming to type 1 diabetes and thyroid, both are autoimmune disorders, so share common connect. Autoimmune thyroid disease occurs in 17 to 30% of type 1 patients. and the risk of hypothyroidism in type 1 patients is around 25%. Both hyper and hypothyroidism are more commonly associated, and poor diabetes control predisposes to autoimmune thyroid disease. I have already mentioned earlier. This is a interesting chart by a very young enterprising endocrinologist Sujoy. And if you look here, the diabetes mellitus and thyroid disease mutual influence on each other. Here, diabetes in euthyroid individual. If the sugars are there, it has some suppressive effect at the level of TSH. Now, diabetes in hyperthyroidism, what happens? There is a poor glycemic control. There is increased incidence of dysthyroid optic neuropathy. So, if a diabetic patient develops hyperthyroidism, the optic neuropathy chances are increased. We'll discuss a little later about orbitopathy also. Hyperthyroidism in euglycemic individuals. What happens? The glucose intolerance is seen approximately 50% patient, and sometimes we see frank diabetes also. Hyperthyroidism in diabetes, there's a deterioration, all of us know, and when we treat thyroid, there's improvement. Hypothyroidism in diabetes, predisposition to recurrent hypoglycemia, but sometimes we see a higher fasting blood sugar. And in type 1 diabetes, the chances of involvement of hypothyroidism or any thyroid disorders is there. This is very interesting picture, and there is an association between normal thyroid hormone and diabetic retinopathy in patients with type 1 diabetes. Here what happens? This is a no retinopathy, mild to moderate retinopathy, severe and proliferative diabetic retinopathy. And look, as the FT3 number is going down, and this is what is happening, the increased prevalence of, increased chances of complication or severity of diabetic retinopathy. But this is just a paper. I just wanted to show this for discussion's sake. We have yet not reached any conclusion as yet. Thyroid cancer and diabetes mellitus. Thyroid cancer is a risk in 20% diabetes patients, and it is independent of geographic region, study design, and quality analysis. And risk is increased among diabetic women, but not in men. Now, what to do? The algorithm. If you do TSH and TPO antibodies to all patients, if the patient is euthyroid, type 1 diabetes, you need to do annual analysis. Type 2 diabetes, if it is less than 3 and TPO negative, we need not follow very frequently. And if it is more than 2 TSS, TPO positive, annual follow-up. If there is overt hypothyroidism, treat. And if in subclinical range, you also treat. Subclinical more than 10, I mean standard recommendation, and in between, you try to follow as you are doing here. Management. Hyperthyroidism with diabetes. The standard management like antithyroid drugs and radioactive iodine and surgery, I mean, these are the things. But what is most important thing is in subclinical thyrotoxic process, if PSH is 0.1 to 0.4, and some studies say 0.3 also, they should be considered for treatment of, if there is history of coronary artery disease, stroke or atrial fibrillation in diabetic population, they should be treated, or maybe prior to treatment they need further workup. Management for hypothyroidism with diabetes, standard treatment with thyroxine, that is fair enough. And this treatment improves lipid profile and reduces insulin resistance. This is what I wanted to highlight. Anti-diabetic medicines and effect on thyroid dysfunction. First, discuss the most commonly and the first line medicine, metformin. It reduces TSH level in euthyroid patients, subclinical hypothyroidism, and overt hypothyroidism. However, it has no effect on FT3, FT4, and metformin does not affect significantly if there is intact hypothalamic pituitary thyroid axis. One interesting thing is metformin affects LT4 absorption, the thyroid absorption, if they are given together. So that is again important, and it reduces biliary thyroid carcinoma growth and possibility of other thyroid cancers. Coming to other agents, sulfonylurea, the modern sulfonylurea, glimepiride, gliclazide commonly used, does not have any PPAR gamma, that is pioglitazone and maybe saroglitazar, stimulates TSL receptor expression. And PPAR gamma leads to increased fibroblast and adipose tissue stimulation in orbit. So it should not be given in Graves' orbitopathy. So this is another important thing. GLP-1 analog, glucagon-like peptide. In animal models, there is increased history of medullary thyroid carcinoma. However, no such effect is seen in human trials. Insulin as such does not have any significant role in terms of thyroid function. So finally, what to do with anti-diabetics and what are the recommendations? TSH should be monitored after starting metformin treatment in subclinical hypothyroidism. Maybe a lesser doses are required. Pioglitazone should not be given in Graves' orbitopathy. This is again a very important. If a person is Graves' thyrotoxicosis, somehow patient is on pioglitazone, please stop it. Glucagon-like peptide should not be given with personal or family history of medullary thyroid carcinoma. Sometimes the doses may be increased with hypothyroid patients. In cases of ketoacidosis, thyroid function should be considered even with little suspicion. And use of statin should be considered after making patient euthyroid from hypothyroid. And this is the last slide, and 3-4 days I took it. Here the rains are not as aggressive as in Kerala. These are the beautiful clouds, and I saw this cut tree, and immediately I thought of Corona and how it has affected. But immediately I saw this small bunch coming out, indicating that life never stops. With this, thanks a lot for your kind attention. I'm ready for any questions. Thank you so much.
Thank you for an excellent presentation and for an important topic that the combination of both thyroid dysfunction as well as diabetes mellitus. I think there is so much questions available in the chat box. So it's easy to treat in a patient with diabetes, either hypothyroidism or hypothyroidism. Which is your worry a little more?
Which is more common, actually, voice is not clear.
No,
Actually, hypothyroidism is much more
hypo or hypothyroidism?
Hypothyroidism is much common. I mean, it is seen in 6 to 20%. So,
sorry, but this which produces more complication, hypothyroidism or hyperthyroidism, or which is easy to control and we are comfortable with?
Both depending on severity and distance, but if you look at hypothyroidism, especially in a subclinical thyrotoxicosis, we have to pick up the patients with the history of coronary artery disease, history of atrial fibrillation. So there we should really be
What can
careful.
lead to more cardiac complications? What can lead to more cardiac complications, hyper and hypothyroidism?
Yes, thyrotoxicosis is more commonly associated with cardiac complications. Actually, your voice is not very clear.
Okay, right.
So actually, I am also not able to get what is actually.
Voice is not very clear. I'm
audio
answering on the basis of words, not sentence. I'm answering on the basis of words, not sentences.
Yeah.
Audio is not clear, I think. Not clear. You're not hearing properly.
Yes.
Okay, any questions? We didn't hear much questions in the chat box. So I think we can conclude the session if no more questions.
Okay. Thank you so much. Thank you.
I don't know. So to conclude today's session, I would like to welcome Dr. Sunil Prashaw, Chairman. Sunil Prashaw.
Okay, I think we had some fantastic scientific sessions today by some great speakers, and most of the topics were excellent and were up to the mark. Tomorrow also we have some much awaited topics and by some much awaited speakers. So tomorrow we will start exactly at 9 o'clock. Hope we had a fantastic CME this time around. So that's it for today. Thank you very much. We'll meet tomorrow.
Okay.
Good night, everyone.
Good night, Dr. Shabir.
Naleshwar sir.
Okay, Prasad. Happy to see you. Okay.
Yes.